Good morning. On behalf of Jacksonpal Pharmaceuticals Limited, makers of Doxypal DRL doxycycline 100 mg capsules, the drug approved by government for treating COVID-19 patient in the fight against coronavirus, Lycorette soft gels to boost the immunity. Also, Lycorette preg sachet of L-arginine, lycopene, and DHA to prevent pregnancy complications, and Endorec 2 mg tablets of Dynogest. I am Dr. Vipin Tyagi, along with my teammates, Dr. Deepika Chabra and Mr. Amit Saxena. A warm welcome to the scientific session of the North Zone Ethics and Committee Conference this Sunday morning. Yesterday was a power-packed and most informative public forum on building bridges in Corona times. We thank the office bearers of Rewari Obs Gyn Society for associating with Ethics and Medicolegal Committee of FOGSI to organize this two-day NZ EMLC conference. We are indebted to ICOG for providing 5 ICOG credit points to all attendees of the scientific. Welcome to all the esteemed faculty for the conference. We welcome the attendees in large numbers. Please keep posting your queries by text in the Q&A box. Please note this webinar is streaming on Facebook Live and the recording will remain on Jacksonpal's YouTube channel for reference and promotion. I will now request the MOC, Dr. Priyankur Roy, for welcome and inauguration.
Thank you so much, Team Jacksonpal, for the welcome. Good morning, everyone. I would like to welcome all of you to this wonderful eConnect North Zone Ethics and Medical Legal Conference held today morning. As Vipin has correctly said, yesterday we had a power pack session, almost attended by 800 plus delegates in the public forum. So thank you so much, delegates, for attending this session. This session is organized by the Ethics and Medical Legal Committee FOGSI in association with the Rewari Obs Gyn Society. So first of all, to welcome the dignitaries for this session, I would like to welcome Dr. Surekha Yadav, who is the organizing joint secretary of this session. She is also the president of the Rewari Society and her special interest, of course, lies in gynec surgery. So welcome, ma'am. Next, I would like to welcome Dr. Renu Yadav, who is the organizing joint secretary again of this conference. She is a past president and patron of Rewari Society and a very senior member of the Rewari Society. She has been a professor at the she has passed out from the GSVM Medical College, Stanford, and has done her MS from there as well. So welcome, ma'am, to this platform. Next, we have the organizing secretary of this wonderful conference, Dr. Mitra Saxena, ma'am. She is the past president of the Rewari Obs Gyn Society. She is also the Northern coordinator of the Medical Legal Committee and is the chairperson elect of the Practical Obstetrics Committee, under whom leadership we are sure the committee is going to do attain greater heights. So welcome, ma'am, to this platform. Next, we are having Dr. Alka Kuthe, ma'am, who is the organizing chairperson of this wonderful conference. She is the national coordinator of the Medical Legal Committee. She is also the past chair of the AMOX Medical Legal Committee. And she has won the Best Committee and Best Chairperson Award of the Medical Legal Committee. So welcome, ma'am, to this platform. Next, of course, a very important person, Dr. Manish, sir, who is also the organizing chairperson of this conference. We all know him as the chairperson of the Medical Legal Committee, and under his leadership, of course, the committee has done really well, and there are a lot of things, uniform consent, etc., that has come up under his leadership. He has been the past vice president of the prestigious Pune Obs Gyn Society. So welcome, sir. Next, we have Dr. Arti Agarwal, ma'am, the vibrant vice president of FOGSI from the North Zone. She has done wonderfully well and conducted many programs under her leadership, with many community connect programs also that she has done. She has been the past chairperson of the Food, Drug and Medical Surgical Equipment Committee of FOGSI in 2009 to 12. So welcome, ma'am. And next, it gives me immense pleasure to welcome our chief guests for today's morning's program, Dr. Meera Agnihotri, ma'am, who is teacher of teachers, professor and head of the GSVM Medical College, Stanford. She has been an ex-professor and head. She has been the chairperson of the Ethics and Research State Medical College, president of the WWW Foundation, and overall an excellent personality. Has won Padma Shri from the President of India and has been awarded a number of awards and has been an invited faculty for many conferences. It's always a pleasure to see ma'am in the conferences, and especially early morning, she comes with a vibrant smile. So welcome, ma'am, to this platform. And then we have, of course, our always smiling, always encouraging president-elect of FOGSI, Dr. Hrishikesh, sir, who is a medical director of Bloom IVF Group, probably the biggest IVF group in India and also world over. He is also the administrator of FOGSI Manyata initiative, and he has got a number of awards to his credit. He has also been awarded the esteemed fellowship at EUDEM of the RCOG, and also has been the past Secretary General of the FOGSI, past President of ISAR IAG, and also the prestigious Mumbai OBGYN Society. So welcome, sir, to this platform. So now I would request Dr. Surekha Yadav, ma'am, first of all, to welcome all our delegates and kindly say a few words to our delegates and faculties present today.
A very good morning and a very warm welcome to all the dignitaries, all our honored guests, Chief Guest Dr. Meera and Dr. Hrishikesh Pai, all the senior members of the faculty and the attendees. It's a moment of happiness and pride that though virtually, we are here to welcome you. You all are sparing your most valuable commodity, and that is time for us. And together we are going to be very much educated about the most important menace despite our every effort when we are in problem. So I would like to, Priyankur, that first of all, we take the blessings of Goddess Saraswati and carry on.
या कुन्देनु तुषारहार धवला या शुभ्रवस्त्रां, जो कुंद्र चंद्र या बर्फ की माला के समान सफेद रंग की है, जिसके हाथ वीणा के सुंदर दंड से सुशोभित है, जो सफेद कमल पर बैठी है, ब्रह्म विष्णु महेश आदि देव हमेशा जिनकी स्तुति करते हैं, जो अज्ञान और जड़ता का नाश करने वाली है, वही देवी सरस्वती मेरी रक्षा करे, वही देवी सरस्वती मेरी रक्षा करे.
May the Almighty God bless us all, and may we overcome this COVID times unscratched. So I would next invite Dr. Alka Kuthe, ma'am, the organizing chairperson of this conference, to kindly address us all.
Good morning, everybody. I welcome you all for the first zonal event on medical issues. Dr. Mitra, madam, and her team has strived hard to make this successful. Yesterday we have witnessed the program of public forum. So I welcome you all to enjoy the scientific feast. Thank you very much.
Thank you so very much, ma'am, for welcoming everyone. So next, of course, Dr. Manish Machave, sir, requesting a few words of wisdom from you to the delegates and faculty present today morning, sir.
Good morning, respected Dr. Meera Agnihotri, madam, Dr. Hrishikesh Pai, sir. I can see Dr. Narendra Malhotra joining. Teachers and dear friends, last year we had a lot of things to be done through Ethics Medicolegal Committee, but somehow they were a little difficult to implement. This system of online also very thought that we'll go ahead with our programs. So Ethics Medico-Legal Committee aims at bringing you this year 4 zonal events. So this is our first zonal event, North Zone Ethics Medico-Legal Committee Conference. We will have one with South Zone, one with East, and one with West Zone. And as was discussed at length with Dr. Shanta Kumari Madam and Dr. Pai Sir, that we need to reach out to all the different corners of FOGSI. And this is one attempt to reach out to all the different corners of FOGSI. And when we were discussing this, we have regular meetings of my committee. And when we were discussing this, Dr. Mitra Saxena Madam was gracious enough to accept immediately that she will be doing this North Zone event with Rewari Society. And I have to praise her a lot because she has been a COVID warrior and a COVID survivor. And in spite of all that, in no time, less than 3 weeks, she's come up with a fabulous event. Yesterday, we saw around 900 to 1,000 people attending superb discussions on COVID, the public forum. And we also released a newsletter, the e-newsletter, which I hope all of you will receive in no time, maybe today or maximum by tomorrow. The theme of the newsletter was bridging gaps in COVID times. So it was all about communication skills, vandalism in hospitals, and issues that arise during COVID times of medico-legal nature. So it's very well written, very well edited. Again, thanks to the editorial team, Dr. Mitra, Dr. Surekha Madam, and the entire team. Thanks again to Rewari Society, for hosting this event for us. And if you go through the newsletter, you will not only find articles which are useful medico-legally, but you will also find some jokes and some anecdotes which will tickle your nerve and get that little smile back, which is probably gone for last 1.5 years. And I would fall short if I do not also take name of my vice president in charge, because as I've been saying always, and even yesterday, Dr. Ragini madam is open to all weirdest of ideas, whatever we tell her, and she's very encouraging in whatever we say. So whenever we tell her this is what we have to do or this is what we plan to do, she will always encourage and let us do it. So thank you, Ragini madam, for being there with us. And in these testing times, I think we let us learn, let us enjoy today. As yesterday, we will see a lot of attendance, lot of queries being solved, and we have good stalwarts today to speak. I again thank Dr. Hrishikesh Pai sir, Dr. Meera Agnihotri, Dr. Narendra Malhotra, and all the faculties. I also thank yesterday's all the authors who have written down chapters in the newsletter. We will in the forthcoming time have 3 more events, as I said, with 3 more newsletters. So we will have 4 newsletters. No topic in the newsletter and no topic in the conference will be repeated. So we will have different speakers, different topics. And the National Medico-Legal Conference, which we plan to have it in Pune, where Dr. Sunita Tandulwarkar madam is the president, and she has accepted graciously our request to hold a conference here, which will be in 22nd to 24th of October. We also plan to release one small booklet there, which will have all flowcharts. So it will be situation-based flowcharts, so that you can just have that in front of you and do things which you are supposed to do and not hunt for medical legal even at 2 o'clock you have a problem. So this is the whole plan this year, and probably we'll try and repeat the same plan next year, so that you are not overburdened with, there should not be a pandemic of webinars, but quality webinars, which everybody enjoys. So thank you again, Rewari Society. Thank you, Surekha Yadav ma'am. Thank you, all of you. And special thanks to Mitra ma'am alone. She has not left any stone unturned, and fabulous work done. As a chairperson yesterday, I was satisfied. I could sleep very nicely. So I think today also I'll sleep very nicely as a chairperson. Thank you very much. Thank you.
Thank you, Manish sir. Medical legal problems are always a nightmare for general obstetricians and gynecologists. So thank you for charting out a very nice roadmap for all of us, so that we too can sleep peacefully knowing that you guys are there for us. Thank you so much, sir. So next I would request the VP in charge of the committee, Medical Legal Committee, Dr. Ragini Agarwal ma'am, who is always ever vibrant lady, always there into organizing some conference or some webinar or the other. Ma'am, kindly requesting you to address all of us, please, today morning.
Thank you, Priyankur, for your kind words. Very good morning to all of you, and my warm welcome to all esteemed guests. Meera madam, who is an idol to all of us and inspiration. Dr. Hrishikesh Pai, President-elect FOGSI. We are going to finish our tenure, and Shanta's tenure is going to start. We are friends since almost more than 3 decades. And Dr. organizing team led by Dr. Machave, Dr. Kuthe. At the national level, local organizing team, Dr. Mitra, Saxena, another dear friends for since decades, and the ever vibrant Rewari Obs Gyn Society. Dear friends, faculty, Dr. Malhotra is there. Namaskar. First of all, I want to pay a tribute to all thousands of our fellow doctors who has lost their life to this pandemic in their line of duty. It's sad, but you're always in our mind. Welcome to this second day of North Zone Medical Legal and Ethics Journal Conference. Thank you, Manish, for giving at the end of my tenure this wonderful thing for which I am waiting. And thank you, Mitra, literally grabbing at the first journal conference and doing it within my tenure as a vice president in charge of this committee. Yesterday, we have a wonderful public forum attended by many public and the doctors, and it was many our doubts were removed by the esteemed faculty, Dr. Dhruv Chaudhary, Dr. Matthews, Dr. Reena Vani, and our own Dr. Manju Puri. And many bites we have from the people who are working, whether doctors or non-doctors, from the medical fraternity. Medical legal problem is another pandemic to our fraternity. What I can say, every patient is a litigant until unless proved otherwise. Like corona etiquettes and corona precaution, if we have a medical legal etiquette and medical legal precaution, only we can be spared of the devastating effect and we can have a normal life. So we have to be medical legally aware to fight this menace. I again welcome you all and hope we are able to do justice for your time and you go back little more aware for your practice, which is more peaceful and save you in a long run. Thank you so much, Chair FOGSI.
Thank you so very much, ma'am, for your wonderful work. So next, moving on, I would like to invite Dr. Meera Agnihotri, ma'am. As I've already said, she's a teacher of teachers, and all of us love to listen to her, to kindly say a few words to all of us today morning and bless all of us, please.
Okay, Dr. Priyankur, I just have to convey this message on behalf of Dr. Meera. Madam has gone for a cesarean section and all of us must take inspiration that ma'am is so senior and still she's so busy. So she has, politely informed me that she will not be able to join right away. But when she's back, when she joined, then we will have her words. So I think we will now go on to have a wonderful chief guest, Dr. Hrishikesh Pai.
Absolutely. So thank you, ma'am. And of course, Meera ma'am will, she always blesses us. So I'm sure her blessings are with us. So now I would request Hrishikesh sir to kindly address all of us. We always love to listen to sir of his ideas. And I'm very sure we're going to have a very fruitful year ahead of us under his leadership. Over to you, sir, please.
I would like to first of all thank you, Priyankur. You are always a wonderful, compare and you coordinate very well. One of our upcoming young people. And I would like to first of all, pay my respect to Dr. Alpesh, our president, Dr. Tang, then our dynamic vice president, Dr. Arti Agarwal, who is in charge of this. After, of course, my colleague, Dr. Meera Agnihotri, and then my all very good friend, Dr. Mitra, Manish, who is our chair. Then Dr. Alka Kuthe, who is also very important now. She is, I think, becoming more and more active in the Medicolegal society. Then the president, who is very important for us. FOGSI is made up of the societies. So I must remember that societies make the FOGSI. FOGSI doesn't make the society. So for us, Surekha Yadav, the president, is very important. And Renu Yadav. And the other people I see in the audience, senior people like Dr. Achla Batra, who is our AOJD president now. Dr. Gitendra, who is I'm so happy. Before I forget, the big shot, Dr. Malhotra. And what I inspiration for Dr. Malhotra is what? So there should be no language saying that our tenure is over and there's no over of tenure. FOGSI continues. We just have to keep on being attached to the federation. Dr. Ragini, that is a note for you. So your tenure is not over. Your relationship with FOGSI is continuing. That is very important. We need to have the continuity. FOGSI, so that is very important. Like how then Narendra Malhotra represents that continuity. See how he is there. He doesn't have to come. He became president so many years back, but he is involved in the federation. And then, of course, Gitendra Sharma, I've got a lot of hopes from him now. He will be my vice president. And Dr. Deepika Chhabria is there, Dr. Tyagi, I see Dr. Reena Vani, Manju Puri. Sorry about all this. If I miss out anyone, Parag Pinivale, I see his window also there. So what I want to tell you is that we need to integrate. Already integration is occurring. But I was just thinking that, so what are the 5 important things that are going to we are going to face? One is the COVID. We have to do rehabilitation, rebuilding. Focus has to be on patient, but primary focus on our fellowship, our responsibility to our federation. If there is any person, any gynecologist who comes into difficulty, we will contribute money to take care of him. So this is a very important prime thought process which I have, that we have to take care. Otherwise, what is the use of having FOGSI? So first priority is that. Second, then we have the acts. So P&AT MTPV Act is there. Then we have the Clinical Establishment Act. And now the two more acts will get added to it, the ERT Act and Surrogacy Act. So we'll have this Medicolegal Committee along with the group. So I personally feel, Manish, now we must make a permanent group. And I've been telling Gitendra also that there should be no exclusion. You can include, but not exclude. And I don't want anyone who is connected with Medicolegal has to be in that group, irrespective of whether he's a full-time professor, he's a private practitioner, I don't care. You bring everyone into the group. Then the second thing is the connectivity. So I feel that you divide the country into 30 states. Each state should have 4 people in the 4 zones. Suppose there is a problem, that number of those 4 people for say UP state. UP is the largest state. You divide it into 6. So that person phone has to be with every gynecology. कुछ भी हुआ तो फट करके फोन उठाना मांगता है. वो फोन नॉट कोई अरे फोन किसको करेगा, मनीष माचवे कौन है, अरे मेडिकोलीगल का चेयरमैन कौन है. नो, one man. No, not a single phone. 1-800 is a useless phone. You give this one person, so he picks up the phone, then the network starts. They can phone the vice president, they can phone the president, we'll mobilize everything. I want a total defense. Not a single case we must lose. Ruthless. Not a single medico-legal. We will have affidavit. Everyone. Suppose there's a patient with affidavit, 5 affidavits will get. 2 from professorial group. They are all our FOGSI members. Not a single case. If there is we lose a case, arbitration, we must create a fund. We will arbitrate. We will not allow our members. Members become very upset. I remember one of them committed suicide also. That's not acceptable to me. So we have to become very aggressive. Not a single case we should lose. We will take the best lawyer, topmost, 10 lakhs appearance lawyer will take, but we will win the cases. So this is the aggression we need to have, and we need to have the connectivity, and that's it. And then all those fire compliance and all. So now you make a national group. This group will add, not decrease. So create the national group, divide the state. And I don't, someone will say, "Arey, Dr. Pai, ye kya idea deta hai?" I don't care. Let Shanta implement it. I will consolidate it. I'm not here to sit and say, I did this, I am the greatest. I did 10,000 conferences. I'm not here to do that. I'm not here to do one upmanship. I'm here to take care of the federation and the interest of our FOGSI members. I'm just one of the savers of the federation. So this idea has to pervade. After Manish finishes chairmanship, he will continue in that committee. So I want you to involve all the 3 past chairmen of the medico-legal. Bring them in. They have got a lot of potential. And so that becomes our core solid group of medico-legal. Anyway, I don't want to spoil your fun, but I've got a lot of ideas. But I am going to, in my opening speech of FOGSI, I'm going to say, I don't want to do anything new in my year. I just want to consolidate all the things that the last 10 presidents did, because this is the biggest problem of FOGSI. Every president comes and tries to do something new and changes what has been done in the past. This has to be finished. We must now get on. We must graduate. We must evolve ourselves from being self-focused to being focused on the organization. Thank you very much, Dr. Mitra and Manish and all of you for calling me here. And I hope, and I'm going to sit with you. I'm going to listen to you and learn from you. Thank you.
I want to just say one thing, that it is so nice that everything is by destiny. We got to hear you completely. And all I can say is this inclusiveness. This is the essence of being Hrishikesh Pai. And we are very happy to have you as our chief guest and that you all are going to be here. So thank you, and thank you all the seniors, Dr. Naren Malhotra, Dr. Gitendra, Dr. Parag, all the seniors who've joined in. I welcome once again everybody on behalf of our society, our committee. And Priyankur, I think we are in time. We have 5 minutes. So my MOC, Dr. Neeraj, make sure that the flight takes off at 10 a.m. sharp with Dr. Naren Malhotra. Let's see how you do it, girls. Dr. Neeraj Yadav, please.
So I would like to thank Dr. Ma'am for giving me this opportunity, Mitra ma'am, and of course the vibrancy and the thought process of Hrishikesh Pai sir really awakes all of us, and I'm sure it's going to be a great time, and we all are going to have that fellow Foxian into the spirit into us throughout the next couple of years probably and the years on. So thank you so much, and now I hand over.
Thank you, Priyankur.
Sir,
Now
Pai sir, I'll just
like
add what you said. Priyankur, just give me 10 seconds. I'll just add, sir, this attempt of doing these zonal conferences is meant for this only, so that the zone people get activated. So now, for example, East Zone, hardly anybody is into medico-legal. We've always had chairpersons, people from West Zone, or North Zone, West Zone mostly. So when we have these zonal events, the local societies, the local people get activated, develop interest, and then, come and join the committee. So that is the reason why I put this, that we will have, instead of having, with individual societies, let's make it zone wise. And now
I think it's a very good idea, Manish. But now, before you finish, I want you to identify those 100 people all over India, 100. And this Jackson Paul is a very active pharmaceutical. You get them to give you that support, so let them be involved in the support system of the network.
Yes.
See, network support, and once the pharma takes it, the pharma can take it for 10 years. So they can give the network support to you, connectivity, this, that, so many, it's, anyone wanting affidavit, P&D cases there, who is going to take care of the P&D case, which are the important lawyers, but it has to be proactive. So alone, because we are, see, the problem with FOGSI is that we are a pro bono organization. Means what? We do everything without money. When many of the organizations abroad, if you do everything without money, they get suspicious. They say, paisa kha rahe kya? Paisa kaisa kar rahe hai without money? Because abroad, everything that you do is paid for, even if you are in a charity organization. So if we are a pro bono, so we are doing our private practice as well as we are doing our all this thing activity. So in that we get a little lacking. So we need the network of the pharma. So please, now you are a dynamic person from Pune. You give those 100 people. So give them to Shanta Kumar. Give them to Shanta Kumar, the 100. Let us start it in a year. We will consolidate in our year. But the committee will be made up of all of you. Jitendra is there, one of my generals. And that doesn't mean that Ragini is not my general. She is also my general. So that is very important. So continuity rakho. सबको लो, then only वो चलेगा, नहीं तो नहीं चलेगा. हमारे इंडिया में क्या है ना, सब लोग अहम है, यानी I, ego, me, myself, self-focused. We have to now get out of that. Yeah, it's important to be self-focused, but at our level, when we have reached our peak, now we have to be defocused about ourselves.
Yes. So thank you, sir. Inclusiveness should be the mantra as per what says. And of course, I think that will go a long way in helping all of us too. Thank you, sir. So next, I would hand over the session to Dr. Neeraj Yadav, ma'am, to take it over from here, please.
Thank you,
So,
Dr. Priyankur.
She's the secretary of the Rewari Obs Gyn Society and former medical officer at the Civil Hospital, Rewari. Over to you, ma'am.
Thank you, Dr. Priyankur. On behalf of Rewari Obs Gyn Society, I welcome you all in this North Zone Ethics and Medicolegal Conference. May the Almighty bless us all and we have safe time ahead. I am the MOC for session 1 and today we have galaxy of national speakers and chairpersons. So our first chairperson for session 1 is Dr. Achla Batra ma'am. Dr. Achla Batra ma'am is the president of AOGD. She is working as a professor, Department of Obstetrics and Gynecology, BMMC and Safdarjung Hospital. She has been president Narki Delhi chapter. She has been chairperson of Rural Health Committee AOGD 2017. She is a dedicated undergraduate and postgraduate teacher since 35 years. She has conducted research projects for ICMR and Indo-US projects, and she is the author of Workbook of Obstetrics. She has contributed to several Ministry of Health and Family Welfare guidelines. So, ma'am, we welcome you to this platform. Our second chairperson for today's session is Dr. Arti Gupta. She is the president, Agra Society, founder of Saath Saath Doctors Group, And she has received Nari Swasthya Pehal Award from FOGSI for organizing a multi-specialty health camp for 18,000 plus patients. And she has conducted national and international webinars as a coordinator and as a faculty. And she's also active in spreading health awareness in schools, rural areas via free medical camps. We welcome you, ma'am, to this session. Our next chairperson for today's session is Dr. Sarita Gulati. She's a PGIMS Rohtak alumni and she has the experience of SMO and Gynec in charge, Civil Hospital, Yamunanagar. She is presently working at Gulati Hospital, Yamunanagar, and ma'am is a president FOGSI Yamunanagar Society, and she has a special interest in infertility and high-risk obstetrics. So the opening batsman for today's session is Dr. Narendra Malhotra sir. Bas naam hi kafi hai. Narendra itself means Indra Devta. She is a highly intellectual personality, and sir is a practicing obstetrician and gynecologist at Agra. He is the director ART Rainbow IVF Agra and Delhi, and managing director of Global Rainbow Healthcare Agra. He is the past president FOGSI 2008 and 2009 with special interest in high-risk obstetrics, laparoscopy, infertility, ultrasound, ART, and genetics. And he's a member and fellow of many chain and international organizations. He has organized many workshops, training programs, conferences, travel seminars, pan-India and in Asia. In short, highly learned, able and dynamic personality, and I'm sure he'll take us all to the depth of heavenly knowledge. Over to you, sir. The topic is consent. Job well begun is half done. We welcome you, sir.
My one word for Dr. Narendra Malhotra is the indefatigable person of FOGSI. And he has visited Rewari many times, and this is time that virtually we are meeting. Welcome, Dr. Narendra.
Thank you, Dr. Mitra, for inviting me to this very, very great conference. I did attend a little bit yesterday, but because of being very, very busy yesterday in the COVID wards, I could not attend the full thing. So thank you for giving me a very, very interesting topic. Consents in OBGYN. Job is well done. Job well done is half begun. So it's not just the consent, it is the other things also. And I acknowledge that the material being used in this presentation is kindly given to me from Dr. MC Patel and Dilip Walke. I've just modified and colored it and beautified the slides a little bit. So the problem with the world is that intelligent people are full of doubts, and it's only the stupid people who are full of confidence. And that is where the problem lies. So if the intelligent people think and start thinking and not doubting and take decisions properly, we would have a different world. Now, when we talk of consents in OBGYN, it's not as simple as this, where a boy asks the girls, do you want to have sex? And she says yes, and that is it. So it's not that simple, and this is not the job which will be well begun and half done. Now, the easiest way to learn the legality of consents in the Indian context is that you go back to 2008 when I was the president, and to the Sameera Kohli versus Prabha Manchanda case, which was decided by a 3-judge bench of Supreme Court. On 16th January, we got the decision on, and they actually simplified what is consent. And consent here in this case was taken for diagnostic and operative laparoscopy, and it was said that laparotomy will be needed. But the surgery done was a total hysterectomy with bilateral salpingo-oophorectomy in a 45-year-old lady. And then she filed a case. Yes, they did the laparotomy, but they never took consent for hysterectomy. So going by this case, the judges decided what should be the consent word by word. And I'll try to simplify and take you through these steps so that we don't make such mistakes. The text of this judgment is more than a textbook chapter. It's huge. And it just tells us what a valid consent is. And the judges said that the valid consent criteria would be the capacity, define the voluntarily, and define the knowledge. And that is the consent which you have to take. So let's see one by one, what is capacity, validity, and knowledge. So capacity is that it should be an adult who's mentally sound. So 18 years and above, who's not insane and is not incapable to sign. And this comes under the Indian Penal Code 87, 89, 90. And it's easy to understand that over 18, the patient signs. Under 18, or if insane, or if incapable, then you take the consent of the guardian. So minor, mentally retarded, take. And if it is an emergency, you take your own consent. You don't need a consent. So what about, but there is a catch here. What about the girls who are 16, but they're matured too early mentally? So 16 to 18 is the girls who can still take their own decisions. And here you have to take the decision, the consent of the parents legally, but you also should take, like we do, consent of that child in addition, because she's not a child, she's an adult child, what we can call it. Next point is what we come as voluntary. So it should be free, no pressure. It should be signed by the patients and the others of the witness. So consent can never be signed by witnesses. You cannot ask the mother-in-law, father-in-law, husband to give a consent for what you're going to go and do to the patient. She has to sign the consent herself. So consent has to be signed by the patient, and all relatives, friends who sign on it are as witness. And this is Article 21, which gives autonomy, the right to life, the dignity and personal liberty to this woman to sign herself. Thirdly, it should be informed. Informed means there should be knowledge, nature of treatment, benefits and side effect. And there should be no fraud, no coercion, and no false promises to be made by the operation or by the treatment. The nature of the treatment, the benefits of the treatment, the side effects of the treatment, available alternatives, consequences, and refusal, all has to be explained. But here is a dilemma for us. How much knowledge is the dilemma? So if we give too much knowledge to the patient, then it's bad. If we don't talk to the patient too much, then it's bad. And of course, the Dr. Google Core is always there to interfere in what knowledge we are giving. And the patient comes to the knowledge of Google and then questions us on wrong points. Then there can be a refusal of treatment. Patient just refuses that she doesn't want treatment. And this also comes under the informed. And a proper consent for refusal also needs to be taken. Otherwise, you may land up in a suit. So the concept, looking at this, the concept of a valid consent in India is that the name, meaning, purpose, indication, description of the procedure, alternatives, and refusal. One area. The other, substantial risk of anesthesia, bleeding, blood hematomas, infections, injury to surrounding tissues, scar not healing, adhesions formation, hernia formation is the other thing which we should be explaining. Very rare conditions like allergies, fistulas, placenta previas, inadherent placenta, burst abdomen, incontinence, should or should not be is your choice. Every blood transfusion has to be consented, every blood transfusion. That is very, very important. And of course, the consent in OBS for the baby has to be taken, that it could swallow, it could have problems, it could come out with some problem, and that would need an ICU. So you need to inform the patient about the anesthesia and the blood transfusion, the nature of the anesthesia, the benefits, the purpose, and the effects, and the alternatives, and the substitute risk. And for blood transfusion, why are you giving the blood transfusion? What are the effects? And here, the anesthetist has to take the consent for anesthesia before surgery. So it's not that you take a blanket signature that I've explained everything. The anesthetist, before giving anesthesia, has to come out and talk to the patient. And so you could always have informed booklets available outside your OT or at the time of booking or at the time of elective operation and give it to it. When we do a tube ligation, again, that has to be an informed consent. So purpose, effect, types, alternatives, benefits, substantial risk. And then there is a question of whether we will do a tube ligation without the husband's or the family's consent or not. So again, the patient has refusal here, and then it is better that the consent for tube ligation be taken on the government consent form. Here is it, and it's available in regional language. And if you have a failure and if you're taken by the government consent form, then the government is going to compensate you to the tune of probably 2 lakhs if there is a failure, and the patient can claim it from the government. So the failure is explained very well in the government form, and just don't take I consent for tube ligation. That's not right. So as a physician, what should we tell the patient? Now here's again a dilemma, and every day I have to talk like this. So there could be 3 ways you could be talking about, and this is the American way, the English way, and then we want to make a Indian way. So most of the states in USA do take a reasonable patient standard. That means tell what is typically reasonable a physician should tell, which is usually inadequate and does not satisfy the requirement of informed consent. So it's not proper. The reasonable patient standard which the UK government follows and which the Indian law also allows or tells is a reasonable doctor standard, where you tell the average patient and let her make the decision. And then of course decide on case to case, and which is also known as the subjective standard. Now here this went into the Supreme Court, that what should India do? So the Supreme Court made it simple for us. Now does the Supreme Court expect us to talk about all possible complications? No. Expected, anticipated complications or requirements depending on the condition of the patient. Not all. So we do not need to explain all the theoretical risk and frighten and confuse the patient, which will result in a refusal consent for a necessary treatment. So that the Supreme Court allows us. Supreme Court tells us need to explain the risk and refusal of the treatment. So you have to have a column in your consent form as refusal of treatment. Supreme Court says no, but it is better that you take one, because the lower courts would take you to task if you do not. Supreme Court expects us to talk about all possible complications? No. It does not expect us to talk about theoretical risk of a treatment, which will persuade the patient to undergo fanciful, unnecessary other treatments like that. So what the Supreme Court tells us, a balance should be achieved, and the onus of deciding the balance is on us and you and me. FOGSI can decide the balance? Yes. Hence, it is important of standard procedures, surgery, specific consents be made by FOGSI, which I think we have, and it's on the website. And if we take consent on our federation's consent forms, then of course the federation is going to back us and back us in case if there is any litigation or any problem. So that is what we know. So FOGSI will balance, provide the balance for us, which is needed for consent, a valid consent. Now, so there are some questions which you ask me. Is the consent always written? In the absence of written consent, the lawyers in the good old days argued, nowhere it is mentioned it should be written. Consent is a contract and it could be oral. But the Samira Kohli Manchanda case said consent has to be written for all surgeries and procedures. So the informed consent has to be written. Now, examples of consent which are not written. When the patient comes to you for examination, a PV examination does not need a written consent. A PR examination does not need it. An injection does not need a written consent. An IV does not, a phlebotomy does not, a non-obstetric ultrasound, only oral consent is necessary. A breast examination by a gynecologist expresses oral consent. And here again, there was a case, the Anuj story, and here also the oral consent is good enough and you don't need a written consent for all these factors. Just to complete the list, advance consent given by the patient before death for organ donation. Recycle yourself. If she's written it on her hand and she dies or he dies, is that going to be a valid consent or not? Again, that has to be decided. And a proxy consent, if there is a road accident and the patient is unconscious and you picked up the patient and brought to the hospital, you cannot be authorized to give the consent, or the police will give the consent, or the attendants or whoever is the witness who have picked up can give a consent, which is known as a proxy consent, or a bystander acting as a proxy. Should consent be taken by a doctor? Can physically be taken by any resident or staff nurse, but it has to be signed by the operating doctor. So counseling can be done by the concerned consultant and final signature also. So who signs? The patient signs, the guardian signs, the witness signs, and the treating doctor signs. So these are the 4 signatures which are needed, and it's a contract between the 2 parties. So several judgments are there that it has to be written contract and it has to be all the parties and the witnesses signing it properly. Now here's a quick quiz question for all of you. You took a consent for elective CS, but you postponed the surgery for 3 days. So can we do this consent, the same surgery with the same consent? Yes or no? Well, I see 10 people saying yes and 10 people saying no.
No.
So
no.
48 hours is generally accepted as the limit by most hospitals. And if it is delayed more than 48 hours, a fresh consent has to be taken. You finished LSCS and there is a table death, and you realize suddenly that the staff had forgotten to take the consent. Now, should you take a thumb impression of the dead patient? So in all cases of goofed up cases or forgotten consent, the compensation has been to the tune of only a few thousand rupees, despite saying that it is an assault or a battery of assault. So don't bother too much. If it has been forgotten and if the case is in the court, you're going to be fined only a few thousand rupees for not taking the consent. And you're not going to be found guilty for negligence. So never resort to forgery. Forgery is a crime. And if you take a thumb impression and forgery, then you can be arrested and criminal case could be there. So it's better to accept that it was a lapse of my judgment than to face a full-blown negligence and face a negligence and be fined a few thousand rupees rather than face a criminal case for forgery. So consent for last few slides, consent taken in obstetrics is an additional challenge. It's a well-begun, half-done job. Now let's look at the other half and do a full good job. So situation 1, a patient is in obstetric labor. You did counseling with the patient, told her an LSCS is required. She said, talk to my mother and my mother-in-law and her consent. You took the mother-in-law's consent. Is it valid? No. Patient's consent is a prime. Having said that, the patient was in labor and she was having pain. And if something went wrong later on in the court, she can tell, I was having so much pain and I did not know what I was signing. And these 3 people came to me, jaldi sign karo, and they did an operation which I did not want. So be careful of that. Situation 2, consent mentions LSCS on demand. And there is a complication. Now the allegation in this case was that the doctor never explained me a possibility of a complication in surgery or delivery as compared to vaginal delivery, and documentation was not done. So a separate format of consent for this situation is needed. So the patient is asking for LSCS on demand, you have to take a consent for cesarean delivery on maternal request, and she has been explained for all of it. What about the Mahurat Caesar, timed Mahurat LSCS? There was a delay in delivering the baby and the doctor had promised a solution, but it was never assured. So I will try. So your solution is that you have to tell the patient, I will try within the stipulated time if you have a specific time, but there may be deviations because of a lot of factors which are there. Never mention that as an indication. Mahurat's LSCS is not a medical indication for doing a cesarean section. So never mention that. Patient has registered for a cord blood storage for stem cells. And the phlebotomist of the company has arrived. The LSCS was done. But during the LSCS, suddenly there was a bleeding and everything, and everyone forgot to collect the cord blood. Now the allegation to the doctor was that I have paid 60,000, I paid to the company, it all got wasted, company is not refunding, you have collected only 20 ml of cord blood outside when the placenta came. So that situation could be there. So there should be a proper SOP for policy of the hospital for stem cell banking if it is needed. Do not share the data of the patients in antenatal period to the companies and never endorse any single companies, no standees, no sponsorships of antenatal classes, not let them sit and counsel your patients for cord blood. You do it yourself. Because if they do it, then it comes under the kickback rules. And please don't take any kickbacks. You collect your fees, let the company collect their fees. You collect your fees for collection and do not take anything what the company collects out of that. Another situation, 14 weeks pregnancy, and she came with a severe right iliac pachyphone. Appendicitis was diagnosed. Laparoscopic appendicectomy and a hemorrhagic ovarian cyst discovered intraoperative. Now, can you drain this cyst or a simple cyst? If this is an additional surgery and it cannot be treated without the patient's consent. However, if you feel this was an emergency one, and if it is an emergency, then an emergency consent can be given by you and another doctor, your assistant, and then you tackle this situation. Otherwise, no. Pregnancy with ovarian cyst, consent of a relative is not valid if you have found an ovarian cyst, small ovarian cyst or a small fibroid on the time of operation. PPH, severe PPH has occurred. Relatives are not found in the hospital campus, not contactable, and you've done bilateral iliac, you've done compression sutures, you've done everything, and you had to finally do a cesarean hysterectomy without consent. Is it valid? Yes. This is valid because this is an emergency, life-saving, life-threatening situation. Section 92 of IPC allows you to do a cesarean hysterectomy without consent of the attendants of they're not. Similar situation with a twist. Fetal distress, you advise LSCS, relative said, okay, patient refuses. Can you do it without consent? Is there a threat of life to the fetus? There is a threat of life to the fetus, but in India, the fetus is not a legal entity. And if there is not a legal entity, there is no case of such being decided by the courts. So you may take a refusal consent, and if she refuses to give a refusal consent, get 5-6 neutral bystanders and explain to her that she needs a cesarean because of the fetus death, fetal distress, and then take a consent. Similarly with placenta previa bulging, and if it starts bleeding, emergency cesarean hysterectomy can be done. Now here was a very interesting case which went to court, a case of perforated appendix with peritonitis, and the patient refused to give consent. And the refusal was not documented. A conservative treatment was given. Next day the patient worsened, and now the patient gave consent, operate kar do. But she was very serious to be operated. So the conservative treatment continued and the patient died. So here the verdict went against the patient, against the doctor, because in such a case, consent was not needed. It was an emergency situation. It was life-threatening situation under IPC 92. You could have done so the judge said, I find it to be a bad judgment by the doctor. Consent for surgical, whether you can push the patients deliberately and forcefully into the OT or not, in such cases is again which needs to be decided by you. So if there is a situation, obviously the Indian hospitals are always full of bystanders. So you take, if she refuses, call all of them in, explain to the patient what the situation is and take everyone's signature. So in the court, they will be your witnesses. LSCS with fibroid, if you've detected the fibroid before, please take the consent treatment that the fibroid will be removed. If you find a small fibroid during the operation, please don't take it out without the patient's consent. Unindicated cesarean sections too late, too early. I was told about, not told about the complication, not told dura puncture, not told. These are patients remember, even after 2-3 years back, and they will come to the court with this. So this would be your consent was taken, but it was half done. So it was not completely done. In labor, you document the NSTs, CTG, document everything, and then take a refusal. And again, this has been, the refusal consent has been documented in the American Journal 2013 in a very beautiful article, which you can go through and read about refusal of consent and the capacity of the patient to remember when they come back for the case. So what needs to be done? These patients have to be counseled. And this study says that during the antenatal period, everyone should be talking to the patient. And you should have antenatal classes where once the anesthetist should be talking, the junior doctors, the nurses, everyone should be talking. Now, this is not possible because we're dealing with so many patients. So we have what we call as the app, the IMUMS or your pregnancy companion app. And if the patient gets free app downloaded on her mobile, she gets all counseling done by doctors, by a group of doctors who are listening here. Hundreds of you are on this app who can counsel the patient through the app, and that could be a very, very good pregnancy companion and could be a very, very good defense for you. Last slide, COVID. Are there any special concerns for COVID? We have made an admission consent for COVID. We have made an admission consent for COVID, and where we ask the patient about fever, about cough, or about this thing, about vaccination, about COVID test, and then to take a consent that she could be bringing asymptomatic COVID into the hospital, or she could take away the COVID from all of us, all the nurses, all the other patients. So probably that type of consent which I'm working at would be needed. And I'm sure MC Patel, Dilip, Achla, Manish, Machave must have worked up on a COVID consent, and we could add this COVID consent to our consent. So ladies and gentlemen, take a valid consent. It must be of any type for treatment procedures. It should be written and informed. A blanket consent has no value. It should be procedure specific, and it should be for medical legal purposes. You can't say this consent is not valid for medical legal purposes. All consents are valid for medical legal. Consents in OBGYN is a job begun, but it's half done. So you have to be vigilant. The consent provides us a legal protection. Consent is not a defense in professional negligence and criminal negligence which you have. So consent will just provide you the patient consented. But if you've done a criminal or a clinical negligence, have left a sponge inside the abdomen, done a botched up surgery, that would be a different case. You might be right of doing a surgery, but that case would come to the criminal court. So thank you very much. Please do not confuse, it has to be informed, but please do not confuse the patient with so many things that she get A, B, C, D, E. Now you choose yourself, and the patient is going to be very, very confused. Choose whichever therapy you prefer is not the correct answer. We need to guide our patients. We need to help our patients. We need to do our job completely and well done. Thank you very, very much, Dr. Mitra, for inviting me here to express my views on consent. Thank you very much.
Thank you very much.
Thank you, Dr. Malhotra. I always find, ever effortlessly doing multitasking, everything, and your talks are always very simple and comprehensive. But before I sum up your talk, I think though Mitra told me not to talk about pleasantry, but I cannot but thank Mitra, most vibrant, enthusiastic, and ever smiling, for making me part of this conference. I'm gaining a lot from it. Now about Dr. Malhotra's talk. I think the few take-home points we must all remember is that counseling the patient before consent, and like he said, don't scare the patient. The judges also said that you can give them reasonable side effects or complication which can, you don't have to tell them all. But Dr. Narendra, can whatever is written in FOGSI, will it stand in the court of law?
Yes, because if your organization supports you, and if what the Supreme Court has said in the Manchanda case, and you've done exactly like that, it will stand in the court of law. Yes, and we have.
Hello.
Yes.
Can I say something?
Please.
Yes, please.
So I personally feel that we must have this I've been telling, but somehow we have not got to doing it. So we need to have a SOP guideline on everything. And we need to publish it so that if there is a litigation, we can refer to the guideline. So this is one of my thought in my mind. Gitendra and all of you, Manish, you will have to work on this. Say, for example, cesarean. What are the prescribed this thing? So tomorrow, if there is a litigation, we'll say, no, we are referring to this. Our association has got together and has put this guideline, minimum guideline, and we are following it. And that will help our people to follow the guideline also. So this is one more point I would like to make is this is where Manyata licensing you all should do, because it's a very cheap. What is there? 20,000 rupees. PNDT Act 35,000 rupees. If they tomorrow increase it to 5 lakhs, you will pay that 5 lakhs and get your PNDT license. But so Manyata is very important because it makes you very standardized in your protocols. And that what we want to do is also extend it to the NCD and want to extend it to the infertility also in the years to come. So what I'm saying is guidelines are important, and FOGSI should publish the guideline along with the professional group and the private group together, create a consensus guideline which should be used for medical legal defense.
Thank you, Dr. Pai. That's what exactly, what is needed. When we say that FOGSI said it, we should have a documentation. Very well said. The next thing, very important, which Dr. Narendra said, and I want to reiterate, that must take the consent for refusion. That is where we are lacking most of the time. Blood transfusion consent also is not taken by many. So that also should be remembered, that blood transfusion has many complications which can occur. So the consent must be taken. And the timeline, yes, even, I was not very sure about this 48-hour period. So I have also learned that the consent is only valid for 48 hours. So thank you, Dr. Narendra, for, simplistically bringing all the things about consent. Thank you very much.
Dr. Neeraj, please take the second talk.
Okay, thank you very much, Dr. Achla ma'am. Now the next speaker for the session is Dr. Ragini Agarwal ma'am. Madam is a Vice President FOGSI 2020 and she has many feathers in her cap. She is the founder of Gurgaon OBGY Society and she is the founder president of Har OBGY Association, which has united all OBGY people across Haryana. So we welcome you, ma'am. And in today's, with lots of medical legal cases and litigation in today's time, your prescription paper becomes very important. So ma'am will be speaking about don't underestimate the power of your prescription. So over to you, ma'am.
Dr. Ragini, please
Dr. Ragini, ma'am.
Yeah, very good morning to all of you. I'm just sharing my screen. And excellent talk by Dr. Malhotra. It was so mesmerizing and always helpful to all. So with blessings of Mahakal, I will start my talk of today. Don't underestimate power of your prescription. Yes, we write our prescription just like anything that we are just writing a prescription. If you see many prescription even written by you afterwards, you think, is it really I have written it in such a absurd manner? And many a time you are not able to read anything from anybody's else prescription. The prescription is something when anybody entered in your room for an interview, if the person is well kept, well groomed, he has more chance to get a job than a person who is unkept. And that is your prescription, which tells a story to other person, whoever take your prescription in her or his hand, your whole personality will be reflected. Now coming to the medico-legal way, a written or today electronic prescriptions from a practitioner or designate agent to a pharmacist for a particular medication for a specific point. It is a medico-legal document. It is the first time a patient is entering in your room and there's a unwritten consent with her, with you. It is a contract that you are going to treat this person and now you are starting your treatment. So it is a paper in the hand of that patient which can be given to the court at any time and can be just totally mercilessly, whether you have done a right job or not. So a prescription itself has its own components. It is just not writing that Tabladolo 650 BD. No, it has a component. And until unless you will cover each and every components of that prescription, it will be an incomplete prescription. Although there is no global standard as such clearly written that it will be a part of prescription or not, But there are certain guidelines which was now defunct MCI was given to us. You just see this prescription, although writing is very good, but it is okay? This prescription were written a BID, what does it matter to a patient? What is BID? How is going to take that tablet? Or this prescription, although rightly they have entered all type of the information, but it is so hazard, it is very difficult to say what is written where. And this calligraphic writing, which is not being read by everyone, is not acceptable. So it's this is a prescription from the MCI, which was on the net long time back. Now the site is not there anymore. One thing is very important, your own registration number, where you are registered, which state you are registered, what is your number is given, full address, and any contact number, whatever you want to give for an emergency to the patient. Patient full name, address, her age and sex is very important. Then we come to the date. So these things is the part or component of an paper. Now for OBGYN practice, for us it is very important to know the last menstrual period. So you should write in your just print it in your paper, last menstrual period, LMP or ADD, if you are seeing doing obstetrics practice also. And we all write non-generic medication. But think of how you add the generic word like iron, calcium. Maybe in the second line, you write what you want to give, but the printed is iron. And when you write the medicine, it is always better in today's world to make a table and give it a heading and write it like this. And it should not be a small slip or a paper from a pharmacy. I have seen those prescription also from a pharmacy paper, the doctor who is sitting in a chamber of that pharmacy writing on that the prescription. These things are not valid in today's days. The time has changed. Bygone is bygone, and any person who doesn't change with the time is not going to survive. The most important requirement should be legible. It should not be something which is not legible. And many a time, specifically a drug which can be having a confusing name can be taken inadvertently with the patient. And second thing, it is very important, very precisely, it should be written how to give, what is the dose, what is the strength, what is the frequency, and what is the duration of the treatment, what you are giving. So there's a subscription, prescriber's detail, means your detail, your name, your address, your contact number, your degrees, and your registration number. Then inscription, that is the name of drug, amount, duration, frequency, intensity, and direction, how to take it. Then any other instruction if you want to give, take with the water, take empty stomach, take with this tablet, or you will not take with this tablet, then your signature is must, and it is better to put a stamp also. So what are the common prescribing errors? Wrong or inappropriate drug, wrong or inappropriate dose. Sometimes you're writing 10 and you have written 100. inappropriate unit. Instead of microgram, you have written milligram. I've seen in the basically in the thyroid medicine, instead of 25 mcg, many a time it was written mg. Poor eligible prescription, failure to take account of the drug interaction, and this is very important. The patient take iron and calcium together. It is a small mistake, but there are many a time two drugs can interact a lot. Then omission, wrong or multiple routes. Instead of subcutaneous, you have written IM, or patient not, you forgot to write the subcutaneous, like in your case of low molecular weight heparin, and patient has taken it IM. Calculation errors, specifically in the pediatric patient, not in R, it is not so much common. And you have to write in which you are going to dilute that IV injection and how much amount, specifically with IV iron. It is very important that you are not going to put that ampule in the 500 ml of the normal saline and give it slowly. What it will do, it will cause a reaction. Iron will be dissociated from the molecule and there's an iron reaction to the patient. Anaphylactic reaction can be occur. So everything should be detailed, that how you want to give this thing, a proper instruction from your side, and it should not be oral. Now, date. Why it is so important? Because if you are not written a date, it will come in a purview of a negligence. It is an important part of the medical record. Compliance behavior can be estimated using the date filling and refilling. Duration of therapy will be taken from that. If you are written on 22/5 for 5 days and patient is continuing it till say 22nd June only, then you can say that I have written for 5 days. It is very common with the steroids, and patient can always blame you that I have taken this steroid because you have not written the duration. All the orders for the controlled substance be dated, signed on the day issued. So write legibly. It is better to use the block letters. Sign and date are important. Legal document. Never abbreviate drug names. Not write LKO. Or never use proprietary names. Always use generic name. So make your prescription like iron, then whatever brand of the iron you want to give. Use plain English for dosing direction. 12 hourly, not even twice a day. He will take a 10 a.m. and the 2 p.m. It is a twice a day. Write 12 hourly, 6 hourly, 8 hourly at the night time or whenever is needed. No SOS, no HS. Then careful with the look like or sound like names. We have seen I have seen a woman getting Minolone, which is an anesthetic agent instead of a mixogen. Now, do not guess. Check the name or the dose of drug. Open your mobile, see. If you don't remember, just don't write like this. Nobody bothers. You are not a computer chip in your mind. Avoid tenfold dosing errors. Write 1 milligram instead of the 1 mcg. Do not allow patient to prescribe for you. Never give a prescription. If patient asks you, doc, just give me this prescription. It is absolutely wrong. If you're not sure, not even write for your relatives. So finally, your all prescription is your reflection. How it should be written. Not only all these details, they are a technical part of this. You should write a very short history. It is not your bedhead ticket. Examination, proper examination, positive finding, related examination, and where it is a negative findings are important, it should also be entered, and a probable diagnosis. It should be always written diagnosis provisional, and then whatever investigation she has, review it, only then write the judiciously the investigation. And if patient refuses, document it that patient is not going for this investigation. And plan of care is also a new terminology which you have to write. Then only come your pharmacological advice and the follow-up. So this I have all told you. But there's one thing which I again want to stress is the recording of the vitals, and specifically in the today's COVID time, it is very important to triage your patient. If patient is having a fever or a headache, myalgia, sore throat, that patient should be in this pandemic be taken as a first COVID patient unless ruled otherwise. And pulse, blood pressure, temperature. In our case, even weight and BMI is also very, very important. If you document, it will help you a lot to write your prescription. Instruction to the junior staff and the patient is very necessary. If you are told your junior staff in advance, they are able to discuss with the patient again. Maybe they are not bothered to you. History of drug allergy, very important. And prescription, again, the clean handwriting, I will stress and stress. History of past illness, history of any additions, major drug interactions, and without diagnosis. If you give a prescription, in this, it was a culpable homicide in this particular judgment, and provide contact in case of physician non-availability or emergency. You are responsible for your patient, specifically a pregnant patient. You cannot say no, that now I am not available for delivery. Mention diagnosis under revision until diagnosis is finally settled. Record advice for diagnosis test and the referrals. If you're referring a patient to somewhere, clearly written. Maybe you don't want to refer a person, you write a tertiary center, or you write a reason. Now I love referring for a betterment of the patient. Counseling and the prognosis discussion should be explained, and it should be done in writing. Signature of the patient should be along with the one witness if possible. If you are thinking that this case is little difficult, going with you for a long time, but now you are not able to manage, these type of documentation, or your patient is not agreeing with you, these type of documentation always save you in a long way. A note should be recorded in case of erring patients on any count, unreliable history, refusing admission, refusing investigation. And as I told you, a registration number should be there. I will not cover this part. Otherwise, also Mitra has given me only 12 minutes. So I will just say one thing. Telemedicine is going to be covered by my friend Dr. Valke very, very beautifully. But only thing is that we all are doing telemedicine today. We should be very clear about it. It should be properly entered, and it is important to confirm the identity of the patient before consultation. Consent before starting the teleconsultation is important, that you are not doing a physical consultation. Things can be missed, and patient will come for the physical consultation whenever you want. And have a photocopy with you also. Clear, concise histories, clear instruction, it is more important, and follow-up date is necessary. And this is something like category of medicine, list O, A, B, and prohibited list. This is important when you are giving a telemedication. I will not show this thing. So coming to the end. So at end of the day, the goals are simple when you are writing a prescription or treating a patient. That is safety and security. Thank you so much for your patient hearing.
Thank you, Dr. Agni. Thank you, Dr. Agni, for such a crisp message on the prescription writing. I have seen many prescriptions in my vicinity which are even not having the blood pressure, weight, even the basic things of the LMP, EDD. So most of the gynecologists are not writing the proper prescription. By this talk, I think the most of the people should understand the value of writing a prescription. I am really, I thought that when the prescription is not complete, how the gynecologist itself can evaluate the growth of the fetus and all the other things. Now the BP is last time कितना था, अब कितना है, weight कितना था, अब कितना है. जब आप basic चीजें भी नहीं लिख रहे हैं, तो I think this is very important that we should write. And the most important thing which you have emphasized is that we should write the negative things as well. The patient is not ready for this investigation. Patient is not ready to understand that her child is not in a good health. There is a deficiency of LICA. There is IUCR. All of these things which we should mention on our prescription, the patient is not understanding, patient is not following the instructions, patient is not coming at the proper interval when the patient should come. I think there are a lot many things which we should write on the prescription, and prescription is very important. We should write each and everything. I don't know how the people are making the prescriptions without temperature, without BP, even in COVID time.
Thank you, Dr. Arti. I am very sorry, but the talks are excellent. What I want to say, one sentence only, that what an organizer feels when the speakers do full justice to the talks given. So Dr. Narendra and Dr. Ragini, you've done full justice to the topic given. Don't underestimate the power of prescription. Dr. Neeraj, Dr. Yes, I'm very sorry because we want to catch time.
Okay, so no problem.
Invite our third speaker.
Just one comment.
Thank you very much,
Dr. Mitra,
everything
very well said by Ragini, but I think the writing should be legible and we should not use the pen, the ink may run off. We should be using permanent ink. That is very important.
Yeah.
Okay. Thank you very much, ma'am. So the next speaker for today's next presentation is Dr. Dilip Balke. Sir was the president of Pune Society 2019 and 20. He was the chairman, Ethics and Medicolegal Committee, FOGSI 2007 to 2010. He is the founder director, Dr. Prax Telecommunication System. He is a
Please switch off your audio. Dr. Arti, can you please switch off your audio? Yeah. Carry on, Neeraj.
Dr. Dilip Balke is the pioneer in telemedicine with emphasis on the correct use of telemedicine. He has visited Rewari twice and we are privileged to have you here, sir. Dr. Dilip Balke, sir, over to you.
Thank you. Am I audible and can you see my slides? Oh, thank you. Thank you. So first of all, thanks to the Medicolegal Committee of FOGSI and especially thanks to Mitra Di because I'm here because of her. She's a very good friend and because of which I've been coming to Rewari so often and I'm just waiting for that day when this pandemic gets over and I come back to Rewari once again. So coming to the topic, looking back from 2018, I have been trying to promote telemedicine, but I was ridiculed, literally. Every time I tried to do that, I was ridiculed. Because the teachers would say treatment without examination, such consultation, and even Dr. Balke should be condemned. The medical legal experts would say, "Arey, terko Jacob Matthews malum nahi kiya, usme telephonic consultation allow nahi kiya." Or don't you remember Dr. Pavaskar, who was implicated under 304, or the MCI, which is silent on telemedicine. So all these people used to ridicule me whenever I used to talk about teleconsultation, and when I talked about my app. Way back in 2018 and the audience would say हम लोग करते तो है मगर कहने से डरते हैं. And the gossip in those days was लगता है कि वाल्के का ये जो ऐप का धंधा है ना वो एक दिन डूबने वाला है. But now in 2021 there are more than 100 doctors on board with me on my telemedicine app and telemedicine has come to stay now. I was wondering what to speak today and when I was doing that I thought if I were to talk about telemedicine this would be the reaction of all the audience sitting because telemedicine ke bare mein sun ke kaan pag gaye. Because if I were to tell you that it is allowed, that we can charge, that there are 4 categories of drug, one of which is prohibited, there are specific guidelines for first and follow-up consultation, that record keeping is mandatory, and that private platforms providers are recognized. Ye sun ke hum log bore ho gaye. So what I thought was, I should ask someone, a friend of mine, what to speak today on this topic, and the only friend that I could think about was Mitra Di. And Mitra Di has got a slide which says ask me anything. So मैंने उनको पूछा मित्रा मैं क्या करूँ? The only thing that he said कुछ भी बोलो मगर जरा हटके बोलो. And that's the reason why today I decided what I'm going to talk about in telemedicine is only about data privacy and confidentiality. Privacy is all about personal identity, taking care of personal identity, and confidentiality is all about health related data. Private platforms have to make money, and that's the reason why private platforms will make money by either collecting money upfront from the pharma and then offering the apps free to the doctors. But that will not be, if you take any app from any private platform provider, you will be pulled up for code of ethics. Code of ethics ka kya hoga agar if you're taking anything free from somebody? They might sell the data, and if they sell the data, then privacy and confidentiality ka kya hoga? And if they want to do their business 100% ethically, then what they are supposed to do is charge subscription charges from the doctor for the software support and the storage of data on the cloud or server, or charge you percentage of transaction fee. But all these two things are not enough. And I am into that business, and I understand that charging these two are not enough to make any private platform provider sustain financially. So essentially, they are either going to contact a pharma, or they are going to sell the data. Now, the moment I say they're going to sell the data, the medical legal experts would come and say, if there is a breach in data, private platform provider ko kuch nahi hoga, lekin tum latkoge. Private platform providers are not governed by any authority, lekin you are governed by NMC. And if the data which is owned by the patient is sold by the private platform provider, doctor, you are going to be answerable. And then the immediate reaction, abhi kare to kya kare? And दूसरा रिएक्शन होता है कि हम लोग ये प्राइवेट प्लेटफॉर्म प्रोवाइडर जो आके बेच के गया है ना अपने को, उसको पकड़ेंगे और बोलेंगे अगर मेरे पेशेंट का डेटा तुम बेचोगे देन देखो मैं क्या करूंगा या क्या करूंगी. And they are very cool. All these marketing guys are very cool. They will cool you off, and they'll tell you we maintain data in an encrypted form. We have our own server or cloud to store data. Our backup person who can decode the data is bound by a non-disclosure agreement. Our system is robust system as per the American standard or UK standard or Canada standard or XYZ standard, and we sell the data. When we sell the data, we maintain anonymity of the patient, and because we take a blanket consent the moment the patient downloads our app, we take a blanket consent from the patient that with anonymity we may sell the data. Blah blah blah. Ab bilkul chinta mat karo. This is what they will tell you. And on the top of it, they will show you the telemedicine practice guideline, which mentions that a doctor will not be held liable for any breach in the privacy and confidentiality which occurs due to technical snag in the platform. So ye humko wo batayenge. But then we will tell them hamare FOGSI medical legal experts ne bataya ki divulging patient data is a crime. Now, first of all, try to understand divulging data, is it always a crime? Because divulging data and sharing data has got public health implications. Because unless there is a homogeneous ecosystem for sharing all the data with anonymity to a government of India server of, say, the Ministry of Health and Family Welfare, it will be very difficult for the government to come up with good healthcare policy. I mean, they have been able to make the healthcare policy in this pandemic only because the data is coming to them. And data, you all know, is very important. There are many people sitting here who are researchers. Data is very important for medical research also. But however, though healthcare data has got public health implications, it is also important for us to know that data is like oil. It is a lucrative commercial commodity because companies like Amazon, Google, Apple, Microsoft, and Facebook, they make use of this health information, geolocation information, financial information, browsing information, professional and employment related information, etc. for a big business that they are doing. And your health related data is going to be a lucrative commercial commodity even for a pharma industry. So to be a smart user of teleconsultation platform, we need to know the laws which govern privacy and confidentiality in our country. So if you want to try to find out what are the laws which govern privacy and confidentiality in India, you will understand that there is no specific legislation in our country, but they follow certain other statutes. And number one statute that they follow is the Article 21, which gives us a fundamental right to privacy. Number two, they follow the Information Technology Act of 2000 and the rules 2011. And they follow, they will follow later on, because this is just a bill, Personal Data Protection Bill of 2019, which will be soon presented in the Lok Sabha. Section 43A of this IT Act says the firm is liable for compensation. How much they have not mentioned, if security of the data is breached and has caused a wrongful loss or gain to someone. So data breach and wrongful loss or gain to someone, and the firm is going to be held liable. It is not liable if there is a consent from the person jiska data rakha hua hai, and they say that the company has to publish the privacy policy. They should allow the individual to access his or her personal data. So presently the platform providers can escape by taking patient's consent. So as things stand today, you take a patient consent for selling the data or for divulging the data, you are safe. 722A is punishment of maximum 3 years and a fine of 5 lakhs for the person who contravenes the act. Limitation of this particular act that is there at the moment is it is only applicable to sensitive personal data only on electronic medium. It is not applicable to state or state government, central or state government owned firm, and it does not specify which government agency will govern the data protection. And the consent, as I told you, is an easy escape route for anybody who's divulging the data. So this proposed Personal Data Protection Bill of 2019 has come, and which includes health-related data under the term called DISHA. This is going to include diagnostic checkup online, advertisements, health insurance companies, and apps even like Fitbit. Breach in notification of the data can attract fine and punishment, and will also include state and central government owned companies, and will include geolocation information also. And the DISHA has an objective of securing electronic health record through a state or a central level digital health authority. All providers and all clinical establishments will be governed by it. And the key points are that the data is owned by the individual, that we all know. Owner has to be informed about any breach if it occurs. Data can be collected, stored, and transferred only in specific situations which are going to be mentioned in that act. And divulging of information in public health interest still remains protected. So if the information has been divulged for the sake of public health, then it is going to be protected, and the person will not have any privacy right over it. So till DISHA shows us the way forward, at this moment of time, we must look out for a private platform provider who stores the data in an encrypted form so that nobody else can see it, who has got a non-disclosure agreement with the doctor and the patient so that this data cannot be divulged anywhere. There is a patient consent for divulging the data on the promise of anonymity of the patient's name so that the privacy will be taken care of. And there is an ecosystem to make the data available to the patient on demand. And also there has to be an ecosystem to make this data available to a common server, which can be owned by the government of India, so that will help them to make the healthcare policies for our country. Later, when the act is passed, then we will decide to abide by it. However, I do not see this becoming an act very soon, because the one organization who keeps a vigilant watch on our personal information is none other but the government of India, because that they need for their election strategies. Secondly, can the lawmakers dissatisfy companies like an Amazon or a Google or Apple or Microsoft or Facebook who are running only on data? So they are not going to do that. So till that time, let us relax and continue to connect on telemedicine apps which are available. And when the law actually comes in our country, we will abide by it. Thank you very much for a patient listening. If there are any questions, I'm ready to take it here.
Interesting and
Thank you
crisp
very much.
and enlightening.
Thank you very much, sir, for such an excellent talk. We are falling short of time, but I would like to have one comment from Dr. Sarita Gulati, ma'am.
Thank you, Dr. Akhle, for such a comprehensive and informative talk. You have enlightened certain new things in this telemedicine, and everybody must have gained a lot from your talk. Thank you very much. At the same time, I like to thank Dr. Mitra. I have got all praise for her. This is her enthusiasm and effort for organizing this CME in these times of COVID. She is a real warrior, COVID warrior. Thank you so much.
Thank you very much, ma'am. Now I would like to invite the speaker for the next session, that is Dr. Jaideep Tang. Who doesn't know Dr. Jaideep Tang? He has been heading FOGSI as a Secretary General since long. and he has been awarded FRCOG honors in 2020 by Royal College of Obstetrics and Gynecology. He has been ex-chair Publications and Newsletters Committee, Asia Oceania Federation of Obstetrics and Gynecology. He has been heading so many forums. He is a consultant gynecologist at Ashwin Maternity and Surgical Hospital. He has worked on amendments to the MTP Act with Government of India and drafted the proposed guidelines for abortion beyond 20 weeks by Government of Maharashtra. We welcome you, sir. He will be speaking on MTP Act's new amendments timeline. So over to you, sir.
Thank you. Thank you very much, Dr. Neeraj. I will just share my screen. Right. I hope I'm audible and my slide is seen. Am I audible?
Yes, sir.
Yeah, and the slides are seen, right?
We can see our program. We cannot see your slide.
Yes, that's my first slide. Okay, thank you. Thank you very much, Dr. Mitra. And first of all, let me congratulate the Ethics and Medicolegal Committee and the entire organizing committee of this quite wonderful conference, both for organizing it, hosting it, and also for inviting me. I would like to acknowledge the organizing chairpersons, Manish, the chair of the Ethics and Medicolegal Committee, Dr. Alka, Kuthe, the organizing secretary, Dr. Mitra Saxena, the organizing joint secretary, Dr. Renu Yadav and Dr. Surekha Yadav, and the secretary of the Rewari Society, Dr. Neeraj Yadav, for having me here. And also thank our dynamic president, Dr. Alpesh Gandhi, and Vice President Dr. Agni Agarwal, whom I have come to know and admire over the last couple of years very well, for coordinating the whole activity. So Dr. Mitra Saxena, actually, when she called me up, she said that I am supposed to speak on the timeline of the MTP Act and the new amendments. And when she told me that, I was immediately excited because this is something I believe that we don't focus enough on. And that is the time that is taken actually to draft these acts, to take opinions on these acts, and then bring these acts to fruition. I know that one of the major questions on people's mind is when will the new amendments become applicable? And I hope that during the course of this presentation, I will be able to answer that question. It's rather unfortunate that physicians, and particularly our specialty, I think our specialty is one of the most regulated specialty in medicine. If I look back at my nursing home practice, I know that I have to take something like 27 various licenses and permissions, some of them which are renewable every year to run my practice. And I think this kind of an attitude and the fact that we are not well informed about medical legal issues leads to us as physicians and obstetricians and gynecologists treating laws as obstacles to be overcome rather than something which will facilitate our life. It's something like this, what Hermione says in Harry Potter and the Deathly Hallows. I don't know how many of you are Harry Potter fans, but I'm a big fan. And when Scrimgeour asks Hermione, are you planning to follow a career in magical law, Miss Granger? She says, no, I'm not. I'm actually hoping to do some good in the world. So it's quite unfortunate really that, this is the kind of pervasive attitude that we have, which leads to us looking at acts, regulations, and laws as something like what Mark Twain said, a classic, something that everybody wants to have read and nobody wants to read. However, if there is somebody who is listening and is not read the MTP Act, I would strongly urge you to read it. According to me, the MTP Act is easily one of the most elegant pieces of legislature passed by our parliament. And that is really saying something. It is short, it is crisp, and it is empowering. And I hope that I will be able to convey why it is all these things in the presentation. If we are looking at the timeline of the MTP Act, the story actually begins in the British era when the British gave us the Indian Penal Code way back in 1860. We inherited this Victorian kind of a legal provision from the British, where there were two sections which essentially punished both the women who underwent an abortion as well as the physicians who provided the abortion. The incidence of unsafe abortion in the 50s, 60s, and even prior to that was extremely high. And so the government of that time decided to set up a committee to look up to stem the high maternal morbidity and mortality which was associated with illegal abortions. Many people feel that the MTP Act was actually brought in as a family planning measure, but that is not the truth. The MTP Act was actually brought in to reduce the maternal mortality and morbidity, and the Shantilal Shah committee was set up in 1964. And you will see in that picture that I have over there, this is actually a picture from the original Shantilal Shah committee report, which I managed to obtain from the Parliament archives. And you will see over there a representative of the Federation of Obstetricians and Gynecologists. So even at that time, FOGSI was represented for drafting the MTP Act. The committee was set up in 64. It gave its report in 66. The bill went through the Parliament in 69 and the Joint Select Committee review and finally passed as MTP Act in 71. This is again to illustrate the time it takes for an act to go through, even when the government wants to get this kind of an act passed. The second important thing in this slide is the last two lines, that it was legislated by the Parliament on August 10, 71, but was enforced nationwide on April 1, 1972. That is a clue as to when the new amendments to the MTP Act are going to come into effect. The next in the timeline is to understand that there is a difference between the Act, the rules, and the regulations. The Act essentially is passed by the Parliament. The rules are framed by the central government and are ratified by each house of the Parliament, but they in a sense work to explain the Act or bring the nitty-gritty of the Act down to the ground. And sometimes the changes in the rules are actually much more far-reaching than the Act itself. The regulations are framed by the state governments and relate to issues and relate only to issues involving opinions, reporting, and maintaining secrecy. So if your state government is passing something as a regulation, which is beyond this ambit, it's quite clearly overshooting its brief. Again, nothing much happened in terms of legislation till 2002. And that is actually when I started getting involved with the amendments to the MTP Act. I think the first meeting that I ever attended for amendments to the MTP Act was probably in 1998 or 1999. That is almost 3 decades back. And the result of those meetings was this wonderful MTP Act amendment of 2002. Again, see what I have highlighted in blue. The Act was declared, or the Gazette was published in 18 December 2002. It was then notified and became active on the 13th of June 2003, when the rules and regulations were also published. Again, a clue as to when the new amendments will start coming into action. A great example of what I said, that the rules sometimes are more important than the Act, came in these 2002 amendment rules, because it was the rules of 2002 which actually brought medical abortion into this country and made it legal. I know that medical abortion probably used to exist earlier, but it was the rules in 2002 which actually made it completely legal to do medical abortion in this country. Again, look at the time gap, since we are talking about timelines, between the notification from the Drug Controller of India, which came in 2006, and the rules which came in 2002 to 2003. Again, a clue as to when the new MTP Act amendments will be applicable. However, although it seems to be a simple act of administering pills, medical abortion pills actually have a complex regime which surrounds it. And that's why when you look at the timeline for the MTP Act, and also given the fact that the large majority of abortions occur by medical abortion, it is important to look at the acts which conflate to our MTP Act. Before that, however, I must say that second trimester abortions are still quite a major problem. And I'm very happy that this FOGSI ICOG GCPR that I had drafted in 2004, and I think at that time it was taken as the template for which all FOGSI guidelines should be drafted, is still quite relevant today. This is available on the website. It talks a lot about how medical abortion is to be used, how second trimester abortion is to be provided, etc. If you have not read it, I will strongly urge you to read it. The acts which conflate with the MTP Act, of course, are the PCPNDT Act. Despite the fact that there is very good data to show that large majority of second trimester abortions are not related to gender, the way the PCPNDT Act is implemented has made a vast difference to how women access abortions. And this seems to be an attitude. I will not say it's not fair, but at the same time, it's not something which is very desirable, where physicians say that it doesn't make any difference to my practice if I say no to provide an abortion, but it does make a great difference to my practice if I do an abortion and it turns out to be a female fetus. It is rather unfortunate. And this is despite the fact that we have presented data even during our petition to the Supreme Court to show that even after an analysis of lakhs and lakhs of F forms, not a single sex-selected abortion could either be prevented or detected. However, as it may, these are the important questions that we need to answer when we talk about the conflation of the MTP and PCPNDT Act. And I will refer you to a document which is easily available on the ministry website, which addresses all these conflations. The second act which causes a lot of confusion is POCSO. And the problem with POCSO really is the way it is drafted. It not only criminalizes all sexual activity below the age of 18, it also has this aid and abet clause, which makes us vulnerable to prosecution under POCSO. So in a sense, what the POCSO Act does is it adopts a protectionist approach and conflates adolescent sexuality with child sexual abuse. This has led to a lot of conflict and conflation, particularly in providing abortion to adolescents. If you look at our government website, you will see these two documents.
आया है क्या question chat box पे?
Dilip, you might have to mute yourself.
Q&A कहाँ पे है वो?
Dilip?
Chat के बाजू में है क्या? Okay.
Dilip, you might have to mute yourself.
Sorry.
No problem. So this has led to this conflict and conflation where on our government website, you have these two completely contrary documents. You have the POCSO Act, which criminalizes all sexual activity below 18, and you have the RKSK document, which actually says that adolescent sexuality has to be accepted and adolescents need contraception and they should be well informed about it. And therefore, I think it's imperative that we answer a few questions about this conflation. Does a provider have a legal duty to inform the authorities if a minor girl is pregnant? Absolutely yes. Even if the girl has not expressed a desire to take legal action, even if the girl is a married adolescent, and even if the girl's age is uncertain. How do you inform? On your letterhead, you have to write a note to the appropriate authority, in a large majority of cases, your local police station, which says that so-and-so age around so-and-so has come to me and is pregnant, and then take a received stamp on that particular note. Do you have to wait for a medico-legal procedure before performing the abortion? Quite clearly, no. You don't have to wait till the POCSO case runs to its conclusion. Once you have informed the local authorities, you can go ahead and provide the abortion. Do you have to preserve the products in these instances? The answer is quite clearly no, because we have a section of the Indian Penal Code where there is an element of intent And if you don't have the element of intent, which you don't do over here, then it is not considered to be a crime. So in terms of timelines, the MTP Act, the amendments to the MTP Act, but the way the PCPNDT Act and the POXO Act conflate, make it more difficult for us to provide abortion, particularly to adolescents. FOGSI and me have done a lot of advocacy around this issue, and this is an abstract from a report which is as yet unpublished. This is going to be published by the Jindal Global Law School, and they asked essentially my opinion on this conflations. And I have talked about how the narratives of the PCPNDT Act and the MTP Act have been shaped over the years to make providers more hesitant to provide these services. I was just thinking in terms of timeline, when did I attend the first meeting for amending this current MTP Act? And when I looked at my calendar and I searched, I found that you can see MTP Amendment Act meeting at the ministry on 6th October 2008. Actually, I have put the picture of the iPhone below because that is 2008 is when I got my first iPhone, and my calendar before that is not available to me electronically. But actually the first meeting I attended for amendments to the MTP Act was much before that. But this is just to illustrate about the time that it has taken for these amendments to come through. A lot of advocacy has been done. I have been quoted quite extensively in media on the need for the amendments to the MTP Act. And not only in the media, I have been quoted in law journals. A lot of several scientific articles have published my writings and so on. And I have also made a reference to the need for the acts in the International Journal of Obstetrics and Gynecology when I was a co-author for this article. And all this finally led to a parliamentary panel suggesting that abortions be allowed till 24 weeks of pregnancy, because as I told them in my presentation, the question of abortion shouldn't be an issue in the political arena. When a woman has to make this decision, she should see her doctor and not her lawyer. We had even visited the Prime Minister's office. We did not meet the Prime Minister, but we met the person who was in charge of health affairs at the Prime Minister's office. You can see over there, Dr. C.N. Purandare, Dr. Jaideep Malhotra, and myself standing outside the Prime Minister's office. And we conveyed to them that we urgently need all these amendments to come into the MTP Act to ensure that women are able to access abortion with dignity and safety. We were therefore extremely delighted when the MTP Act was presented and passed in the Lok Sabha. At that time, of course, it was passed only in the Lok Sabha. However, shortly after that, it was also passed in the Rajya Sabha. I don't know whether you can hear this clip, but you will see Dr. Harshvardhan ji mentioning FOGSI specifically when he was making the presentation to pass the MTP Act. And I think that's where FOGSI's name comes in. So that was a good moment. And over here, I would really like to acknowledge all our past Secretary Generals, all our past presidents, in particular the chairs of the MTP committee, starting from Nozar Shehryar to Atul Ganatra to Kiran to Shamal, and myself, who was also an MTP committee chair, and all our presidents, Secretary Generals. I think Hrishikesh is here, who have really, contributed to the fact that these amendments have been passed. So what do these new amendments say? I'll just go through them very briefly. The writing in orange are the amendments of 2002, and the writing in red are the amendments of 2020. So the new amendments essentially constitute a medical board. They bring medical abortion into the ambit of the MTP Act. They essentially say that for abortions between 12 and 20 weeks, from the requirement of 2 providers, it comes down to a requirement of 1 provider. For 20 to 24 weeks, you will still need 2 providers' opinion. However, the indications for providing abortion between 20 and 24 weeks will be framed under the rules. It also removes that provision of married for use of the failure of contraception clause, and it extends the limit of gestational age to 24 weeks when a pregnancy has been caused by rape. These are all the other amendments. I'm running short of time, so I'm not going to go into the details of it, but they essentially allow or they focus around how the act will be implemented. I'm very happy to say that I had written an opinion piece for the Government of India on the amendments to the MTP Act, and this has been issued as a press release, and a lot of embassies all over the world. You can see Algiers, Lusaka, Zambia, Mali. It's been covered in a lot of international newspapers. And again, this opinion piece is available on the internet. If you could please read it, I will be very happy to also receive your inputs on this. This has also been published in so many other embassy websites, the UK, Greece, European Union, and so on and so forth. I know that a lot of people are unhappy by saying that the amendments to the MTP Act don't go far enough, but I would really like to to differ with them. Our Prime Minister recently mentioned some chronically unsatisfied people and so on and so forth. I'm not getting into the politics of this, but I think it's high time that we step back. We say that, all right, maybe it didn't go far enough, but at least it went somewhere. And I think that it by itself is a credit really to not only the government, but also to everybody who worked for the MTP Act. The rules are, I think, in the process of being framed. And recently I had the privilege of drafting the SOP for MTP beyond 20 weeks. And the government of Maharashtra has accepted this. And one landmark thing that has been accepted is that if there is a pregnancy beyond 24 weeks, which needs to be terminated, these guidelines talk about, and I sort of sneaked it in over here. These guidelines allow for KCL injection into the fetal heart to take care of that tricky problem of a late MTP fetus being born alive. And I think this is a really, if the Government of India accepts it, it will really be a landmark because it will mean that the government accepts feticide as a legitimate procedure. So to answer the question, when will the MTP Act amendments come into force? Again, as I said, the clues are here. The original act legislated on August 10, 71, enforced on April 1, 72. The MTP Act amendments came on 18 December 2002, started being implemented on 18 June 2003. So if you look at the current Gazette, which is the last one, it simply talks about informing. It doesn't talk about the act coming into force. So mind you, as of now, these amendments, although passed by the Parliament, still have to be notified as for a date on which they will become active. So as of now, we are operating under the old MTP Act. Although the MTP Act has been passed in Parliament, normally the rules and regulations will get framed, and once they get framed, the act will come into effect. So as of now, if you have a woman who comes to you beyond 20 weeks of gestation, you still need to follow the current procedure of going to the High Court, etc. It is not come into action as of now. However, we know, and we write really, really great policies. The problem is implementing on the ground, and the road from policy to implementation is really tortuous. It's very ironic because, it has been acknowledged worldwide that almost all abortion-related deaths are preventable. And in fact, when abortion is performed by qualified people using correct techniques and sanitary conditions, it's one of the safest medical procedures. It's therefore all the more ironic that women all over the world and even in India to this day are dying from unsafe abortion. Ladies and gentlemen, we have an imperative need to make abortion safe. The amendment will help us, and we need to act on this now because at the end of the day, history is her story too. Thank you very much.
I want to make just one comment. Dr. Jaydeep, I loved your quote of Mark Twain that a classic everybody wants to read, but nobody reads. But today you made sure that 230 of us sits spellbound and hear this classic story. Thank you so much.
Thank you.
Dr. Achla, please conclude the session.
Jaydeep sir, fantastic talk. And
it's a pleasure to conclude Jaydeep Tang's lecture because he is always so crisp. And the saying in between, they're really very good. I would want to know the source, And he takes so much effort to make the lecture which is given to him, which shows in what he has said. And I think the bottom line is that though the amendments have been made, but we have to be patient. Don't start jumping. Yes, you can do it. That must be remembered by us all. And I'm sure the FOGSI advocacy, which has become very strong now, we will be able to roll it in sooner than which was done earlier, 5 years after the 71 amendments. And so we are hoping for that from FOGSI. And we are all FOGSI, actually. We will all advocate it. And excellent topic.
Thank you, ma'am. Thank you very much.
Thank you. Thank you. Thank you, Jaideep sir. Amazing talk as always, and very good, because we were thinking that the FOGSI is doing so much for each and every member. Each and every member has to understand this. I mean, you have presented it in 15 minutes, but I am so sure hours and hours of efforts must have gone into, even if somebody has to draft a 4-line, introduction to something, it
Manish,
takes hours
years
and hours
and
of
years.
study.
Years
Yeah, so all the effort has come today, and we are now getting the new amended act for us to make our practice better. So thank you, sir, for all your efforts, and thank you, FOGSI. Long live FOGSI. Superb.
Thank you. Thank you, Manish. Thank you. Thank you.
Over to you, Suman, for the session 2.
Good morning, everyone. I, Dr. Suman Yadav, on behalf of Rewari Obs Gyn, welcomes you all in this North Zone Ethic Medical Legal Conference for our session segment. We'll be inviting our respected and eminent chairpersons and speakers for discussing a very important topic which will educate the masses, medical fraternity and delegates regarding various medical legal aspects of clinical practice like documentation, insurance. So I invite our first esteemed chairperson, Dr. Girija Wagh. Excellent teacher and person, has been Vice President of India Chapter Justosis since 2014, Chairperson of Medical Disorders in Pregnancy Committee FOGSI since 2012 to 16, has been awarded with the Anandibai Joshi Award for her excellence in medical services. Ma'am, my heartfelt greetings to join us from Pune for this session. Second, I invite our second esteemed guest, Dr.
Dr. Mitra, I think you have to take over.
Okay. I don't know, there may be some
Savita
connectivity.
Vast experience in teaching experiences. We all in Rewari had a pleasure to hear her at one awesome. Ma'am, we welcome you all for this. We welcome you all for this live session too. Thirdly, I will invite our own current president of Rewari Obs Gyn Society, Dr. Surekha Yadav. She holds a special interest in gynec surgeries and has done nearly 10,000 NDVH in her past 15 years of medical services. Along with a competent surgeon and beautiful personality, she is a very humble and helping person. Welcome, ma'am. We welcome you for this. Now, coming to this second session, I would like to invite our first speaker, none other than Dr. Gitendra Sharma. He has been the chairperson of Ethic and Medical Legal Committee FOGSI 2017 to 19, Vice President-elect 2022 FOGSI, President of AOGS Committee 2016-17, hosted AICOG in January 2017. Sir has authored many books, which includes Law in Obs and Gynae, Consent in Obs and Gynae, Law a Doctor Must Know. So he'll be guiding us and elaborating us on documentation. Sir, over to you. Dr. Gitendra Sharma, sir, over to you.
I think before Dr. Gitendra Sharma logs in, good morning to everybody. Thank you, Dr. Mitra, Saxena, and Dr. Arti Agarwal for having me here. And I must congratulate Dr. Jaideep Tang for whatever he delivered on MTP Acts. And I'm going to write on FOGSI Friends. So I'll send you all a link of what I'm going to write about it. And I think Dr. Gitendra is going to be speaking about a very, very important topic. And our friendship, Dr. Mitra, goes back to the first medical legal conference that we had in Pune, if you remember. And that was the first time you were introduced to me as a person who is so ardent and meticulous about her clinical practice. Thank you, and move on to Dr. Gitendra. We are waiting to listen to you.
Does Dr. Gitendra have a challenge, Dr. Mitra, in connecting?
Sorry?
Dr.
Gitendra sir, you need to unmute.
Gitendra sir needs to unmute himself and yeah.
Can't hear.
Ma'am, he's already unmuted, but the problem is his internet connection, I believe.
Dr. Gitendra, we are not able to hear you. No, he's trying to say something, but he's not audible.
I think he should move out and then re-log in. If you can hear me, then please leave the meeting and then re-log in because we can't hear.
Okay, till the time he logs in again, fantastic talks since morning. I hope everybody, getting all sorts of inputs to improve their practice. And the opening batsmen and all the opening faculties have had fantastic talks. And I hope that all of you have received, and all those who haven't, please let us know. We will see that the newsletter that we released yesterday will reach everyone, and good contributions from all over India. I'm very happy that this North Zone Ethics Medico-Legal Committee event hosted by Rewari is going on very well. Sir, yes sir, Gitendra, are you there? Sir, somehow we can't hear you. That's the problem.
Amit, will you please help Dr. Gitendra?
In the meantime, Mr. Amit, while you are helping Dr. Gitendra, shall we go ahead with the second talk?
Yeah, I think we can start with the second talk.
Dr. Rahul, I can see, has logged in.
Yeah.
Can
So
you hear me?
yes, Rahul.
Yeah. So shall I start my presentation?
Please introduce Dr. Rahul.
Moving to our second speaker, we all are so scared of medical litigations, how to get insured ourselves. So we keep ourselves updated with everything, but there are certain final points which we should know, and for this I will welcome Dr. Rahul Vani sir, President Navi Mumbai Obstetric and Gynecological Society, Honorable Consultant, Mathari Hospital Trust. He has been a lead assessor in Manyata project. Over to you, sir, for the same.
I'll start my share screen.
Am I audible now?
Yes, sir, you are. Thank you. Yes, Dr. Gitendra, you are audible.
Okay, madam. Thank you.
Shall I continue with my presentation?
Yeah, continue, Rahul.
Gitendra sir, we'll just finish Dr. Rahul's presentation.
Yeah, sure.
Okay, thank you, sir. Thank you so much.
Thank you for the introduction. My topic today is practicing safely, insurance company, everything you should know before you tie the knot. शादी करने से पहले सब कुछ परखा जाए और उसी के बाद माला पहनाई जाए. तो कोई भी इंश्योरेंस कंपनी से प्रोडक्ट लेने से पहले उसके बारे में टोटली जाना जाए और फिर बाद में आगे बढ़ा जाए. So as Dr. Mitra has specifically told me, keep it very simple and keep it brief so that everybody understands. So these are the points I'm going to cover. What is indemnity insurance? Why should we have indemnity insurance? How much cover should we have? What is covered? What is not covered? What should we look for in the policy? And whether we should go for an individual or a group policy? And how do you claim in case there is a case against you? So what is indemnity insurance? Indemnity insurance is a liability insurance. So what does this mean? As practicing professionals, when we practice, we are liable for medical negligence cases. So if something goes wrong, there is a complication, a patient files a suit against you. So in case of a medical case is filed against you, if you have an indemnity insurance, the insurance company will pay for the compensation. If compensation is awarded against you, depending upon the cover you have. If you have a cover of say 10 lakhs, the maximum insurance company will pay is around 10 lakhs. If you have a cover of 20 lakhs, the maximum insurance company can pay is up to 20 lakhs. So depending on what cover you have, the indemnity insurance will cover you. Now, why should we have professional indemnity? Now, a survey conducted by the National Law University, Bangalore in 2016 said there were 400% rise in litigations against doctors in a period of around 1 year. The Times of India recently quoted there is a 110% increase in cases. Now, compensation awarded is uncertain. You may say, no, what if there is a compensation awarded, I will pay it off. I don't need insurance. But compensation awarded is an uncertain, and in some cases it could be in crores. Even if a case is frivolous, you may end up paying in lakhs as lawyers' fees. So that is why it is important to have a indemnity insurance. Now, how much cover should we have? A compensation awarded does not depend on your earnings. It does not depend on what is your practice or how much you are earning. It is based on how much your patient was earning, the potential active years of the patient who was earning, the potential increments in the earning, the mental agony and sufferings of the family, loss of companionship, and there are various other factors which the court will go into before deciding the compensation. Whether the patient is permanently disabled, the medical treatment the patient will require over the years, the attendant the patient will require over the years. So there are various factors which the court will go into, and the compensation is not dependent on what you are earning. In famous case of Kunal Saha, the compensation awarded went up to 11 crores. So the compensation amount plus the interest from where the case was filed till the case was decided, the interest amount was approximately around 4 to 5 crores. Difficult to ascertain the amount of cover we should have, but as individuals, we should have at least a minimum cover of 1 crore. And if you are running an hospital, the hospital should have a minimum cover of at least 2 to 5 crores. If you have a high case load, you should have a higher cover, because more the patient load you cover, more is the possibility that a patient will sue against you in case of complications or if something goes wrong. Now, indemnity for establishment and personal. Now, when we talk about indemnity insurance, there are two separate insurance, where it covers one individual as a doctor and where it covers an hospital. So if you have, say, a hospital or establishment errors and omissions policy, it will cover you for the hospital which has the establishment or which has the indemnity cover. Suppose I am running my own hospital and I have only that establishment errors and omissions policy, then it will cover me for my medical negligence only in that hospital. Now, suppose I go and operate somewhere else, or if I go to help someone in an emergency and a medical legal case arises from there and a case is filed against me also, then I will not be covered under that indemnity. If I have only an establishment policy or which covers me only for that hospital. So it is important to have an individual insurance cover which covers you for all, wherever you are practicing, in wherever you go, and an establishment policy which will cover your staff and the other people visiting consultants in your hospital. So it is important to have both the insurances. Now, what is covered? Generally, when you buy an insurance company, you should look for all these things. What is covered in that policy? Whether the defense cost means from the time when the case is filed, replying to the legal notice, your advocate fees will appear for you in the court, and then the final compensation which is awarded. But all these should be covered. Third-party damages, breach of confidentiality, libel and slander. These are medical legal words. Some policies will cover this, some policies will not cover. Loss of documents, the claims arising out of professional services, bodily injury, death, all this is usually covered by the policy. Now, recently, the FOGSI leadership has changed the indemnity insurance, which all the FOGSI members they have changed to the ICICI Lombard General Insurance Company for Professional Indemnity. And I think this is one of a very important change and a good policy for all the FOGSI members, because it has 80% less premium from market. There are medical legal lawyers in its board, senior doctors on its board. There is cashless compensation. It covers loss of documents, covers breach of confidentiality, it covers defamation, it covers dishonesty from profession, and most importantly, defense cost for criminal cases is covered in this policy, which new policy the ICICI Lombard is offering. It covers qualified and unqualified staff. It covers visiting consultants. And there is a provision for out-of-court settlement in this policy. So I think our FOGSI leadership has done a very good job in changing the policy which we had earlier. And this policy is also covering your retroactive date. So if you have a FOGSI indemnity policy and you take this policy now, it will cover you right from the date when you started this indemnity policy. Now, what is not covered? What is not covered in an insurance policy is the medical treatment for weight loss, plastic surgeries, genetic damages, conditions associated with AIDS. Your criminal acts are not covered. Penalties, fines, punitive actions, and damages which are given under criminal laws are not covered under your indemnity insurance. Intentional non-compliance or willful neglect, deliberate acts is not covered. Your loss of goodwill, if there's defamation because of a case against you and you lose your practice, then the loss of goodwill is not covered under this. Medical practice done under the influence of alcohol or narcotics will not, the indemnity insurance will not cover this. Any contractual liability, if you have a contract with some provider or some housekeeping, this contract liability will not be covered under indemnity insurance. Blood banks are usually not covered under indemnity insurance. Now, this is a very important concept to understand. AOA versus AOY, any one accident and any 1 year. So professional indemnity basically is for a year, and an accident occurring in that period of year is covered. So there are certain terms in this which you should understand. The sum assured refers to the limit of indemnity. That means if you are covered for 1 crore, it means that is the sum assured that you will get. The limit is fixed per accident and per policy period. And ratios can be chosen from 1:1 to 1:4. Now, this is what I would like to explain. A ratio of 1:1 means if you have a policy of 1 crore, if any case arises against you, if the ratio is 1:1, the whole sum assured will be available for you for that case. Now, suppose if you have a 1 crore policy and the compensation awarded against that case is around, say, 15 lakhs, then that 15 lakhs will be awarded, and the rest of the 85 lakhs will be still available if there is one more case in the same year. But if you take a ratio of, say, 1:1 or 1:3, that means your sum assured will get divided into 2 or it will get divided into 3. That means for every case which comes in against you in that year, if the policy is 1:2 ratio, that means out of the 1 crore, only 50 lakhs will be available for that case. So if your compensation goes beyond 50 lakhs, the insurance company will give 50 lakhs and the rest of the money you will have to shell out. So it is important that you choose a ratio of 1:1. And if you choose a higher ratio, the sum assured will get divided into according to the ratio you choose. Retroactive date. Now this is very important. Now date from which the policy is active. So the first policy which you had taken, the date from which it has become active, every year when you renew, the retroactive date remains the same, the first policy. So you have to timely renew the policy. If you are late in renewing the policy, the retroactive date might change and it might come to the new policy which you have taken if you have been delayed. Now, if you are changing an insurance company, you have to see that the cover is from your previous retroactive date. You have to negotiate with the new insurance company, ask them to cover you from the retroactive date. Maybe you will have to pay a little more premium to cover yourself from the retroactive date. The policy should be in force when the incident occurred. Means suppose you are in 2021 now and a case is filed against you in a case which you had handled in 2016. So your policy should have been in force in 2016 and your policy should be in force when it has come into action also. So what should you look for in the policy? Now you should, as I told you, what is covered, what is not covered, you should look into all these things. You have to look in different policies which gives you a better coverage and what all is covered. Important things to note is whether your unqualified staff is covered, It allows you to choose your own lawyer. Sometimes these insurance companies have their fixed panel and they do not allow you to choose your own lawyer. So whether this policy allows you to choose your own lawyer and whether there is a provision for out-of-court settlement. So rest of the policies usually are the same, but compare the policies for their premiums and the coverage they give you. As I mentioned earlier, the new ICICI policy is very good. You check at the track record of the company. That is the claim settlement record. Whether the claim settlement is high. If there are certain, say 100 claims, they have settled almost 95 to 96 claims. If that track record is poor, so out of 100 cases, they settle only 60 claims, then that means that company is not good for insurance. Now, whether to buy an individual or group policy. Now, it is always better to go for a group policy of your association. Advantages are, it is already bargained. There is a bargaining power. If something goes wrong, the association will be there to fight with you. The terms have already been negotiated when it is an association policy or a group policy. Now, if company defaults on the claim, it can be fought collectively. So it is better always to go for a group policy, and the current FOGSI leadership has done a good job with the ICICI Lombard for a very, very comprehensive coverage. Now, how to claim? As soon as you anticipate a medical legal problem, some patient has threatened you to go into court or something like this, intimate the insurance company in writing and take an acknowledgement. Once you receive a legal notice, inform the insurance company and take a case number. This is very important. You inform the case and take them a reporting number or a case number so that they cannot deny later. Complete the claim form. There is a claim form which the company will provide. Fill in the claim form, give the copies of legal notice, the court correspondence, and you also give them the estimate of legal fees, the fees the lawyer is going to charge, and get it approved from them. Thank you. This is all about indemnity insurance. I kept it very brief and very simple so that everybody understands. Thank you.
And you've stuck to time also. Thank you so much, Dr. Rahul. Dr. Girija, your comments, please. Dr. Girija?
Unmute.
Dr. Savita, Dr. Girija, please unmute.
Hello, very good afternoon to all. At the outset, I'd like to thank Dr. Mitra, Saxena and the Rewari team for giving me this opportunity. And it is a very excellent talk since morning. I am listening, Dr. Narendra Malhotra, Dr. Jaydeep Tank, and I thank you, Dr. Vani, and he has very well explained about the indemnity insurance. I think insurance is a need of the hour. I think all the private practitioners, the big hospitals can't work without this insurance. And he has already told this hospital indemnity scheme. Ideally, I think the insurance should be in such a way so as to cover also the non-medical persons, as he has told. And it should be very, very important. He told it should be from the day of the last insurance, because sometimes you don't know, in between some case comes. Suppose your insurance was still in March and new insurance starts from the May. And if some case is filed in April, so all thing is gone. So it should be back to back from the previous date. And I thank you, Dr. Vani, for the excellent presentation.
I just want to add, Dr. Rahul Vani, you spoke so very well, and very important message that you posted was that we have to be up to date, like our car insurances. It's important that we look at our practice insurances, and maybe we can use some mediums like the Google Calendar or something which can remind us about the date so that we do not fall in the middle of nowhere when we have challenges. Thank you for a very, very crisp talk.
Thank you.
Thank you.
Dr. Gitendra?
One thing I just want to ask from Dr. Vani, what about this cashless insurance? What do you think, what is better? Because all the patients usually are willing for cashless nowadays. So if cashless insurance is there, then all the documents, I think, have to be filed by the hospital. Can you give some opinion on these?
So when you are dealing with this insurance company and providing cashless this to patients, then you have to have a separate department who will follow up with these companies, because initially they will promise that they are going to pay the bill, and then later on there are deductions, And so I had started cashless, then I stopped it because it was difficult to follow.
So that's so please highlight what are the things to be seen by the institute or the hospital once you are landing for the cashless. Because most of the hospitals are providing cashless, and even the patients or users are willing for cash. They will just offer for the cashless only. They will not go for the reimbursement. But reimbursement takes so much of documents to be written, and they don't know, the user don't know at the end how much it will be reimbursed. Just like you're telling, it may be 70%, 80%, and they may say that this disease is not reimbursable or will not reimburse for this thing. So most of the users are willing for cashless. So what the institute has to be seen particular when they are applying for the cashless policies.
You should have a dedicated after insurance, and you should have a good lawyer backup who will fight if your money doesn't come.
Okay, thank you, Dr. Rahul. And before Gitendra sir starts, I have to say this. Dr. Gitendra is one of the most learned. I think he would know law more than lawyers. So trust me, I have been with him in his committee as national coordinator, not only about law, but about so many things that I have learned from Dr. Gitendra sir. And now he is our vice president elect of FOGSI. I hope if the team changes, I get some time to work with him as a chairperson also. So thank you, sir, for encouraging me, always making me national coordinator when you were the chairperson, and so much to learn from you always. Sir, please welcome.
Good morning, everybody. And at the outset, I would like to thank Ethics and Medical Legal Committee Chair Manish Machave sir for giving me this opportunity, along with Dr. Mitra Saxena madam and Rewari Obstetric and Gynecological Society. I am going to give your eyes the rest, because I am not going to show any PPT. And the subject given to me is documentation. Good documentation is good defense. Poor documentation is poor defense. This is the topic of talk today. So if we deal with the documentation, I think the whole day will be less. So I will only quote a few 2-3 cases which will enlighten the importance of documentation. And I will also like to acknowledge that what is the good documentation and what is bad documentation or poor documentation. See, going to the definition of document, we can go to Indian Evidence Act or Indian Penal Code, where it is defined what is document. But I am not going into intricacies of the definition as it was there in the Three Idiots. The definition of machine was so complicated that nobody could understand. So in the similar way, I will only define the thing in a simple manner, that something which can be produced in the court of law as an evidence, in your case, is a document. So that is the simple definition. So anything which you can produce in the court of law in your defense, that is as an evidence, that is known as document. It may be in writing, it may be figure, it may be printed something, or whatever it is. It may be CD, it may be audio cassette, whatever it is. So we all know that medical documentation is the tedious job for a medical practitioner, but there cannot be any excuse under law. The reason, because that is the only weapon in our hand in the court of law. So why this is necessary? We all know why documentation is necessary. So we all know that it is said by Justice Bhagwati in one of the case that courts are not the courts of justice, they are courts of evidences. So whatever you put forward in front of the court as an evidence, court will look into it and give the decision, give the award. That may be justice or that may not be justice. So if your documentation is good, if you put forward your documentation in a good manner in the court of law, definitely you will get justice. But if you will not put forward your case in the court of law properly, then you may not get justice. Although you may not have done anything wrong to the patient, but you may not get the justice. So, dear friends, what is the meaning of document and what kind of documents you should have? Document does not mean only case paper. Document can be medical documents and can be non-medical documents. What is the document related to patient? So we all know that OPD case paper is related to patient, indoor case paper that is related to the patient, and a few documents which are not patient related, but they are hospital related. What are those? So hospital related medical documents are different registers. See, we are supposed to keep different register, indoor case register, outdoor case register, operation theatre register, autoclave register, fumigation register, MTP register, PCPNDT registers, and many more. Birth and death register. So many more registers are to be kept. These are the medical registers. And we all know that more than 100 different kinds of acts are applicable on a hospital. So we have to keep all the documents related to all those acts also ready in our hospital. So today we are going to discuss only regarding our case paper. We are not going to discuss about the medical records or registers and all that. The question comes in our mind that what is a good documentation? We all say that good documentation is a good defense and poor documentation is poor defense. So what is the meaning of good defense? Good documentation. Good documents means the document which should be accurate. Accurate means what? Accurate means everywhere the person responsible should sign. Proper date and time should be put. You should not use abbreviations which are not universally acceptable.
Sir, sorry to interrupt, sir. There is no presentation.
Yeah, there is no presentation at all.
Okay.
Then you should not try to alter anything. So you should not apply white ink. So I cannot give in 18 minutes the names of the case which are decided by National Commission or Supreme Court regarding all these things. But whatever I am speaking, everything is decided by either National Commission or Supreme Court, and relevant cases are available. So your document should be accurate. It should be complete. Complete means it should start from registration form, admission consent, history taking, examination, provisional diagnosis, history, provisional diagnosis, then investigation, final diagnosis, plan of treatment, and pre-op, per-op, and post-op treatment sheets, nursing charts, up to discharge card with all kinds of annexer. So all the things should be completely perfect in your case paper. And your case paper should be legible. Something which is not legible will not be taken as an evidence in the court of law. It is said in the D.H. Kumari's case that something which is not legible, so whatever you write, if your handwriting is not legible to the court, then it will be considered that you have not written anything. So the handwriting of doctor, we all know that what kind of it is. So only pharmacists can read that. So we have to improve our handwriting, or we can take help of electronics media and we can keep our record in electrical medical record system. We can keep our record in handwritten form also. We can keep it in EMR system, that is electronic medical record system. We can keep up with us as a hard copy. We can keep a scanned copy of case paper, or we can keep it in our computerized program. Anywhere you want to keep, you can keep, but our record should be accurate, it should be complete, and it should be legible. So if your record is accurate, now what is the meaning of complete? We will start from registration form. See, we usually go for the audit, medical legal audit in different hospitals. And when we go to audit, we find many mistakes done by our colleague. In registration form, see, it is necessary that identity of a patient should come in registration form. Name should be complete. Suppose patient is only Suman. In one of the case, that was the case of Suman versus Government Hospital, Chandigarh. In that case, the name of the patient was written only Suman, and there were 3 Suman in a similar ward. All 3 required blood, and blood got exchanged. So you should write the complete name of the patient. Identification mark should be mentioned, or photograph should be put. So identity is the duty of hospital to prove that for which patient treatment was given. And sometimes when patients are from the foreign countries, the detail of the visa and passports are to be mentioned in the registration form. So we are doing some kind of mistakes. Nobody is writing ID marks, which is mandatory as per law. Many of us are writing short names, and we are not writing details of the foreign patients in our registration form. Regarding chief complaint, see, in indoor case, it is always advisable to take a separate admission consent. Many of us are not taking admission consent. So it is always advisable to take admission consent at the time of admission. In chief complaint, when we go for audit, we find that most of our colleagues write in chief complaint primary infertility or secondary infertility. That is not acceptable in court. See, this is a diagnosis. This is not a complaint. So complaint should be written in the language of patient herself, and it should be mentioned in the format of OPD, that is origin, duration, and progress. So whatever is the old complaint should be mentioned first, and what is the new complaint should be mentioned later on. In history taking, we all know that what mistake we do. We are writing short history. See, in the case of D.H. Kumari, obstetric history was not taken properly. And what was missed? Patient did not give, or doctor did not ask from the patient that was there any incidents in last delivery, and actually that patient had history of PPH in first delivery, and doctor did not make arrangements at the time of delivery for blood transfusion, and doctor was held negligent for not keeping blood ready and for not taking proper history even of first delivery. So obstetric history, menstrual history should be written in details, not in short. Second thing, negative histories must be documented. If you want to take proper history, you must document that no history of diabetes mellitus, hypertension, heart disease, tuberculosis, or allergy. So that kind of negative history means you have asked the patient and patient has given no history. So that means it is not your fault if patient suppresses the material or suppresses the history. So history should be taken and documented properly. When we go for examination, we all know that we are writing PS NAD, PV NAD. Okay, you know, recently decided case that was the Rishabh Sharma versus Indraprasth Hospital, Delhi. In that case, it is mentioned that whatever findings are there, whatever examination you have done, you must document it properly. Suppose for retinopathy for prematurity, if you have done the fundoscopy, you have to mention that by which particular instrument you have done the fundoscopy and what are your findings. What are the status of peripheral vasculature? What is the status of cornea or retina or whatever it is? So you have to document it properly. So in the same way, when you write PV, you cannot write NAD. You have to write in details uterus anteverted or inverted, normal size, smaller than normal size or bigger than normal size, whether fornix is clear, tender, movement is there or not, mobile or immobile. So you have to write in detail uterus anteverted, normal size, form, mobile, fornix is clear, like that. That will be acceptable by the code. But if you have written NAD, that will not be acceptable by the code. So we have to be cautious in writing the document. We have seen that we are not writing in routine provisional diagnosis. It is must to write provisional diagnosis in our case paper. Second, next to it is the investigation. Investigations are of three types. First, the mandatory investigation. Suppose you are going to do some operation for minor surgery or major surgery, then minor profile and major profile should be done. Second type of investigations, the investigations which patient brings to you. And if you consider those investigations in diagnosing a particular disease, then you have to add it in your case paper. And last but not least, the investigation to confirm your provisional diagnosis into a final diagnosis. So your investigation should be justified according to your provisional diagnosis. You cannot do at random investigations. Over investigation and under investigations both are negligence as per law. So you have to be cautious. We have seen that in many of the road traffic accident where there is no complaint of head injury. In many corporate hospitals, they, as their own policy, do CT scan of head, which is not indicated at all. So these kind of policies should be changed and investigation should be justified. And whatever investigations are done, you must note the report of that investigation in your case paper. You may have annexed the report, but you have to write it in your case paper, and that will be a good document. After that, you have to reach the final diagnosis. Once you write the final diagnosis, you have to decide the plan of treatment. And after taking decision of plan of treatment, you have to do the counseling. There are three kinds of counseling. One is medical counseling. In medical counseling, we have to explain to the patient that what is the diagnosis, what is the plan of treatment, what is the purpose of treatment, what are the alternatives available, what are the risks of that procedure, what are the success rate, what are the failure rates, and what if you will not undergo this treatment. So all the things are to be explained. Second thing, financial counseling. It is must now. We all know in Clinical Establishment Act, there is a provision that overcharging is a negligence or will be regarded as deficiency of services. So you cannot charge more than you have written in the counseling. So financial counseling should be done in writing, and it should be documented in writing that what you have explained to the patient. Suppose you are giving something in package, then you should write that what is included in package and what is not included in package. It should be absolutely clear so that later on you may not be held in any problem. Psychological counseling, if required, then we have to take proper counseling. Consent, Dr. Narendra Malhotra sir has very well explained what is consent. So consent should be taken if you are going to do any kind of surgery. We all know that we are taking consent. Recent judgment of Vinod Khanna versus RG Stone Hospital of Delhi that has shattered us. In that judgment, National Commission has mentioned that pre-printed uniform consent will be considered as arbitrariness and high-handedness on the part of doctor, and that will not be considered, and that is unfair trade practice. And 10 lakhs rupees compensation was 10 lakhs are to be deposited by RG Stone Hospital in the legal aid of National Commission. Although patient has never told the court that the doctor has not taken consent, but uniform consent. See, we used to use in our case, in most of the clinic, we are using single paper, single printed paper. That is common for all the surgeries, and we keep blanks in between. And those blanks we do not bother to fill at the time of taking consent. In the case of Jaipal Reddy versus Dr. Padmini Velluri, that was Yashoda Group of Hospital, Hyderabad. In that case, perfect consent was taken by the doctor. Diagnosis was written as endometriosis, treatment was written as hysterectomy, and a signature of patient and doctor was there with witness. But in between gaps in which alternatives was to be mentioned, the risks are to be mentioned, were left blank. And in that consent, in that case, National Commission gave the decision that consent is not a mere paper on which the relative should sign or the patient should sign, but consent is the documentation of counseling and communication done to the patient. So whatever you have counseled to the patient, whatever you have communicated to the patient, when you document it, it becomes consent. So consent should be elaborative. It should include all the adequate information which is required to be given to the patient. We have seen that in pre-operative orders are not mentioned in our case paper. We give chit to the patient, but we don't give orders in writing. In case paper, there is no writing. And when it is not documented in your case paper, pre-operative orders, it is considered deficiency. So that is not a good record. Next to it, when we go to pre-operative anesthetic checkup and anesthetic report, in pre-anesthetic checkup, anesthetics are not taking history. They are not mentioning investigation, which they have considered while giving anesthesia. So these are things which are considered incomplete. And sometimes there is discrepancy in history taking by the anesthetist and by the surgeon. Whenever there is discrepancy in your case paper, that will go against you. In post-operative treatment sheet, we should keep in our mind that every doctor who examine the patient should write in or his or her handwriting all the examination findings, and he should sign with date and time at a proper place. See, we cannot write something in the place of date and time. We cannot write the examination finding. It should be at a proper place. Otherwise, court will presume that this is added later on. In many of the consent paper, we have found that something is written horizontally and something is written in a vertical manner. So court will always presume that these all things are added later on, and that presumption will go against you. Last but not least, we have seen that nursing charts and this medication charts sometimes are not being prepared. TPR, BP chart, input-output chart, these are not maintained properly in our hospital. And in one of the case, we all know that was the case of D.H. Kumari's case, in which nursing chart was not prepared and not added. So it was considered that your document is not a good document and compensation was awarded against doctor. Whenever we discuss documentation, we always discuss discharge summary. You are bound to give discharge summary to the patient in all cases, whether it is DAMA discharge, whether it is DAR discharge, whether it is a simple discharge. And discharge...
Sorry, sir, to interrupt you. Sir, we need to conclude. We are running a little short of time.
Okay, madam. Can I have 1 or 2 minutes or?
Sure, sure.
Okay. So discharge summary is a mirror image or reflection of your case paper. We have noted that something which is nowhere in the case paper is reflected in discharge summary, and that is not proper. You cannot write anything more than your case paper in the discharge summary, and follow-up guidelines should be given in details. Last but not least, I will mention, I cannot conclude without mentioning 2 cases on documentation. First, we all know the case of Malay Kumar Ganguly versus S. Mukherjee. That was the case in which 11 crore rupees compensation was given against Amri Hospital, Calcutta. In that case, patient remained in Amri Hospital for 6 days, from 11th May to 17th May. And when they asked for the case paper, the Amri Hospital provided 22 pages, simple 22 pages, and that included only the simple, there was no nursing note, there was no medication chart in that. And that patient remained admitted in Bridge Candy Hospital, Mumbai from 18th to 27th. On 28th, she died. So for 10 days, she remained in Bridge Candy Hospital, and the indoor case paper of Bridge Candy Hospital was containing 370 pages. So dear friends, Dr. Udwadia, who treated the patient in Bridge Candy Hospital, mentioned everything in details. He mentioned that Dr. Saha himself is a surgeon, his brother is also a surgeon, they are interfering in the treatment, they are forcing me to start quinolone, they are forcing me to give erythropoietin, they are forcing me to give intravenous treatment, this nutrition, which I don't feel proper for the patient. Whatever they are abusing the staff member was also mentioned in the case paper of Bridge Candy. And if you go through the judgment, you will find that the documentation of Bridge Candy was such that ultimately they have to take decision to drop the Bridge Candy Hospital from the party. Otherwise, they could not have won the case. And they only prosecuted the Amri Hospital. And the judgment of 11 crore was mainly dependent upon the non-proper documentation. So, in conclusion, I would like to say that good documentation is good defense, no documentation is no defense, and poor documentation is poor defense. Documentation does not only show that how I can say perfect you are in your treatment, but that will always show the quality of the care. So if your documentation is good, it proves that the quality of care of the patient in your hospital is perfect. Thank you very much.
Thank you, Dr. Gitendra. Thank you for that very, very elaborate talk. And I think all of us should learn a lesson and a message from him, that even if anything is coming to your mind when you're looking at your clinical practice patients, please write it on the paper in a proper format. And thank you, Dr. Gitendra, for giving us these wonderful insights, because finally your empathy, your care, your attention to the patient has to reflect. And I think we can move on to the third talk.
I just, though we are running short of time, thank you, Dr. Jitendra, for excellent presentation. I want to just add one point about the name. In name, as you were told, the real name should be written, but we come across nowadays that once the obstetric patient comes for delivery, when the attendant comes, they say the mother will come, write the name Rinki. But afterwards, we come to know the name in the Aadhaar card is someone else. So there's a lot of problem with the birth certificate. So at the entry of the patient, the hospital name as on the Aadhaar card or ID should be written for everyone. It might be gynae patient, it may be obstetric patient. So they should be asked to show the identity at the admission. If it is not, they are not having the ID card, so name should be as per on the ID card. They should be told that, so as to avoid the unnecessary problems afterwards to change the name in the birth certificate. So this, I want to highlight this thing.
Absolutely, and this can be a challenge in an unmarried patient coming for MTP. Usually they write some different name, and we can be in a soup. So we have to be careful as
yeah, we should follow the policy of ID only. So
identity card, and
that is the best policy to follow. Yeah. Thank you, Dr. Jitendra.
Thank you, sir. Thank you, ma'am. Now, I invite our third speaker, Advocate Shri Amit Khanis ji. He is dealing with medical legal laws. Sir.
Welcome, Advocate Amit. Welcome, Dr. Sanjay sir, Dr. Kuthe sir. You are the one who started all this medical legal. So very happy that you have joined, sir.
Thank you, Manish. I was the one who started creating these problems, right?
You were the solution to the questions.
Yes, sir. Yes, Amit. Yes, Amit.
Manish, your name is coming, so I hope I won't have any problem in sharing the screen, because instead of my name, it's showing your name, on the screen.
This is Manish's good luck that he is being named as doctor. You will correct it, sir. Don't worry.
Okay. Can I continue, Dr. Mitra, with your?
Sure. Please do.
Okay. So at the outset, I would like to thank Dr. Mitra and the Medicolegal Committee of FOGSI, Manish, and all the office bearers. And I would like to thank Mitra once again, because she gave me such a wonderful topic to talk on. Because I was really wondering whether stalwarts like Gitendra, Manish, Jaideep, and all those people who are going to speak on medical legal, what would I speak on, because the case laws would have already been covered. Like, Dr. Gitendra is a walking, talking encyclopedia. So, there was no point in talking on case laws. But yes, she insisted on this topic, and I feel I'm honored to present this presentation today. I'm going to keep it very short. And, I don't want to take, I don't want to, bore you people. There's always a death by PowerPoint, and I don't want to be part of that. So when to do what? Pay up or fight back? I think so. What this topic eventually will lead to is a question whether you would like to settle a matter or no, and whether you are fighting a case for the principles, or whether you are fighting case to save your honor, or whether you are fighting the case because patient has harassed you unnecessarily, or whether you are fighting it for fighting it for the merits of the case. It all boils down to one thing, is that whether you want to settle or whether you want to fight back. So before we go any further, just a small warning that you'd be, I'm sure a lot of you must have heard these statements from various people. There are lawyers who would have said, don't worry, doctors, nothing will happen to you. I will ensure that you are out of this mess. Courts can't do anything. Now, these things I keep on hearing a lot nowadays. Courts kya kar sakte hain? 20 saal case chalta hai, But then one thing one should remember is that when the long arm of the law catches, it really only catches your neck. It doesn't catch your hand, it catches your neck. So that's why, please don't go by this statement that courts can't do anything. Courts can make or break your careers, and that is very, very important for us to understand. Don't reply to any notices. This is another thing which I keep on hearing from lot of consultants. अरे lawyer का notice है, छोड़ दो, जाने दो, कचरे के डिब्बे में डाल दो, simply deny करो. I have seen articles written on whether the notice should be replied or no. So there is a logic to replying to a notice, and you should reply to that notice, because what matters is that putting on the record true and correct facts at the right time is definitely going to help you save a case in future. I guarantee you that you will be acquitted. Now, this is last statement, but this is the most important statement that you all should be very careful of, that as a doctor, you cannot guarantee a treatment, and as a lawyer, I cannot guarantee you the outcome of a case. We can guarantee the efforts, we can guarantee the quality of the service that we give, but we cannot guarantee the outcome. It is against your professional code of ethics and even my code of ethics to guarantee anything to either a patient or a client when it comes to me. So please please stay away from anyone who says that I can guarantee you. There is really nothing as guarantee. Judges are all human beings. When they hear a case, every case is different. They look at every case from a different perspective. They look at every lawyer from a different perspective, and hence no two cases are same. All the cases are different. They may be on the same topic, but then the facts of the case matter, and they are different for different people, different for different cases. And judges give their judgments based on facts and circumstances of every case. So that's why there cannot be any guarantee, especially if you find or come across a lawyer who says that I'm 100% guaranteeing you that you will come out of this. Then I think so you should be, there should be a red flag in your mind. Why is he going against his professional code of ethics by guaranteeing something which is not in his hands? Yes, efforts can be guaranteed and the quality can be guaranteed, but not the outcome. So don't, 1 minute, let me just, so do I settle a case? If yes, then when? Now this thing is something which I feel, must have passed your mind more than once. So, people here who have faced litigation, or people who have suffered at the hands of, patients, or they have had a brush with medical councils, or wherever the cases are, I'm sure a lot of you must be thinking that discretion is better part of the valor, and hence let me think whether I should continue with the case or no. So yes, you should settle a case if you are not confident of defending the same. And I think so this goes to the crux of the entire legal battle, or whether any battle for that matter. If you're not sure of your own case, or if you're not sure about your own treatment, and if you have a little bit of doubt in your mind that, boss, I'm not able to defend this, or I may not be able to win this case, then at that point of time, you must step back and introspect and take a call based on your conscience, saying that, yes, I will settle this matter because I'm not confident of defending this case. Second, and the most important thing, the earlier speaker, Dr. Geetendra, covered this very extensively, and I'm happy that he mentioned this. So bad documentation or no documentation, that should be your second point. And I feel if you don't have sufficient documents to back up your case or your claim, then I think so it's always better to settle the case and not to continue with the fight only for the sake of ego. Subsequently, I'm sure I will cover this point as well. But bad documentation or no documentation should be the driving force behind your decision making. Case which is open and shut case. Now there are a lot of cases which are open and shut cases of medical negligence, and howsoever you would want, you cannot defend them because those are cases where there is gross negligence. In such cases, I feel you must be magnanimous and you should show some open heart and you should try to settle this matter. Obviously, you must negotiate. When I say settle the case, I don't mean that you listen to your patients or lawyer for the patient. Don't settle on their terms. You must settle it on your terms, which means that you need to negotiate. You need to have proper channel of communications with everyone who is negotiating, and open and shut cases should normally be avoided because nowadays there is a trend that the courts have increased the amount of compensation post 2013, where the Amri case was decided, like Dr. Geetendra mentioned. A lot of compensations have been granted. The courts have been generous in giving compensations. So we are not seeing discussing compensation in 2 lakh, 3 lakh, 5 lakh range. Average is about 10 lakhs and above, which is a substantial amount of money. And hence, if you feel that, it's an open and shut case, so please don't waste your time on lawyers or on the courts or on the judicial machineries. You please settle the case. If you feel that there has been a mistake and compensation can justify, so there can be some cases where you feel that yes, there has been some oversight, or there has been some sort of a mistake either on your staff's part, or whether on your part, or whether it could be risky for you to take chances with the judiciary. So at that point of time, you can step back and say that no, I would like to go and settle the matter. So this is something which is very indicative. That is, your gut feeling will have to tell you this. And don't go by what advice you will get from the others. Obviously, you will need to take advice on the evidential value of the documents that you have. But ultimately, it is going to be your call, because as a client, a lawyer is bound to go by the instructions given to him by the client. And that is what is my professional duty. Court is not with you. Most of the times you get a feeling when you argue a case that the judges are against you. And this has happened with me in more than one case. In my 20 years of practice, I have come across so many cases where the judges have directly indicated that please go and settle the matter, or they have indirectly hinted that, boss, if you don't settle the matter, then we will probably grant compensation. So you need to know the mood of the court, you need to know the judge very well, and you need to know where the drift is, where the currents are lying, and for that you need an experienced lawyer and someone who can actually gauge the mood of the court, because you need someone who goes regularly before the same court again and again, day in and day out. That is the only way a lawyer would know how a court would react. And this is extremely important, that in the course of the hearing, if you feel, or if you get a feeling that the court is not with you, then I think so there is no problem in settling that matter. Please don't take chances with your reputation and goodwill, because my experience of the last 3-4 years say that every time that there is a medical negligence judgment which has come against the doctor, whether the doctor is big, small, or medium scale practitioner, the courts, the newspapers have reported those cases. Whether a newspaper in Mumbai like Times of India has got 2 dedicated correspondences covering only consumer courts in Mumbai, so which you can understand the kind of material that they are getting out of consumer courts. And they have got 3 correspondences covering High Court. So which means 5 people are covering only the courts in one city, that is Mumbai. And that is the kind of attention that the media is giving to doctors. So hence, if you feel that the courts are not with you, if your lawyer is also advising you the same, and if you have also got the same feeling, and if all of you are on the same page, please don't hesitate to settle the matter. If you have lost in the lower court and judgment is solid and has no chance to stand the appeal. Now, this is something which, this is a situation where, you have a district forum has given a judgment, or a state commission has given a judgment. It is a reasoned judgment. The order is speaking for itself. The issues have been framed properly and answered properly. A proper evidence has been appreciated by the court. And if the judgment is rock solid, and and if your lawyer advises you that boss, this judgment cannot be even if you appeal this judgment, the chances of winning is very less, then I think so you must be able to, then you must actually settle the matter or not appeal, because filing an appeal will only drag the matter for another few years. And trust me when I say few years, it could be from 2 years to 5 years. And right now, there is a complete mess, and I will cover this a little later. So if you feel that your trial court judgment is solid and strong, and it can be justified, then please don't take a chance with the appeals court, because nowadays National Commission and the Supreme Courts have started fining people for filing frivolous appeals. So I got asked one day that the lower court has asked only 3 lakh rupees, given only 3 lakh rupees of compensation, so why are you wasting our time by appealing it? Okay, then I had to tell the court that appeal is a matter of right for me, and hence I have appealed. So then he says that, but your client is a doctor, he must be insured. So what is 3 lakh rupees? Your insurance claim is going to give you that. So why are you again wasting my time? So this is the kind of questions which gets asked many times nowadays. So hence, obviously that cannot be your reason for not appealing. My only thing is that if your judgment in the lower court is good, strong and justifiable, then appealing is a complete waste of time. You please accept that judgment and then try to end the negative publicity that you have already gained by not appealing. Now, last point on this particular slide is if you are a busybody and have no time. So medical legal cases is all about finding time. It is a collaboration. You cannot find a foolproof medical legal defense if you yourself are not going to participate in your own case. If you say that I have no time to come and give instructions to my lawyer, if you say that I cannot help my lawyer with medical literature or with expert opinions, then in any of those cases it is going to be very difficult for a lawyer only to single-handedly defend your case. So that's why if you have no time and if you feel that you cannot contribute sufficiently to your case, then I think so you must not set to the course of fighting the case. You must settle the matter, and that can be done easily, because then there is no way that the cases can get reported anywhere. So is it worth the fight? Should I fight back? Now, I feel that was the main thing that Dr. Mitra wanted me to cover, and this is where I am. So yes, you must fight back only if you have a strong case. That is something which even Dr. Gitendra said, that the evidence is very important. So the entire courts and legal system goes on the basis of evidence. It cannot be your word against the word of the patient. It cannot be that the patient ने ये कहा इसीलिए मैं ये करूँगा. No, it cannot be. So ultimately, if you have a strong case, if you have a good documentary support to back up that strong case, then I think so you must fight back. Okay, if you feel that you can get good medical evidence to support the line of treatment that you have given the patient, then yes, you should fight the case back, because there is always they always say that you must set a good precedent for the other fellow fraternity members, because if you have a patient who is unnecessarily aggressive, harassing, or who is a known litigant, or who is who is someone who keeps on dragging doctors or hospitals to the court, as we call perpetual litigant, then I guess it's a good thing for you to come together and teach him a lesson by fighting your case very strongly. And if the first 3 points in this slide are with you, then I think so half of the battle is won there. You can fight the case properly. If you can get an expert evidence, nothing like that. This is like a Sone Pe Suhaga type of a situation. And I think so expert evidence is highly appreciated by all the courts, whether it's a district commission, state commission, national commission, all of them like to listen to the experts. They like the affidavits given by the experts. So if you can back up your case with experts, then nothing like that. It is absolutely a win-win situation for you. If you have time to support your legal team and help them from time to time, yes. Again, I'm repeating myself at the because I feel very strongly that a doctor's involvement in his own case is extremely important. Your lawyer cannot do it alone. Your medical legal consultant also cannot do it alone. You cannot just give one power of attorney or sign a wakalatnama and say that now you're on your own. Your involvement is equally important for us to get not only motivated to fight your case, but also to help us build a very strong evidence-based case for you. Legal advice is very important as to the quality of evidence, and based on that, success matters. So ultimately, like I mentioned, it all boils down to the quality of evidence that we can show. Evidence, when I say evidence, like Dr. Gitendra mentioned about the documentary evidence, the indoor case papers, the charts, the nursing notes, all the, the hospital admission papers, the test reports, the file that goes with the patient, all these things form collectively as an evidence. It also includes expert evidence. It also includes medical literature from journals, textbooks, or whichever sources you are reliably dependent on. If all the above things are good and the quality of evidence is strong, then I suggest that go ahead, fight the case and go for the kill. Because I think then in that situation, please don't hesitate to go ahead to go to a lawyer and tell them that no, I would want to fight the case back because I feel I have a very strong case. Now, what should I keep in mind? Now, this is extremely important. So there are a couple of things that should be, kept in mind before you actually come to some sort of a decision, whether to take to give a fight back or take a back seat. So number one, the quality of evidence, I'm again repeating, weak evidence is a weak case. It's extremely important that you have a solid evidence. If you have no evidence, then don't waste your money and time. Quality of your documentation is extremely important. No documentation is a no case. I think so. The earlier speaker, Dr. Gitendra, mentioned about the quantum of papers which Amri had made in that case and Bridge Candy had made. So what saved Bridge Candy and Dr. Udwadia was the documentation that they did, the quantum of papers that he wrote, and the clarity with which he wrote. All that actually contributed in saving Bridge Candy and the doctor treating that patient at Bridge Candy, and that is a very, very good precedent even today to follow. So that's why quality of your documentation is extremely important. It is not the quantity of the paper that matters, it is the quality that matters. You can give me 2000 papers, but if only crap is written in it in an illegible handwriting, which cannot be understood by even your own consultants, then there is no use for actually showing that document to the judge, because judge is no better than me or you. Okay, there are few doctors who are judges, but then there are only 2 or 3 such doctors in the entire country, and rest all 97-98% of the judges are human beings. So the same way as I cannot read most of the times the handwritten notes by your nurses or doctors, the same thing is with the judges. In National Commission, for that matter, they ask you for the typed copy of the entire indoor case papers. So if your appeal in a National Commission is of 50 pages, then your indoor case papers is more than 200 pages, because each and every indoor case paper has to be typed out and given separately so that the judge understands what handwriting he is there. And both your original handwritten and the typed version has to be filed in the National Commission. So you can imagine the bulky kind of a petition that goes before a judge. So it's a scary kind of a bulk, and there are 4 or 5 copies of that have to be submitted. So the amount of paper that is lost is extremely, colossal. And hence, if you could save such time by writing good notes or, giving electronic records, then I think so it will go a long way. Legal system has got its own inherent problems, and it is time consuming and time driven. So if you feel that, your case will get over within 1 month or 2 months, then,
Mr. Amit, can you little be fast? We are just running short of, can you wind up? Yeah.
So legal system has got its own inherent problems. It is driven with delays, and if you have no patience to deal with that, then please don't get into the system. Keep aside and stay out. Discretion is better part of the valor. If you feel that you don't want to fight and get a negative publicity, or you don't want to create a noise about it, then please don't fight it. Settle the matter out of the court. If you are insured and so is the hospital, you can still settle the matter because you really don't pay out of your pocket. If you are not insured, then maybe you can think about it. Yes, you can fight the cases for the principles if you feel strongly about it. If the patient is aggressive and if it is left and if left is likely to harass others, then please go ahead and make it as example. Don't leave the case open-ended so that other colleagues get saved in future. If you have not done anything wrong, then please don't hesitate. Please go ahead and fight the case. Finally, take a good legal advice before taking any decision, because a strongly experienced legal advice will be able to give you true and correct facts. So this is the last slide. Take home points. Nothing wrong to settle a case. Don't make it an ego issue, because settling a case is not surrender. Like a lot of people may have told you this, that settling a case is not a defeat or a surrender. It is definitely not an ego issue. It is practical decision. So hence you have to be practical. These are different times right now. See your paperwork properly. If you are having a bad paperwork history, then please take steps. Take a good legal advice. That is extremely important. Don't go on the blind assurance of success. You have to weigh your own pros and cons. Public memory is very short, so don't get threatened by whatever has come in the newspaper. People don't really remember what comes in the newspaper beyond one point. Fighting may not always be advisable. That's why, again, be practical. So hence, with this, I end my presentation. Thank you very much. And I once again thank the office bearers for giving me this opportunity. I'm stopping my screen share.
Thank you, Dr. Amit, for a very excellent presentation, especially in very simple, non-legal language. So we all are able to understand it. And in a nutshell, 4 very important things: the medical records, evidence of proof, and your full involvement of the obstetrician, because obstetrician is the only one who can give the legal clues to the case. Every case is different. It cannot be one line answer. Every patient is different. In that, every patient having complications is different. And last but not least, the previous judgment also. Examples of previous judgment should also be important, which can help the doctors. Thank you, Mr. Amit, for excellent presentation.
Thank you, Dr. Amit. That was excellent. Mr. Amit, I'm sorry, we are used to saying Dr. Amit all the time. And it was so very nice. I think you've become a doctor already for all of us. And what's very important is what you mentioned, never say you don't have time. Remember, the universe is listening to you. Never have ego. And you will require your mentors, your seniors, your colleagues, many a time for expert opinions. And therefore, we must all have a wonderful network within our practice. And that is what all these platforms are all about. And then it becomes very easy for specialists like Advocate Amit Karkhanis to help us and guide us. Thank you so much.
Thank you, Girija. Thank you.
Thank you, sir. Thank you, ma'am. Now inviting our last speaker of this session to our respectable and esteemed Dr. Manish Machave. Sir has been chairperson of Ethics and Medicolegal chairperson of Ethics and Medicolegal Committee FOGSI 2020-22, organizing chairperson of this North Zone Ethics and Medicolegal Committee conference. He has been a leading endoscopic surgeon and is founder, member, and treasurer of Pune Association of Gynec Endoscopic Surgeon. He'll be talking on coping with vandalism in healthcare. Over to you, sir.
Thank you. Is my screen seen?
Yes, sir.
Yeah, okay. Very good afternoon to everybody. I'll run through a few slides. At the outset, I would like to initially thank Dr. Mandakini Meg ma'am, Chairperson ICOG, and Dr. Parag Biniwale sir, Secretary ICOG, for granting us 5 ICOG credit points. So all of us will get those credit points which will benefit us. They head the College of FOGSI, which is ICOG. So thank you, ma'am, and thank you, sir, for being here. I also am indebted to Dr. Sanjay Gupte, sir, who actually, is going to give the next oration. And so much we have learned from sir over these years. And I'm so happy that when we had planned this event, sir consented to coming and sharing his views upon it. And respected chairpersons, Dr. Girija ma'am, Dr. Savita, Dr. Surekha, thank you all. Thank you, Dr. Mitra ma'am, for arranging this fantastic. I'll just run through few slides. I pray to Lord Ganesha to sail me through this presentation. Thank you for a nice nice introduction, and thank you again. So coping with vandalism or violence in healthcare is a issue which is very dear to us. It is happening. We thought that because the Prime Minister has told that aap ghanti bajao ya thali bajao, so everybody will respect COVID warriors and everybody will respect COVID doctors, but that is something which is not happening. In COVID times, this is seen more and more coming up every day. So what we have to realize is there are different types of violences. It can be against a body, which can be verbal, physical, or both. It can be against property, and there's also a part of defamation. Now, some people consider it as a part of professional hazard. So, they say if you want to put your kids into medicine, this is a part of our profession, because we are surrounded by so many people, politicians, hooligans, the law is behind us, obviously the media and their TRP rating. Doctors, community, patients, so everybody, and then we have to find out what triggers such violence, what are the underlying conditions, and what are the areas of conflicts, what are the structural organizational factors that can give rise to this, what steps needs to be taken to contain this hostility, and is only law the only solution to it, and what needs to be done. Who is responsible? Everybody is responsible. Doctors are responsible because a loose word here and there or a loose comment here and there. Paramedicos, nurses are responsible because the way they communicate with the patients, especially in emergency situations, we have to consider that. Hospital administration, a patient who is in emergency, if has to wait for 3 and 4 hours before he or she sees a consultant, it becomes a big problem. Attenders of patients, they become a problem because a small thing, they would come at hours which are not visiting hours for the hospital, and then they create problems. Obviously, limitation of resources. Now we have seen in COVID times, there was limitation of drugs and oxygen. And then this limitation was not because of any fault of doctors, but it is blamed upon the doctors. And obviously there is a law which is there to help us in this situation, but does it really work? And these are the triggers. So be very careful when these things happen in your hospital. Have a policy to settle down this sudden death, denial of admission. If, for example, you do not have the facilities and you stabilize the patient and shift, delay in providing care, absence of equipments and drugs, negligence by staff. So, be very careful in what injections the staff give, the way you tell them to give. Junior doctors communicating about death, this should absolutely not be done, and that is the reason why junior doctors get beaten up all the time. Limited understanding about the disease. So something about which you do not have an understanding, please take a second opinion. These are the causes. Shortage of drugs and supplies. I mean, what other best example that we have seen in COVID, where, if, for example, in a place like Nashik, when there was oxygen leak and 24 patients died, it was the doctor who was held responsible. Malfunctioning of equipments, AMCs have to be done, shortage of personnel, you have to employ proper personnel and resident doctors, with their meager stipend and working and living conditions. Again, all these become causes and triggers. So what is the strategy that one has to follow or one should follow in preventing this violence or vandalism? First is there should be proper training and improvement in communication skills. This is, very easier said than done, but communication skills have to improve. The role of senior staff is a must, especially when it comes to tricky and complicated situations. Increase the number of staff, plan duty rosters and hours, and, establish public relation officers who have good relations with the surrounding general practitioners, the politicians, and everybody who's related or who can be helpful during this situation. And obviously, then there is law. Is it justifiable to respond to a slap with a slap, or you wait till you get killed? Now that is a big question, and that is where the law comes in. So there are various sections of Indian Penal Code, which gives you right to protect any violence against yourself or your property, even to the degree of killing the person who's doing it. But please remember, the burden of proof is upon us to prove that this kind of violence or vandalism was started by the patient or the relatives. No, that is the reason why your CCTV camera, audio and video recording, and the witnesses who are present in the hospital come very handy. And there are so many sections of IPC which can be applied. This is section 350, which says criminal force, then assault, which is section 351, and then it entails to 3 months imprisonment and fine. So these are some sections against which you can, or for which you can have complaint at the police station. And when you are doing this complaint at the police station, don't forget to call the police and let them do a panchanama of whatever vandalism has happened in the hospital and give them the CCTV footage. Assault is also a tort. There is an intention, reasonable apprehension and harm. I don't want to go too much into details of law, but remember that it is use of force without any lawful justification, and that is what there is battery in tort, and assault as a tort also, and as a crime also. Then there's section 503, जिसको हम common parlance में धमकी देना बोलते हैं, या criminal intimidation. And then there is section 499, which is defamation, because if somebody goes and unnecessarily defames you, there it can be slander or it can be libel if it is spoken or written simultaneously, and there is imprisonment which can extend to 2 years or with fine here. Defamation, I told you, is also part of a tort where you can claim compensation against the person. Then there are different state acts, and Haryana has this act, I know, and Maharashtra also has this act, but we need to strengthen this act at national level. What amendments have only come in the Epidemic Diseases Act, but this is the act which is, for example, in Maharashtra Medicare Service Persons and Medicare Service Institution Prevention of Violence and Damage or Loss to Property Act. And there are very important sections, so it applies to all RMPs, it applies to nurses, medical student, paramedical staff and nursing student. And offenses here are cognizable, non-bailable. That means all these people who are doing violence and vandalism in hospitals, they can be arrested without a warrant and they do not get bail as a right. And there is provision of 3 years imprisonment and fine up to 50,000 rupees, compensation twice the amount of damage that that person has committed. And this is very importantly, section 8 says that this is, this is not in derogation, but in addition to. So all the sections of IPC will be put against the person and also this act. So we have to know this act, and whenever we complain, that is what I suggest, give a copy of this act with your complaint to the police station, because a lot of the police personnel will not know about this act. And have these laws, when they have come in, IPC is since 1860, these acts have come since 2010, so 2010. Is the impact of causing vandalism or violence against doctors gone down? If you can see this statistics from IMA, it shows that it has gone down a little, but practically if it happens to one person, it happens 100% to that person. So we have to have some modality amongst ourselves. That is why I said there are these triggers that we have to think and overcome. And law is, something which comes in place after the vandalism or violence has occurred. Our chief aim should be prevention. And that is the reason why we have this North Zone Ethics Medico-Legal Committee conference, because the theme of the conference is bridging gaps. And what better time than to bridge the gaps during COVID situation, where not only us, but the entire country, the entire world is fighting against this pandemic. So I'm very happy that we are having this bridging gaps. Especially, I hope you go through the newsletter, because that also has a lot of things of benefit to all. So thank you all for a patient hearing, and we have to go ahead, I think. So thank you all for, thank you.
Thank you, Dr. Manish. Manish, you have always evolved from, I remember the entire journey of yours to coming to such expertise, and now the chairman of the Medical, Legal and Ethics Committee of FOGSI. And such great wisdom you have given, and I know that you are very helpful in our practices also. One of the most important messages I think I should give here as the chairperson of this session is that, friends, please be kind to your own colleagues. Even if they must have done any mistakes, try to connect to them directly rather than speaking anything about anybody loosely in front of the patients or anyone else. Because that can be really, really very, sometimes somebody must have made a real gross mistake. Speak to your own FOGSI member, colleague, immediately on the phone personally, rather than putting it out in front of the public, because that can really cause somebody a lot of issues. So I think this is very important. We cannot own our practice by demeaning other people, and we have to follow what we call as not only medical ethics, but we should also be very, very cordial in our dealing with the other side of the table. Thank you so much, Manish.
Thank you, Dr. Manish. I want to add one point.
One important message which I want to convey is be very, very soft with your patients. If you are very comfortable talking with the patients, 50% litigation is not there. Counseling is very, very important, and be soft. Don't say, I don't know, go here, you can go anywhere. Just do counseling in very, very proper manner, and so as to avoid most of the litigation. I think not 50%, 80% litigation can be avoided if you are soft with the patient, explain them everything in soft manner. Written consent document, that all is okay. But how you speak with the patient, how you feel compassionate to that is more important.
Yeah.
Dr. Surekha, your comment, please.
Yeah, ma'am, I want to say that we should be very polite and compassionate to the patients. And if we are doing this, our 90% of the job is done. And we should be always very, we should give a hearing ear to our patient always, what they are saying. If we listen to them properly, our problems generally don't crop up. So that's what I want to say. We should be very, very kind to the patient. Yesterday only I was in the OT, and it was a ruptured ectopic. And the anesthetist scolded the patient for some very silly thing. Then I told the anesthetist, please don't scold the patient. The patient instantly told me, yes, ma'am, I know you since so many years, you're so polite. That's why I keep on coming to you. So this is the major thing, like I want to convey. We should be very polite to the patient.
Absolutely. Very important.
Thank you.
Thank you, Dr. Mitra. Thank you, Manish, once again for giving us this opportunity. And I think we take your leave.
I thank the chairpersons and the speakers for session 2. Now we will go on to session 3. Thank God we are not very late, and we did have spillover time. So I have taken this pleasant duty to honor to welcome the main speaker, Dr. Sanjay Kuthe, and our chairpersons for the keynote address. Before I tell about the eminent members of this session, I just want to say my small story in half a minute. That बहुत साल पहले जब डॉक्टर संजय गुप्ते ने ये मेडिकल लीगल रेवोल्यूशन स्टार्ट किया था पुणे से, और मैं वहाँ बहुत सिंसियर स्टूडेंट की तरह से गई थी, लिटिल डिड आई नो that God wanted me to prepare for my time to come. And sir, I was a very honest, sincere student. I attended the 5 days. I listened to every talk, and I made friends with the Pune Society. I invited you people to Rewari. This was in 2007. And in 2009, I faced a full-fledged criminal consumer court case. I lost in the lower court. I won in the high court. 9 years. But really, God was with me and you people were with me. It's my privilege, dear Dr. Manish, that today I was able to do something in return for the Pune team. So with that little introduction, that personally मुझे इतना ज़्यादा FOGSI का, पुणे टीम का, डॉक्टर संजय गुप्ते का और उन सारी कॉन्फ्रेंसेस का इतना फायदा हुआ है कि मेरी सिर्फ ये तमन्ना है कि आज के इस कॉन्फ्रेंस में जो लोग भी सुन रहे हैं उनको जो भी फायदा हो, तो रिमेंबर कि इट इज ऑल गॉड हु हैज designed everything. So now with that, now I will do my official duty, and I am extremely honored to welcome the 3 wonderful chairpersons for this session. The first person, it's my proud privilege, it's my honor to welcome a person who's very, very close to my heart, and she has a very special place in my heart. The personal relationship I cannot describe. I can only say that the first time we met, she made me her younger sister, and she has lived up to that relationship. This is none other than our very, very dear, most respected ICOG chairperson, Dr. Mandakini Meg. Her wonderful CV is there, but I want all the people to remember that Madam has walked the talk. She has worked very hard throughout her career as a brilliant obstetrician, as a brilliant administrator, as a mentor to many people in Mumbai, Maharashtra. She has held hand of people who have spread all over India and who have immense respect for Madam, for her strict disciplinarian, but a soft heart. So, well, friends, I have with us Dr. Mandakini Meg. She has been the National Vice President of FOGSI. She has been the FOGSI chairperson for Imaging Science Committee. That is the time when she had come to Rewari to sanction my center. Madam has been the superintendent of Kama and Albless Hospital. She has been a wonderful administrator. She has occupied very high posts in the government of Maharashtra as the director of health services and advisor to officer on special duty for नहीं दी मुझे प्लीज ये मेरा privilege है. I know that what I am speaking is because I actually really want, I know people have heard it, but I am really, it's my privilege, ma'am. So I really want all the people in the audience to realize that amongst us, we have a dynamic person. And during the course of ICOG sessions, I got to hear her presentations and the volume of work she has done. The amazing talk on cesarean section and local anesthesia. Well, friends, always my intention is that किसी की talk से, किसी की education से कहीं कोई FOGSian को फायदा हो जाएगा. So maybe it is worth the effort. So I want to welcome you, Dr. Mandakini Meg. You have received so many awards, and we are very, very proud and happy and honored to welcome you as our chairperson. The next person I have the wonderful duty to welcome is none other than the most dashing, dependable, and dynamic secretary of ICOG. All of us have known Dr. Parag Biniwale, the person with the sweetest smile. He was the chairperson of Young Talent Promotion Committee. And I have, for so many years, he has been my hotline responder. If ever I am in any clinical problem, I give him a call and there I get his immediate response. It may be anything trivial or anything serious, but Dr. Parag has always been there. He is the secretary of ICOG, we all know, excellent obstetrician, teacher, and wonderful surgeon. I have seen him operate in the live workshops. He is the president-elect of Pune Obs Gyn Society for the term 22-23. And of course, as a FOGSian, he has done many, many good things for FOGSI, and he has been there for all the FOGSians. Welcome, Dr. Parag. And my third chairperson is none other than the National Coordinator for Ethics and Medicolegal Committee, Dr. Alka Kuthe. I have known her personally for many years, but I got a very good opportunity to interact with Madam in these last 3-4 weeks. Very humble, very soft-spoken, and very cooperative person. Madam is a senior consultant of Amravati, and she's been the ex-president of Breastfeeding Promotion Network of India, Maharashtra State. She is LLM. Many would not know, but because of her vast knowledge in law and always ready to help. Very warm welcome to you. She's the editor of textbook on medical legal issues and Jim Leah. It's our proud privilege to welcome the three wonderful chairpersons. And may I request Dr. Mandakini to please do the honors to speak about Dr. Sanjay Gupte. Sir.
Yeah. So, good afternoon, everyone here. A wonderful conference, and Mitra, those personal, official, everything about Sanjay Gupte, about me and Parag and everybody is so heart-touching, and that shows you're the human side of a organizer and a personal relationship. Thank you very much for those words. It's my great pleasure to introduce Dr. Sanjay Gupte. He's a great academician. He's an authority in the medical legal subjects. He is for me, he's a friend, philosopher and guide. As Mitra has said, in the middle of the night also, if I want to, discuss something, he is always there for me. Also, he is a great support to the ICOG for all our official advices. He is our advisor officially, and great support and motivation. He is going to talk. Also, I will read the official biodata that he is. 1 minute. He is holding the very important post of the chairperson of the ethics committee of the FIGO, and he has been awarded the very prestigious FRCOG of Royal College of London. He was FOGSI president, as we all know, and he was president of DIPSI, secretary general of Justice, ethics committee, Maharashtra Medical. And I want to also add here that he is taking all the pains to teach our students of ICOG about the ethics and medical legal issue, which that subject we introduced very recently in all our, ICOG courses. So thank you very much, Dr. Gupte, for being there for ICOG. And I think I will invite you to deliver your very important lecture for all of us. So stage is yours, Dr. Gupte.
Thank you, Mandakini madam, and thank you, Mitra ji. I'm really humbled with, whatever is being said, about me, and I don't think I deserve, all that, at all. It's so nice to have for this particular session, all the three chairpersons who are very, close to me, and with Dr. Mitra and Dr. Manish as organizers of this. So it's a real pleasure to be here and sharing with you some of my thoughts. I think just now the chairperson says, Surekha ji said, and that is something vitally important, and that's the track, after having this from 1996, all the medical legal issues and everything, and all the legalities and wonderful people like Manish, Gitendra, Amit, everyone guiding us medical legally. Still, I think probably as I get older, the perspective has changed, and the way it has changed is that finally we have to say, okay, all this is good, but what we need to know is what does the patients want, and this is where we need to start if we have to safely practice in this today's world. The patient's perspective ought to be a key component of any good quality healthcare, and patients don't want too many things from us. What do they need is responsiveness and empathy, good communication, clear information provision, appropriate treatment, relief of symptoms, and improvement in health status, and above all, safety and freedom from medical injury. So this is, I think, that is their right. And if we recognize that as their right, then everything, all the actions we take further, become quite obvious. So what are the pillars of patient safety? Knowledge, communication, safe procedures, and implementation of those safe procedures. And that is both by compliance by the doctors and compliance by the patients. So we know that knowledge is the foundation, and knowledge is really what is going to give us the safe practice. So practice is important for reinforcement of the knowledge. But very often in practice, the complacency sets in very fast because we feel that, oh, now we know it all. And add to that, many situations. For example, our attentiveness is many times, we get distracted, especially suppose you are in a busy OPD and suddenly an emergency case comes whom you have to take, on table very fast. Then you try to finish the OPD patients faster and you're likely to miss something in that situation. Also, there are many times we presume certain things. Often we tend to presume that nothing can go wrong if small steps are omitted or skipped in a procedure. And once in a while, such a step can be really disastrous. For example, auscultating chest after putting intratracheal tube is to be done routinely by an anesthetist. But if it assume that, because I am experienced and I have done it and it must have gone in, and people have landed in big trouble, just by skipping that small step. So there are so many small steps that we have to follow. Then in larger hospitals nowadays, this is a problem. The first time you see a person is properly donned and you hardly see the eyes and nothing else, and especially with now PPE kits, even that is difficult. So the surgeon doesn't know who is at the head end, whether what is the anesthetist, what is the expertise of the anesthetist, who is the nurse. And so naturally in this situation, everybody is a stranger and it's difficult to create a teamwork, especially when something goes wrong. And that's where the checklists come in. Checklists, actually allow us, remind us of minimum necessary steps. They reduce the dependence on individual memory. They empower the assistant, and that's very important. So anything is faulty, and if anything is deficient, the junior staff is encouraged to point out. And involving them in checklisting process makes really the less error prone for us. So checklists really create smooth communication and teamwork. I'm not going to go through all the checklists, but just a couple of checklists which are important. And though WHO preoperative checklist is there, we have to have our own individual checklists which are more in detail and more specific so that we don't miss out on this. And of course, as you know, the checklists are two types. One, read and do checklist. That means, whenever the nurse is putting on the trolley, she can read whatever is needed and put the trolley.
Hello? Hanji.
What we need is the do and
please switch off your audio.
Done all these things and you're just confirming it last minute on the table. And most important checklist I feel is not just pre-operative checklist but post-operative checklist, because not only the sponge and instrument count, pulse, BP, many times, because remember, the main surgeon goes away without closing the abdomen and it is left to the junior to do that. So they should report at the end of the surgery all these things that I mentioned, including the pulse, BP, PPH, permission from the anesthetist, whether the patient can be shifted or not. Then simple things like whether lab is sent or not, histopathology, can create a lot of trouble if that's not done, properly. So what are the next steps in safety? Are standard clinical practice recommendations. And these are also of two types. One, we all know our standard clinical practice guidelines. And we always advocate, and it has been said before by the speakers also, you follow the clinical practice guidelines, proper documentation, and then you don't run into trouble. But what are important things are also the non-clinical standard operative procedures. And just now, as rightly said, if you from admission to the discharge of the patient, there are almost more than 120 steps that we all go through without realizing it. And every single step has to have an SOP for the person on the spot to follow. And this starts with the when the patient calls to the hospital for seeking appointment, comes into the hospital, how the staff behaves with the hospital, because this is where the trouble starts and this is where the safety problem starts. So I'm not, again, let's not go into the details. We all run the hospitals and we know about it, but the behavioral monitoring of personnel, also said by Gitendra and Amit, is very important. Then now we have learned the hard way, the emergency drills, so many fires during this pandemic, and oxygen shortages, what happens, unless we have a drill, we may be having even the equipment, but there has to be somebody who will actually use that equipment. And this, suppose a fire occurs at night, who is in the hospital? Maybe nurses are in the hospital. Are they, taught or trained to use that equipment? Because it's instantaneous. You can't keep on calling people to do that. So what steps are to be taken? So these drills have to be actually run. And then of course there are emergency drills we all know about for certain situations like sudden cardiac arrest, pulmonary embolism, sudden collapse in the ward, anaphylactic reactions. Unless we do drills with the nurses and our junior staff, if something is like this to happen, the response is not going to be very quick and as desirable as we want. Then how do the things go wrong? These are all the famous cases you all know. In famous Delhi hospital, nurse administered IV chloroquine instead of chloromycin. In Goa hospital, patient was given sulfa drugs when he was allergic to it and lost the vision due to Stevens-Johnson syndrome. In large Mumbai hospital, patient was shifted to the wrong bed in the wards and hence was about to receive wrong medicine, which was pointed out by the patient's wife. In London hospital, 5-year-old girl hospitalized for cancer treatment, about to receive medication through an intravenous line. An alert mother read the order, checked the drug, and informed the nurse that the drug and dose were correct but meant for another patient. In famous Mount Sinai Hospital in US, one of our famous actresses' mother underwent brain surgery on the wrong side. And injection pavillon given as replacement in the hospital was used by general practitioner thinking that it was for the follow-up treatment. So these are glaring examples where thing can go wrong in spite of the due care. So the patient identification that has been talked to by Gitendra also in the surgical site identification, continuity of care, handing over, is very, very important, because one nurse has given one injection, she has not told the next nurse who comes on duty, and she repeats the dose, and it can be an overdose sometime. So in my hospital, if you come, you will be greeted. Somebody will, say, they won't say good morning, doctor, or good morning, madam. They will say good over, doctor. And many people wonder why this is so. I have made it a habit to all the staff nurses, to greet each other also by saying good over, so they don't forget about handing over procedure and they do it correctly. And this sounds peculiar, but that helps, and it has helped in a long way. Then look-alike and sound-alike drug names are there, which we have to be careful about. How effective is the communication? There are interesting surveys. 85% feel that they are not told enough. 53% wanted more information, did not ask for it. 50% wanted to make a request for more information. 53% did not understand what was told, and 40% did not remember what was told. 40 to 45% did not comply with the given instructions. So we feel, and many times my junior doctors come to me and say, doctor, but sir, I had already explained to this patient, this, and she is again asking you, or her relatives are asking her, how many times I am supposed to tell? I keep on telling them, no, as many times as you feel that they have not understood, you have to go ahead and explain to them, and that's the only way the communication can be improved. So ineffective communication can create a lot of troubles. Non-availing of preventive services by the patients, delayed diagnosis, incomplete understanding of one's medical condition, non-adherence to medical instructions, not developing self-management skills by the patient, and poor health status and greater mortality risk. So that's why the communication is very, very important. And what we have to understand is communication is a process. It's not just telling or conveying something and being happy about it. We have to understand that the communication means you communicate to the patient, then the patient has to understand. Patient has to perceive it properly and internalize. Then patient has to be satisfied with what you have said. Then a patient has to remember what you have said, and then only you're going to get the compliance for the patient. So it's a process and it needs a good follow-up. So how do we improve patient-provider communication? The checklists like these, Gitendra mentioned about how, but if you have checklists like this, on the counter page, somebody who is taking history, somebody talking to the patient, these kind of checklists does help them. And just, point out yes or no, especially, before consent taking, this checklist will be of a great use, and you can actually have the patient signing it also, so that will help you medico-legally in a great way. So important point now is we have to engage the patients themselves in their own safety, and that is going to actually make a difference to the whole situation. And that's why we have now created what is called as a movement for patient safety, with many activists, in patients field, who are usually the ones who are criticizing or complaining about our practice. Involve them only. Teams of them have been involved, and we have started this patient for patients safety, where the patients and the families are given voice. When the patient registers concerns, many times they are taken as adversarial threats. They ask for something, but sometimes you have to wake up to what they are asking, and maybe that is the time you can contribute to the knowledge distribution, and that is going to help you. So don't, every time the patient complains, don't feel that that's wrong. In fact, I tell the patient that I welcome your complaint, because now our things can improve, and I can do something for improve my situations. The patients have a huge role in promoting safety, choosing a right, choosing a safe provider itself. You have to be able to tell them why you are the safe one for them, and they should be knowledgeable enough to choose you over others. Then only they will come to you. Helping to reach an accurate diagnosis, appropriate treatment or management. Treatment is appropriately administered, monitored, adhered to, as I showed the couple of examples where the relatives pointed out and prevented something going wrong. What all of us have in practice is the time constraint. And even I'm sure the best of consultants cannot give more than 10 minutes per patient, considering the OPD pressure that we all have. So what we have to do is we have to learn to have a team approach. Let somebody help in taking history. Let somebody help in after your examination, in your explanation. Let somebody else go and explain the patient again. And this will definitely sort out certain problems, and patients who are intimidated before you and don't ask questions can ask questions to your junior colleagues and help you out. So patients play a huge role in preventing errors, and we need their help, and we should definitely enroll them in this particular care. So there are so many errors. I don't want to go into the details of it, but action errors, starting right from the appointment, mental errors, failing to take the medication, and low health literacy. So teaching or learning from each other. All this is important. So we have created a health card which we give to the patients. The patients, before coming, write it down, their own history first, whatever they remember, especially about the drugs they're taking. Recently, I had a patient who had, almost after all this, asking and all that, just when she was almost full term, told me that she was having hiatus hernia, and somebody had told in the past that it should be operated, and she had neglected operating it. So that could have caused problem during labor and all that. So in spite of all this, many times the history will be missed, but if we have a good communication, then the patients help us out. So we have to prepare the patients for their appointment checklist also. This is handed over to the patient, that, what they should do and what they should, follow, and then, give them a list, give them what they need to do and what they need to follow. So basic questions, you empower them, you give them the list of questions what they should be asking you, and that makes it easy, rather than they asking you some irrelevant questions which are not really helpful. So why not us helping them to ask us questions. So we have created certain for example, this is pre-anesthesia information a questionnaire to be filled up by the patients. Again, as Gitendra, Manish, and all always keep on saying, this is the kind of documentation which helped us in a long way. And this is the pre-anesthesia questionnaire that one can have. Then patients and relatives, again, this is a discharge summary and discharge instructions which have to be not only communicated with the patients, but make them read, make them sign, and that becomes a good medical legal support if something goes wrong later on. So we need a movement of the patient safety, and we have already started this movement. And I would like all of you to join in your own way, in your own hospitals, the movement for the patient safety. Let's involve the patients and let's be with them. They are not our adversaries. They are our friends. In fact, they provide us bread and butter. That's something that we can never forget. Thank you so much.
Thank you very much, Dr. Kuthe. Very, very informative, comprehensive, very practical. Actually, each one of us, I was noting down many of the points. And the most important thing which you have said was involvement of the patient. I think that is the key for reducing the medical legal problems and the safety of the doctors. I will like to narrate my own experience with some big hospital, and my husband was also very hurriedly, she tested the injection, and I was very curious. I said, what are you giving? Madam, I am testing the monosep. But I said, already in the morning hours, already one dose has been given. No, it is not written. Then I said, you better call for the call the doctor. And then everybody came. And then you said very, very correctly, good over. No handover was given. And my husband would have got a second dose, and already he was not in a very good condition, and he would have suffered, complications. So much important that patients involvement is so important. Second thing, also in the discharge card and information to the patient in their vernacular language is also very important. So many times Marathi speaking.
Okay, yeah, thank you. Sir, it was indeed wonderful listening to you. And I would once again like to say that when we listen to you talking about medical legality, it's a wonderful experience because you always speak from the heart. Last time when we discussed this, you did disagree, but everybody who's sitting here will definitely agree that, as you start talking about checklists, as you start talking about patient safety and now even ethics, it is a treat for all of us to listen to you. Thank you very much for an excellent presentation.
Thank you.
Alka now, Alka, yeah.
Yes. So thank you, Dr. Sanjay Gupta, sir, for your excellent elaborate talk on patient safety. Actually, these you told about what are the different checklists, what SOPs we should follow, what are the emergency drills. All these things are very important in our day-to-day practice, and this is important for patient as well as our own safety. That is very important. It gives us mental peace and progress also, so that we can have hassle-free nights or hassle-free practice. Secondly, when I look at you, I always think that you are like Sanjay in our great epic Mahabharata. Sanjay used to tell whatever used to happen on the battlefield. Similarly, you gave us a foresight, how we can predict, how we can prevent litigations. And because of you, I think myself and many of us got inspired, motivated to have a medical legal knowledge. What we were purely medicos, we got transformed into medical legal personalities. And I think it is a need of the hour to have medical legal knowledge so that we can have safe practice. So thank you very much, sir. Once again, thank you.
Thank you, Alka.
Yeah, thank you all the organizer for giving us the opportunity.
Sir, दो चीजें बोलना चाहूंगी. एक तो sir, you're looking very dashing. Manish, you have to take inspiration from Dr. Sanjay Gupta.
I have taken
it is a Singham look.
I have taken inspiration.
And the second thing is, sir, every time I hear you, I am like, it is a reaffirmation of what ethics and good practice is. So I have written in the chat box that every word of yours is worth its weight in gold. And sir, I am your chief follower. अपने hospital के documents की एक copy हमें भेज दीजिए, so that we can improvise.
Actually, यही तो मैं कहना चाहती हूँ. मैंने आपको personal उस पे लिखा है, सर. ये सारी चीजें तो चाहिए.
मैं publicly मांग रही हूँ.
To improve our practice also.
Mitra ma'am, truthfully, when sir was giving a lecture, so I clicked photographs and I put on our WhatsApp groups. And the first message I received was from Dr. Kiran Kurtokoti, which said, "Fantastic new look of Guptas." The 5 seconds, 5 seconds. But Sir, amazing talk. Thank you for gracing this occasion. This is the first event that I am organizing as, the chairperson of Ethics Medico-Legal Committee. Truthfully, maybe you are too modest and too humble not to agree. But the fact still remains that there was a time when Pune was known for Dr. Sanjay Gupta and Medico-Legal. Then came a time when Maharashtra was known by Medico-Legal and Dr. Sanjay Gupta. Then came a time when India knew Dr. Sanjay Gupta and Medico-Legal. And now, I mean, outside India, maybe you are known for your justices and so many other things. But for all of us,
really humble.
No, this is the truth. I'm not. This is truth. This is
purely
truth.
Dr. Manish, Dr. Sanjay Gupta sir is actually pioneer of FOGSI Ethics and Medical Committee. I have attended first conference at Pune. It was a great conference that inspired many of us.
भाई कहीं हमारे लिए भी कोई छोड़ दो. मैंने मित्रा को ये बोला कि देखो भीष्म पितामह तो डॉक्टर गुप्ते सर ही हैं. बिना उनके कोई मेडिको लीगल कॉन्फ्रेंस नहीं हो सकती है.
Ragini ji, we had a wonderful conference with Justice Kapadia, and I will never forget that, in Gurgaon.
Sir, every conference which you are there, I cannot forget Markande Kadzu, Ram Jethmalani, what diggaj we have heard. And I am so honored.
We attended all the conference.
We have 3 more zonals and 1 national, and 4 zonals next year and 1 national. So please be there with us.
Thank you. At least मेरे भी tenure में तुमने कुछ कर दिया. एक conference तो दे दी मुझे कम से कम.
Thank you very much, Dr. Mandatni Meg, Dr. Parag, and Dr. Alka. We are so honored that you have shared this session.
मित्रा
हाँ जी मैम.
मेरा ऐसा कहना है कि संजय गुप्ते तो बहुत ही अच्छा लग रहा है, पर all the dashing men are here. So my compliments to all the men who are present. Everybody is looking so relaxed, so nice, and at their best on the Sunday morning. So compliments to all. Yeah.
We welcome Dr. Ajay Mane. I can see him now.
अच्छा, अब I will request. I know आप लोग बहुत busy हैं, and we were to finish at 1:15, but we are not very late. So I will request Sanjay sir, Dr. Mandatni, Dr. Parag. हमारा session 4 थोड़ा youngsters का है, तो उसको जरूर प्लीज आप अटेंड कर लीजिएगा. That will be very encouraging to the youngsters.
Sure.
So actually the chairperson for that session is Dr. Renu Yadav. For few minutes till she comes in, please imagine that I am Renu Yadav. I am sure the audience would now know that we are going to have a debate with the difference. Now, the difficult task of judging this debate has been entrusted to 3 eminent obstetricians and gynecologists. The first one is Dr. Savita Singhal. The audience has been introduced to Dr. Savita. So she is the director professor in Rohtak, and already been introduced, and all of us know. So the judge for the day, second judge, is Dr. Ajay Mane. Dr. Ajay Mane is a medico-legal consultant since 18 years, and he is an extremely helpful member of the National Inspection and Monitoring Committee, PCPNDT, Government of India. As I am told about Dr. Mane, that anybody and every person who has ever had any trouble, he is just a phone call away. He is the chairperson of Sexual Medicine Committee of FOGSI for year 2014-2016, chairperson of official EMOGS website, chairperson of Adolescent Health Education Committee, EMOGS, and past president of Aurangabad OB Gyn Society. So Dr. Ajay Mane, you are entrusted with a very important job of judging the game changer debate today. And the third judge for today is Dr. Kiran Chandna. Dr. Kiran is a very dear friend, and she is my junior, my friend from the same college. She is the director of Chandna Medical Center, Faridabad, and president Faridabad OB Gyn Society. With a work experience of 35 years in gynae obstetrics and special interest in adolescent health. What I want to tell the audience about Dr. Kiran is that she's soft-spoken, she's very hardworking, and she's there unobtrusively. She has been my co-editor for the e-bulletin. So very warm welcome to the 3 judges. If Dr. Renu has not yet come, so imagine that I'm Renu Yadav still. So let's introduce the 4 speakers. This is Dr. Subohi Rizvi. You are going to be mesmerized by the way she speaks. She puts her thoughts across so clearly. She is the secretary of Gurgaon OB Gyn Society and an MFF certified obstetrician doing fetal medicine. The next debater is Dr. Rekha Thakur. Dr. Rekha is a gynae laparoscopic surgeon and a LAMACE trained childbirth educator. She is working at her very own Wellstar Clinic and Diagnostic Center, and she delivers with an open choice of hospital and promise of personalized care. And she's a consultant at many hospitals in Gurgaon. Next speaker is Dr. Indu Bansal Agarwal. She's young. She's a director in radiation oncology. I have known her for this last 1 year, but everything that I know about her, I'm extremely impressed with her credentials. And I will let my audience judge the speakers. She's highly trained, very acclaimed radiation oncologist. I may not be doing justice because I'm not reading out the full CV, but I want to go on to the last speaker. This is Dr. Kirti Kishore Sharma. She is from my city, Rewari, but she brings lots of, pride to Rewari city. Working as a consultant in Kalavati Hospital, she is the founder of Kalavati IVF Center and Fetal Medicine Center. In addition to being a very good clinician, she is a very good dancer also. So I will now tell you the rules. So this debate is how we practice and where we practice. For the audience to be attentive, there will be 4 audience poll questions also. Now over to my judges and to the speakers.
Yes, good afternoon. At the outset, I must thank Mitra ma'am and my dear friend Dr. Manish, who has invited me as a judge here. I'm a very small person, and the biggest thing in my biodata was I am a student of Sanjay Gupta sir in this field. So, be here in front of him is like showing the Kazwa to the sun. Likewise, so he's always there. Today also I learned so many things from him. Listening him since 25 years, and again listening and learning a new thing in each lecture. Sir, thank you very much for being there for us. Thank you. We have divided myself and Sarita ma'am yesterday spoke. Divided these talks in 3 points. Time is given 1 slot of marks. Subject is given 2nd slot of marks, and 3rd is presentation, the way you present and all the things. So 30 out of 30 will be giving you marks. Sarita ma'am, can you elaborate the things further?
Yeah, so we'll be judging you on basically on 3 points. Whether you are within your time, presentation, what is the subject you are taking, the matter related to your subject, and the way of presentation. So all the best, all the 4 presenters. And I think we can start with the presentations. And the 2, first one is Dr.
Subohi Rizvi.
Yeah, for the first talk, I invite Dr. Subohi Rizvi, who will be speaking on ethics. Dr. Subohi Rizvi, please. Yeah? The time slot, Dr. Mitra, how much time you allotted to them?
5 minutes, 5 minutes each.
Ma'am, but the total minutes will be 40, no, in given. So 10 minutes each for 4 persons?
No, 5 to 7 minutes.
5 to 7, okay, fine. Thank you.
5 minutes they will be told, and till Renu comes, I will be Renu. Okay. Dr. Kiran, you please keep the time for me.
Okay, we can start with the first session. Dr. Suboi, please, are you ready with the presentation?
Yes, ma'am, I am. I just want to share my screen. And good afternoon, everyone.
Deepika, can you please help her in sharing the screen?
Yes. Okay. Can anyone see my screen?
No. You're sharing yourself or Dr. Deepika will be sharing?
I was sharing it myself.
Yes, yes.
Okay, now we can see. I want to enlarge this.
Yeah.
Just a minute.
Don't get nervous. We will tell you when we start counting the time.
Okay, I'm trying to share. Has it come again? I apologize for the disturbance in the Wi-Fi today. I hope I'm audible to all. And it happens like the distress kind. Okay, can anybody see my screen now?
Yeah.
Yes, we can see. Yeah, you can do the slideshow.
Yes, I will. I'll just put it on the slideshow. Okay. So good afternoon, Judge, and apologies. Yes, ma'am.
Your time starts now.
Okay. Thank you so much, and a very good afternoon to all. My topic today is ethics in medical practice, and I will dedicate my presentation today to my medical colleague and to my parents who have taught me the best of ethics. Now, when I'm talking about ethics, when I was given this topic, so I had a share in my mind, and I tried putting it in words, and that's like, मेरी मोहब्बत की बात करनी है, एक समुंदर की बात करनी है, चंद मिनटों में कैसे समझाऊं, मुझको मेरी दीवानगी की बात करनी है. So it's like my divangi or my ashiqi, which I'm going to tell you. And because if there is no divangi in medicine, then you cannot be ethical. So either you get it in love marriage, जैसे हम बचपन से दीवाने थे कि हमें डॉक्टर बनना है, or your marriage has been arranged by parents, but you must put love in it if you want to practice, or just leave it. There is no two way. There are no gray zones in this. So if you're putting love in it, come in it. Because love it encompasses all. Because the word itself was derived from a Latin word that depicted the art of healing. And no art can be practiced without love. Whether it is cooking, knitting, or just anything in the world, every art requires love, and more so in medicine, because it is the energy with which you can heal your patients. And many times when you see the patients in labor, just your presence and your words can make the patient calm, and then she can deliver smoothly, the cervix dilate, the baby comes out. So I know all my senior doctors sitting there would have really thought about it and thought how we can influence as doctors to the patients. Now, where has the love gone? Very important to say about a line which I read is like, mohabbat ab tijarat ban gayi hai. The medicine has gone and it's lost its fundamental thing of giving. So you see that the culture is slightly crumbling, and there is more discontentment among the younger generation, and the profession's pillars are shaking. So we need to understand and see what our medical ethics actually were. So they were framed much more before the Hippocrates oath we took. It's like 3000 BC, which I was reading. And over a period of time, many ethics have changed in 18 and 19 and 2002. And many people have said how the pillars of medical ethics have to be really described. But the main crux was that we have to be in touch with our own humanity as well. We have to give respect to the person, do no harm, and we have to treat fairly all the patient irrespective of their status in the society. Now, what ethics actually mean? A concept of telling ethics to the doctors or to any other profession was that you have to differentiate from the internal core that what is right and what is wrong. And then you have to understand that how your profession actually meant service to the humanity, and which includes the service to God. So the financial gains become a subordinate consideration which has to be kept in mind of a practicing physician. We came to know that the happiness, the stressful environment in which we are going on to earn more and to do many hospitals at a time is leading to many bad decisions. And as we know that happiness and money are not directly related, although it is important to have money, but after a certain time, it has no direct correlation with happiness. So we have to see that contentment is an inside job, and medicine itself is a mission. It's not a lucrative occupation that you go and start earning, but how much of yourself you can give to the community in terms of doing voluntary services, doing the best for your patient, and taking everything out, whatever you have, to give it to yourself. Because you have to understand, after all this, you do not be in a rat race, because somewhere down the line, if we join the rat race, we ultimately turn to be one. And we have to rise above that. And it is not important how others look at us, but how we look at ourselves is very important. And we started this journey on high morals of doing service to the society, but somewhere we got lost. And you have to understand that how ethical practice helps you, because it maintains a clear conscience. There are lesser number of disputes between family, patients, physicians, and other parties. And you are better informed. You have better relations with other clinicians. You maintain efficiency and you reduce the burnout. You shine and you get more positive reviews, which in turn bring best out of your practice. Now, you will be having ethical dilemmas and challenges. It is like learning to drive your car well, but still having some accidents. There is medical vandalism is on the rise, but it no way justifies you to be not ethical, because you have to understand that this is a journey. And if it is done right, you will be having and overcoming many of the obstacles. There can be challenges related to euthanasia and do not resuscitate and psychiatry patients, which you can always go ahead and ask for second opinion and your other practitioners. So you have to have some tips for ethical practice. You have to learn to be compassionate and communicative to your patients. You know your limitations, seek information, network with colleagues, explain the charges beforehand, take second opinion, maintain records well, do voluntary work, and listen to your inner voice. Because in all this, you have to understand that you cannot pour from an empty vessel, because we all are worth loving. Make choices that are honoring and respecting yourself. So you have to understand that if you love yourself, you have to connect with the love within. And then you understand that medicine in future belongs to the love and the soul of yourself as well as the medicine, because the most effective medicine here on earth is unconditional love. And thank you so much for your patient listening, because you have to become your own hero. Look at your goals.
We are having some connectivity problem, but Suboi, that was direct dil se, excellent talk. So I will now invite Dr. Rekha Thakur. Let's see what she says about economics. Yes.
Good afternoon, everyone. Thank you, judges, and thank you, organizers and the sponsors, everyone, OBGYN Society of Rewari and FOGSI chairpersons, everybody for having me here today. The topic, how we practice ethics versus economics, is such a beautiful topic. And Dr. Subohi has covered so well about the ethics. Now, about the economics, she will agree with me that both ethics and economics are very critical to our practice, and we can't afford not to know about these topics. We can't afford to go wrong at any step while dealing with our ethics and our economics. But unfortunately, neither of the two are taught to us in our PGDs. But yes, the both has to go hand in hand. We cannot forget economics and only do charity service of being ethical. It has to go hand in hand together. Now we learn both as we move on with our practice. In simple word, economics to me, it means our relationship with money. In our profession, as we have to balance money, which is our income, with the way we practice and our patients' sentiments. The moment we lose this balance between the three, we are accused of unethical practice. And I'm sure Dr. Subohi will agree with this. We have to create the balance with the money that we take on from the patients and their sentiments, keeping everything within the umbrella of ethical practice. So the economics in our practice is a very, very sensitive issue, but we cannot forget that. Little insight on economics. Now, as we doctors are into two groups, half of them are salaried doctors and half is private doctors, which we are private practitioners. Both have different economics. The first group, the salaried doctors, have a fixed salary and they calculate their expenses depending on the salary amount they take every month. But the second group, the private practitioners, should ideally be doing a reverse calculation like all other businessmen. The calculation starts from calculating all expenses first and then see how much money I make every month to meet these expenses and how much do I need more. Very few of us actually practice this way, or the fact is we don't even know how to do the calculations and we fail to define our plan of action in our practice. The moment we fail to do the calculations right, we go wrong somewhere in creating the balance. And that is where we are accused of unethical practice. Very few of us actually practice this way. Everyone in this room will agree with me that we want to make money. Yes, we do. We put in our efforts, our knowledge, our skill, and our time, and we want money in a return. Without that, we cannot survive, we cannot lead our family. In other words, we want to be paid for our services, and we promise to give patients the best of services. And this is called business. Yes, money in return to any service is business. Which industry? Yes, we belong to service industry, and I provide my services and I expect money in return. And I'm not doing charity. The language may sound very different to you. Some may like it, some may not. But this is economics. Doctors and private practice, let us start thinking with a business mind. I am a part of many business networking groups, and I've done business management courses to understand how to create this balance between my practice, my patient's psychology, my patient's expectations from me, and my calculations, keeping everything within the boundaries of ethical practice and also make money at the end of the day. With my experience, I can say that our approach towards our practice or our mindset has to change a little bit. I suggest 3 most important changes that can change the economics of our private practice. And I have made in short, I call it MCD. M stands for mindset, about the money. C stands for our calculations in our practice. And D stands for how we deliver our service to our clients. When I talk of mindset, if I just give you a small example, if I say that I want to make, if I say that I make only 1 lakh rupees in a month, and I'm wondering how can I make more money? If I talk in this language, people will think that I'm a money-minded doctor. But if I rephrase the same sentence and talk to our colleague, I'm not talking about money talking about money to patients. No, within our community, about our practice. So if I talk about money to our another doctor that I'm making only 1 lakh rupees a month and I want to make more money, I'll be called as money-minded doctor. But if I rephrase this, say I see only 100 patients in a day, in a month, and I want to increase the number and see more patients, I'll be called very nice doctor. So this is all about how we rephrase it.
I have to tell you, Rekha, you
Yes,
have finished 5 minutes.
Yes, ma'am, I'm finished. Yeah, thank you.
No, complete it.
Yes,
ma'am. 5 to 7 minutes.
Sure. So don't you think that we have to change our mindset and start talking about money and setting our economics right? Yes, talking about money should be within us and not with the patients. Always let your team talk about money, not talk about money to the patients directly. Let your team members talk about money to the patients, because that will be ethical. But let us change our mindset to believe that talking about business or money is not a crime. When I talk about my income or my earnings or I need more money is not a crime. We are in service industry and wants to be paid for our services. Only then we can set a cost of each service, provide them and justify the cost of our service. Let us not underestimate our own value, rather feel proud to justify the worth of our time and our knowledge and our skill. The second point is calculations. Yes, we should learn how to do business calculations for our own practice in numbers, and also learn how to set goals and achieve them. This will help us justify the cost of our services, document them on papers, and make it legal so that we are not called unethical practice. Once we document the numbers, we are called ethical practice. I can fix any amount for my consultation fee, it's my right. But once I document it and put a transparency to the patients, it is ethical. How we deliver our service is the most important of all the 3. Once we master the art, you can charge any amount for your services, but you have to know how to politely deliver the service and efficiently deliver it. You will never be criticized. You will never be questioned, and you can also make money. We have to learn the art from the experts of hospitality industry. Friends, we are talking about economics and money. Let us not forget about the patient's trust, their sentiments, their privacy and transparency in all this. This should always be the focal point of our practice. Thank you all.
Thank you, Dr. Rekha. That was wonderful, but I have to point out that you overshot your 7 minutes.
So
no problem, madam. Basically, कैसा है? पैसा भगवान नहीं है, पर पैसा भगवान से कम भी नहीं है. This is the sentence everybody says like that. So this debate was very great between these two good doctors. Now we will go on to another topic where we practice corporate versus individual institutions. I invite Dr. Indu Bansal for her presentation.
I have told my debaters not to spend even a minute on thanking anybody.
Yeah, obviously.
Good afternoon, everyone. So first of all, thanks for having me here, and let me share my presentation now.
Starts now.
Yeah. So I'm Dr. Indu Bansal, and I would be speaking about the corporate hospitals, and I will speak about we need to deal with certain, the obvious and the unspoken. So I can say that I have worked in both the setups, corporate experience close to 19 years and individual practice close to 17 years. So I can talk about both. And my big hello to Dr. Hrishikesh and everyone who is present there. So the individual practitioners, they always have they view corporate practice with a limited lens, and I'm going to change that today. The art of medicine consists of amusing the patient while nature cures the disease. So for both the corporate as well as individual practices, there are multiple pros and cons, and I'm going to talk about all of them one by one. First, talking about the pros, about the benefits. So because corporate hospitals, they have the state-of-the-art technology, they can afford to have world-class equipment. So technology adoption and upgradation is possible, which leads to improved diagnostic outcomes, high-tech treatment solutions, more hygienic and pleasing interiors, and of course, it leads to improved quality of life of all the patients. And in fact, if you are very good in your work and you are taken up in a corporate hospital, then getting that instant diamond-studded crown is easy because these people select the best people in market. You get instant name, fame, and recognition, and with it comes a very good pay package. You don't have to slog really hard for every patient, and you get walk-in patients as soon as you join. And some minimum guarantee of salary as your negotiation skills. Apart from that, remember, if you do your work well, you always get the support. So you have the marketing support, staff recruitment is handled by the hospital administration. Administration of the hospital is handled by administrators. So as a clinician, you can focus only on medical aspects and give the best treatment. So high earning potential, as many people slog with the common motive. So there is, which leads to higher revenue for hospitals and as well as higher earning for doctors. So it's a win-win situation for both. There is more flexibility of movement within the group and other groups. So let's say, suppose if you are practicing in Gurgaon and you want to move to Bangalore, then you can move within the same group as well as you can move to different other corporate groups. So the options are unlimited. So advanced treatment are available, and that's not just for the paying patients, but also for poor patients or people with insurance coverage, because these hospitals have all these facilities of CGHS, CCHS, DGHS, railways. And apart from that, they do some CSR services also. So doctors are able to administer latest treatments and medicines, which otherwise many patients could not have been afforded. And remember, you can always build your own team, and everyone gains from teamwork. It leads to a quality of work improvement. And of course, collaborative research is always so much possible. So sometimes, so many times you get stuck up in clinics when you don't know how to manage a patient. But while in a corporate hospital, continuous improvement is always there because brainstorming is possible. Training in CME while working is there, cross-discipline between the team of doctors, and there is cross-fertilization of learning. Apart from that, you never go home without learning something. Every day you learn from your colleagues, interdepartmental meetings, intra-departmental, intra-hospital, inter-hospital, and across countries research is possible. Clinical trials possible because of so many intellectuals, and you always get funds and grants which are otherwise not possible in an individual practice. Teaching and academics is possible. Quality of work is better as SOPs are already in place, and ethical committee approval you can always get. You have PG students, DNB students, seminars, journal clubs, tumor boards, multidisciplinary meetings, and of course you have EMR or easy access to all information on fingertips. We all know that for medical legal things, electronic records are very, very much important, and the medication errors are less, investigation reports are available at fingertips, and protection against medical legal cases is more there because of these health records, and research is possible. So, and remember, corporate hospitals are your place of rescue whenever you fall in trouble. Any patient who can't be managed at standalone clinic or small center can be referred to a corporate setup for better management and saving lives. So going on a holiday is also possible because you have people to give you backup, because otherwise closing your clinic is not possible. So some me time is possible even without losing revenue. So I see that risk of medical legal cases high because the cost involved here is high. So insurance and litigation risk are there. So sometimes unnecessary investigations may be done rather than reliance on good clinical acumen. But mind you, legal protection is also better in corporate setups. So what is not so good about corporate life? Now, some hospitals, most of the people believe that some hospitals may give you targets to fulfill, because life in a busy hospital can be very demanding with very long working hours and immense stress, as expectations of bosses, colleagues, and patients is very high. Sometimes it may lead to mental breakdown. But let me tell you, in my career of 23 years, I have been fortunate enough never to have worked under any such organization which has given me any targets to fulfill. So these hospitals need huge investment, running cost is high, fixed expenses are there even if hospital is not earning revenue, profit over tax margins is low, return on investment is only 5 to 10%, money on credit is high, cash inflow is low, so there has to be a very, very delicate balance between investment as well as profits. And you are always under the scanner, even by people who are not doctors themselves. So the marketing team, the finance team, and the administrative team, they would always be keeping a watch on you. Even your mother-in-laws may be better than them. Beware of jealous colleagues. Risk is more if multiple units of specialty are existing. Risk of patient being frisked away from the reception itself is there. There could be friction between competitors. Unhealthy work atmosphere may be there. Internal politics is a big issue, and you could be an innocent victim. So you have to keep an eye on all these factors as well. Remember, comradeship is a must, because difference of opinions and friction have destroyed many careers. So my advice is argue for the reason, but not with the person, and don't ever take differences to heart. Also, as early you rise, as early you may fall, because management people are rarely doctors. They are sometimes hardcore businessmen. They might harass you if you're not a big revenue earner anymore. And sometimes they are hired to cut down every single penny. And some organizations believe in divide and rule policy. A little mistake and you can be chucked out anytime. So there is nothing like permanent job these days. There can be a junior who can occupy your chair, and sometimes it's like wife. Fault will always be yours. Difficult to help real needy and curable patients, because economics plays a role in corporate setups. Ayushman Bharat and other privileges are not available at every hospital. So moral obligations to help these patients may not be fulfilled always. So some tips for survival, so that the hospital, the doctor, as well as the patient, everyone gets benefited from these corporate hospitals. So don't be in a hurry to jump from one place to another. Have some stability in job. All corporates are not the same. Choose the right place. Search for pro-doctor setups rather than business-minded organizations. Preferably go with a team. Never ever compromise on your ethics. Keep on building your network. Never ever be complacent in your work because you can be replaced easily. Negotiate well after proper research. Mind you, never ever demand too much which you will not be able to fulfill, and never demand less than you deserve. Value yourself or they never will. Document well. Get your signed written agreement before you join and read it well, and get your legal experts go through the document beforehand. Please remember, ego doesn't work at the workplace. Never think you own the place or you are indispensable. Love your work, but don't marry the workplace. You will never be the boss. Your boss will be your boss always. And please never work for money. We had a debate just now on ethics versus monetary benefits. I say follow your ethics, money will automatically follow you. And please, please nurture your patients and colleagues with real empathy if you want to flourish. As somebody said, you have to have butter soft relationship with your patients and your colleagues and your management. Work-life integration is a must. Don't be in a rat race. Publications and money can wait. Prioritize your family and de-stress with hobbies. And at this time, with so many litigations happening, work on alternate sources of income as well, which should be ethical definitely. And please support your fraternity. Never ever criticize your colleagues in front of patients or anyone. Support them whether they are in individual practice or in corporate practice. Only then we all can work together. So I can say that neither an individual can practice without a corporate, neither a corporate can practice without an individual practice. We have to coexist and help each other, and at the same time manage our patients with utmost compassion, empathy, ethics, and moral values. That's all that I have to say. Thank you.
So officially you have overshot your time. That I will leave to the judges, but excellent.
Okay.
The last speaker for the day is Dr.
Kirti
Sharma.
Dr. Kirti.
I'm here. Should I start sharing my screen, please?
Please, please.
Okay. It's very nice to meet you, Dr. Indu. Thank you for the wonderful talk. And I must thank Dr. Mitra before starting, even though she said don't thank anyone. So my topic for today is where we practice and an individual-owned institution. So I represent the smaller ones. So first, to start with the bigger picture, as of today, 70% of hospital beds in India are currently physician entrepreneur run. They are also known commonly as community hospitals. Now, approximately 40,000 or more such hospitals exist in India. They are typically 20 to 40 bedded. And most importantly, they are the main source of healthcare delivery systems in tier 2 and tier 3 towns. Even though there is a lack of formal structure in which they can be integrated, which is a major handicap as of today. So against this, what has been my personal experience? I work in a very humble institution in a place called Kalavati Hospital and Kamla Nursing Home. We mainly cater to women and child health, but we are an NABH accredited institution, which has been in the field for 30 years. Now, ever since 2013 and 14, when we joined the institution, we've brought about some changes. We were initially 10 to 25 bedded, and we went up to around 25 and 45 bedded. We introduced a pediatric intensive care setup, a neonatal intensive care setup, with an endoscopy upgrade, with an IVF center, which now does even pre-implantation genetic screening, and a fetal medicine center and urogynecology. Now, the reason I stress this point is because one of my major concerns when I joined this hospital was, will it take care of all the ambitions that I have for bringing in multi-speciality care? And now with more than a 15-bedded neonatal care unit and an IVF center, which can do pre-implantation genetic screening with a very good team of embryologists, I'm very glad to be able to do that kind of work and involve people instead of trying to do it all ourselves. Also, with my training in fetal medicine, we are now being able to give those services. Now, in my experience, what are the advantages that we can offer patients being from such institutions? And my faith in these institutions has improved greatly because of the kind of trust that that is easy to build with patients, because you've been here for a while, you're a part of their own community, and they see you every day, they know these institutions. There is a definite ease of access for the patients to both healthcare staff, to the services, to the doctors, which don't exist in corporate institutions. What we can offer, which is very difficult in other institutions, is continuity of care. So when we talk of PCOD clinics or cerebral palsy or urogynecology, these are services where patients need to keep coming back to you, and it really helps if they have a steady system to take care of them. Preventive and public health interventions. Now, sadly, because public health institutions can only do so much, these institutions also fill a very important gap when it comes to some services like PAP screening, vaccinations, and such. Also, for independent fields such as ophthalmology and dermatology, it is much more beneficial for them to have a smaller setup than to be a part of a corporate essentially always. As far as the economics is concerned, now, even when we were expanding, we had the choice of going to a higher bed institution. But the realization was that the moment you go more than a certain number of beds, the overheads are so much that the costs to the patients increase drastically. So if you can stay limited, but at the same time offer good quality care, you actually remain significantly cheaper for patients. So even though Gurgaon is just an hour away for us, we can now offer satisfactory and a high quality service at much cheaper costs, because without underpaying our staff or ourselves for that matter through this. Now, advantages to doctors. So I thought we should start with patients first, because I seriously think that these institutions are extremely beneficial to patients. I also think there are certain advantages to doctors. As I said, I started from a mindset where I thought corporate setups are much better for doctors. But now being here and being able to do the kind of things that I am, and with the kind of job security and support, I do feel that private institutions offer a lot of advantages for doctors. First is investment in high quality equipment without bureaucratic red tape. If I want to buy a good machine today, I can go ahead and do it without having to go through and justify my choices to management, or try and reach targets for patients on or how many I would need to kind of meet my aims. And I can at the same time decide, okay, let's curtail expenditure on advertisement for now and invest in equipment, and then we'll take care of that later, or something like that. Because I have the freedom of being an entrepreneur. I can be creative with the kind of work I do. I can be creative with the collaborations that I seek to make. And so I have the kind of freedom as entrepreneur that is not exactly existent in those in corporate setups. I can also offer individualized care to patients. So if I have a patient who cannot afford but has been a long-term patient with me, it is immensely satisfying to kind of give them the kind of cuts that you can, and I don't have to justify my choices to anybody or go through any bureaucratic chain. I have that control on revenue inflow and outflow. Now, as far as work-life balance is concerned, now work-life balance can be an issue in a private setup, but in the long term, when you're going through different phases in your life and you can choose to do how much work you want to and involve other people or take help, I think work-life balance also in the longer run is actually good for doctors within these setups. And as ma'am also keeps saying, think big while being small. So one of our concerns was, will we be able to do research? And we are proud to say today that we've been a part of startups like INICU, which is a software-based for monitoring neonatal care, and also managed to now have publications in international journals, index journals. And this is highly reputed, and it has given us a lot of recognition. We are now collating data on fetal heart rates, and hopefully we will be able to be a part of something bigger. So now with the kind of collaborations that you can get into owing to the internet and social media, I think research and high quality research is also immensely possible while being a part of these small institutions, and you need not feel like you don't have those opportunities or you lack somewhere like that. Of course, disadvantages. Now, disadvantages will always be there. One of the ones that we faced is the public perception of being small. Now, even though we are an IVF center and we are, it's taken a while to change public perception on being locally, on getting those interventions done locally. Even now, for people to refer to our centers for something like amniocentesis is a big thing, and we understand that because patients, it looks small, and that is a mindset. It is a challenge to change that. Multi-speciality service requirements. We, of course, cannot accommodate multi-speciality service requirements, but given the right kind of referral networks, we do manage to have patients who we can take care of in partnership with other bigger setups. There are definitely much more increased administrative responsibilities for doctors, which is a problem and which can lead to early burnout, which has to be addressed. But if you develop a nice community, like I do think we have within Rewari IMA here, then it does lead to a lot of help on those lines. There are rising instances of litigation and violence against doctors, definitely, where again it needs more of network to handle this, and it is definitely more challenging if you're a part of a single, a private network like this. Government antipathy and policy directed towards corporates. This is something that I do believe, because as I said early on, 70% is what is the kind of strength that we are. But all policies today are either catering to corporates or talk about criticism of the public health facilities or increasing funding there. Somehow this is the part that gets missed out. And given an opportunity, I do think that these private setups, which have been so instrumental ever since independence in forming that backbone to healthcare in India, if it can be integrated in a proper manner, then we can probably form the backbone of what can be like a unique Indian model of healthcare, where we need corporates, we need our public health system, but handling chronic illnesses, handling specific specialties, and offering that reduced costs and the benefits to the patients, which will always remain so essential in our country. So if we could be integrated in referral systems, if we could have government support, if we could have a special policy catering to us alone, I do think that private setups are really here to stay, and they should be made an integral part of our health system going forward. Thank you so much. I must thank my teachers. If I can't verbally, I'll just put up a slide there. Thank you so much.
Excellent. So that was very, very nice. Actually, I'm telling you, dear debaters and the audience, I stopped looking at the watch because I thought ye samay ki pabandi nahi kar sakenge. Yes, we have to start the next session in another 5 minutes. So before the judges come out with the judgment, we will have an audience interaction. There are 4 questions. Dr. Deepika, please hold out the 4 questions. Let's see how quickly the audience answers to the opinion poll, while Dr. Ajay Mane and Dr.
Poll 1.
Dr. Kirti, can you stop sharing?
I've done so, ma'am. I've stopped sharing.
And Rekha.
Dr. Mitra, I would like to share my slides because I made them with love.
Ma'am, poll 1 is there. Poll 1 is there. Requesting all the attendees to please answer. Do you think that ethical thought process gives you more certainty that you are doing the right thing? You may answer by yes, no, or maybe. So if you're in doubt, you could also give maybe. Do you think that ethical thought process gives you more certainty that you are doing the right thing?
So all the audience, please give your poll so that the next question can be fired.
So this poll is over. The answer is yes by 97% people, and 3% are still in doubt. So we could go to the next question. Poll 2. Should a clinician also be worried about the economics part? You may answer yes or not necessarily. Okay. 10 seconds over. So now we can see over here, Amit, you may stop the poll. 83% are saying yes, they need to be worried. And the other 17% say not necessarily.
Oh,
next.
Still the mind hasn't changed. Dr. Rekha tried very nicely.
So if given a chance, will you join a corporate hospital? Yes or no? After this debate, if given a chance, will you join a corporate hospital? 10 seconds are over. Amit, you may stop. 40% say yes, 60% say no. The next poll, we go to the next poll. Are corporate hospitals the best model for healthcare provision? Yes, no, or maybe. People in doubt can also answer maybe. Are corporate hospitals the best model for healthcare provision? Stop the poll now. No is the main answer, and there are about 58% saying no, and maybe is the answer by about 29% people. Yes by 13%. The last poll coming up is individually owned hospitals are an integral part of the Indian system, medical care system. Yes, no, or even still in doubt, maybe. So I think there is still some doubt coming up. Most of the people are going with yes. So we stop now. Answer comes to 93% saying yes, they are an integral part, individually owned. And a few also are in doubt, maybe is by 4%. Thank you. Thank you, audience, for the poll.
Very nice questions, ma'am. Very nicely.
While Dr. Ajay and Dr. Savita and Dr. Kiran are compiling, I take this opportunity to welcome Dr. MC Patel, sir. Sir is our very, very senior medico-legal person and a guide and a mentor to me. And thank you, sir, for joining in. I will be doing the official introduction later, but I wanted to acknowledge that, sir, you're here. Thank you so much. So now over to you, the judges.
Yes. We have compiled, I think, Savita ma'am. Can we declare that? Yeah, please.
So now the time has come to just announce. First, I congratulate all the speakers. They have done good job and they have taken their subjects very well. And it cannot be said that one is first or second, but we have to announce something. So they should go back with that. They have done perfect jobs for their topics and they're explaining the corporate pros and cons very well, and of the individual hospital, and Dr. Suboi about the ethics and economics, the other part. So nobody will go, but we have to announce the results for the first group about the ethics and economics. Dr. Suboi is the winner out of the two. So we can give a big clap for the Dr. Suboi.
Thank you so much.
For second group, Dr. Ajay can announce.
You please, ma'am, continue.
Yeah, for the second group, Dr. Kirti, she is the winner. Though Indu has also done a very good job, but Kirti has a better winner.
Thank you, ma'am.
Okay.
Congratulations to all both the winners.
Thank you.
And a big clap for all.
And I must say that the difference between marks is very less. It's been 2 or 3 marks only. But see the individual marks system, it gives the result. But everybody spoke very well. They have presented their topic very well.
Thank you so much.
And we have ignored the network issues. No problem about that.
Thank you so much.
Congratulations to all the debaters, and thank you, Mitra ma'am, and thank you, Manish bhai.
I want to also give my assessment.
Yeah, please.
I want to say one thing, that हम छोटे शहर से हैं और हम एथिकल हैं, सब कुछ हैं, पर मैं ये कहना चाहती हूँ कि जो मैसेज इंदु ने और रेखा ने दिया है, that was very, very important message. I know कि they are in the tougher part, but in रेखा ने जो बातें कही हैं economics की, all of us in private who are ethical, don't sit on your high horse. Rekha has mentioned extremely good take-home points, and so also Indu. Indu has done a wonderful job about highlighting the good of corporate and combating the negatives of corporate. So from my side, all 4 are winners.
Yes.
And these
Thank
two
you.
Can I comment?
That's why I wanted to share these slides, the leftover slide with you, because we and Indu have been doing lot of things. So I just wanted some things.
Just as a judge, I want to say, remember these 3 things as told by
one thing.
Yes, Savita ma'am is saying something.
Because this, both your topics are complementary to each other. They are not adversary.
Yeah.
We have to make a balance between 2 things. We have to make a balance. That is the thing. Nobody is unethical if economics is good. His emotion has to go from here. That a doctor who is earning money is unethical. This notion should go. Till this notion is there, public is really asking, doing atrocities on us, because
Dr. Yeah.
we should do the
Dr.
feeding.
Rekha's message very nice, that MCD, mindset, deliver, and so mindset should be such a way that you should set your mind in earnings to some limit. It should not be in crores, so that to make ethical practice.
Whatever it is,
so mindset should be in that way.
Do ethical practice, money will follow. That is a real thing. But if
mindset should be such a way that only after ethical practice it should be done.
And Mitra ma'am, Mitra ma'am,
डॉक्टर पंजुपुरी कह रही हैं.
मित्रा मैम, आपकी ये बात कि हम छोटे शहर से हैं बिल्कुल गलत है.
बिल्कुल गलत है.
अभी सबको ये पता चल चुका है कि महेंद्र सिंह धोनी, सुरेश रैना, रविंद्र जडेजा ये छोटे शहरों से ही आते हैं जो वर्ल्ड कप जिता के देते.
सही है. क्या बात.
ये आपके 4 वो लोग हैं जो आगे जाके फॉक्सी में बहुत ऊपर जाएंगे. एंड देन वी ऑल विल सिट एंड फील प्राउड ऑफ देम.
Great. And at last I must say one sentence. All parts are very good at their own places, but the winner must be the patient. That's all.
Yes.
डॉक्टर किरण, आप भी अपने कुछ व्यूज रखिए प्लीज.
Everybody has spoken so well and they were right in their aspect, and thank you so much. And I was really surprised by the views of all the Dr. Subbuhi, Dr. Rekha, and Dr. Indu and Dr. Kirti. And I'm really congratulations to all of you, and you are all the winners, and your thoughts are very good.
And special prize to Dr. Indu Bansal. I am extremely impressed by your presentation. I don't know how many of you have appreciated, but it was one of the most beautiful presentations. I have never seen itne खूबसूरत images.
स्टैचू लेके आए, वो कहाँ से लाए थे देखना पड़ेगा. स्टैचूस
every slide मुझे चाहिए वो PPT दे.
Every slide contains a good statue.
चलिए, thank you so much.
Thank you very much.
I would like to thank everybody here to really understand my the message that I wanted to give across to every one of you. So thank you so much, and the topic was very close to my heart. Thank you.
Thank you. So I will now.
वही की स्लाइड तो दिखा दो एक आध.
अच्छा मैम, दिखा देती हूँ. मैं स्लाइड शेयर कर लूँ.
मित्रा, सुबोई की स्लाइड दिखा दो एक मिनट.
Please,
मित्रा,
let's
सुबोई की स्लाइड शेयर करो.
join Dr. Patel and all the panelists are waiting. I am extremely sorry. At the end we will show. Let's just go on with the
Or I will forward.
Yeah.
Okay.
We'll put it on the group. Don't worry.
Okay. Thank you so much and bearing with me for the power toss also.
Last, but not the least, an extremely important session, the session 5. No discussion is complete till we get to understand at the very basics. All of us are facing difficult obstetric situations and how to deal with them safely, securely, medico-legally. To present this panel, we have none other than our very respected senior member, Dr. M.C. Patel, sir. Sir is a medico-legal counselor. He is the Vice President of FOGSI for year 2018, Organizing Secretary for AICOG 2017, Chairperson of Ethics and Medico-Legal Committee, FOGSI 2011-2013. And the most important thing, there are so many things that he is part of and he's leading those associations. But what I want to tell every FOGSian is that sir is just one phone call away. So Dr. M.C. Patel, sir, please moderate this panel and we are all for you.
Thank you, Dr. Mitra, for kind words. And at the outset,
Dr. Deepika, yes.
So at the outset, I would like to congratulate you, Mitra, and your team for excellent conference and good going. So let me introduce my panelist, Dr. Nikhil Datar from Mumbai, who has a very pioneering work as far as MTP Act is concerned, because long back to make MTP available for more than 20 weeks. He was the one of the pioneering work from Dr. Nikhil Datar, and he has worked with me as far as uniform consent is concerned. Just yesterday only in inauguration session, President Dr. Alpesh Gandhi also mentioned that we are coming with some uniform consent, and we have tie-up with Maharashtra Law Commission. And retired judges has also given us green signal that whichever uniform consent we have prepared, Nikhil Datar, Dr. Dilip Walke and myself is okay, and it will be soon available for our FOGSian friends to their practice. So next, Dr. Girish Kumthekar from Solapur. He is also good old friends and a very person to speak very truth on face. So he is known for this and he is good friend, and he has traveled with me in so many conferences as far as medical legal workshops are concerned as a faculty. So welcome Dr. Girish. Yes, next. Girish and Nikhil will be both expert panelists. Dr. Vibha Mishra, very senior gynecologist from Varanasi, long back in almost 2011 or 12. She had organized one full day workshop as far as medical legal consequences are concerned. And I was part of that conference and organizer with Dr. Vibha Mishra. So welcome Dr. Vibha Mishra. Rasmi Sharma, due to some familial problems, she is unable to join, but she has conveyed our conference all the best. So next, Vinit Nagpal from Chandigarh. She is also a good friend, and she has also traveled with me in so many of our conference physically and virtually, and she is also very learned panelist as far as medical legal parts is concerned. So welcome Vinit. Next. And Venus Bansal from Ludhiana. I have visited thrice Ludhiana, and all the time I have seen Venus working very enthusiastically. So, and she is also good panelist. So welcome Venus Bansal. Next. And of course, Dr. Promila Jindal Madam from Ludhiana. Yesterday only we had a good chatting on phone also. And she is also very learned faculty as far as this field is concerned. So next. So, and one more faculty, Dr. Kiran Pandey from Kanpur. I have visited Kanpur also thrice. And for all medical legal workshops, she was always with me. And she is also learned speaker as well as panelist. So welcome Dr. Kiran Pandey to this panel. Next. And one more learned panelist, Dr. Anita Sabharwal from South Delhi. She is Secretary of South Delhi Forum of Gynecologists and doing marvelous activity as far as academic part is concerned. I have visited South Delhi under her leadership for so many workshops, and she is also good faculty. I have invited her for so many medical legal workshops, and so she is at par as far as medical legal part is concerned. So welcome Dr. Anita Sabharwal. So I am lucky that way that I have very rich panel to interact as far as this panel discussion is concerned. So greetings from Statue of Unity. I think my screen is visible, na?
Yes, sir.
Yes. So tallest statue of world, and we all Indians are proud of that statue. So warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank Rewari Obs Gyn Society and North Zone Medicolegal Committee under able leadership of Dr. Mitra Saxena. She is a good old friends, just like my younger sister. And whenever I have visited Rewari, I never stay in hotel. I usually stay with Dr. Mitra's house, and I am always blessed with her mothers also. So thank you, Mitra, for giving opportunity. So practicing obstetrics safely and medico-legally. So bridging the gap is the title of the conference also, and when I talked to Mitra for this particular panel. She had given me this idea that bridging the gap between patient and doctors, and we know there is deterioration of a doctor-patient relationship, and why this is happening or why this has happened, and which are the ways we will go with this panel. So welcome all the learned panelists and expert panelists, Dr. Girish and Dr. Nikhil. And this is common dictum from Dr. Manish Machave, Chairperson Ethics and Medicolegal Committee, and I am proud that when I was heading this committee, Ethics and Medicolegal Committee, FOGSI, he was member in my committee, and I have seen him working since then. Of course, we have traveled a lot all over India as a faculty as far as medicolegal workshops are concerned, but he's a very hard-working person. So all the best for all the future activity, Dr. Manish. So Manish always say, I never learn from somebody who agree with me. And I also admit that if two people agree on everything, then one of them is not required. So as far as panel is concerned, our panelists are not such, they will agree with everything and whichever is said. So many a times I start my panel or my talk with this, is it worth discussing? Always yes. Why? Because medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first as far as this medical legal consequences are concerned. And this is ठोस reality. अगर आप सुबह से भूखे हैं और रात का खाना भी आपको नसीब नहीं हुआ, तो जरूरी नहीं आप गरीब हो, आप डॉक्टर भी हो सकते हैं. So this is our practice. So let us start with panel. This is real case happened in city of Ahmedabad only. It was case of lower segment cesarean section, bilateral uterine artery tear. C was RH negative. Blood was not ready. Cross match was not done. During shifting patient to municipal medical hospital, patient expired. Notice was served. Case was filed. This is one part of story. On other part, as far as doctor's part is concerned, she had advised elective lower segment cesarean section 4 days back, but patient and relative refused, came in emergency at 11 p.m. at night. She tried to manage for blood as it was RH negative, but she couldn't manage in time, and whatever happened is the story. So inference held in the court in this particular case, PM examination, intra-abdominal hemorrhage following negligent surgical procedure, no blood kept ready, medical record not to be believed because report of gynecologist and anesthesiologist is contradictory. In note of gynecologist, she wrote vitals were within normal limit and anesthesiologist wrote vitals were compromised. So court didn't take it in a good defense. So my question starts with where thing went wrong. So when patient and relative refused or consent, does it any inference in our favor if this type of cases when we are facing in court of law, any panelist can take? Refusal of consent.
So refusal of the patient is the right of the patient.
Yes.
So patient can refuse it. It is the right. The important thing here is that does they understand the consequences of refusal? That is the important duty of the doctor, that they have explained her properly or not, because that is the issue. Have they it has been documented or not? Have they been told that if they refuse, what all can happen? What are the complications possible? Patient was RH negative. So were they told about it, that the blood might not be ready in emergency? Have they arranged any donor? RH, some donor is ready for that. She been counseled? They've been counseled for that. And has anything taken in the written form? they've been told that if the blood will not be there, this facility is not adequate for emergency cesarean section or emergency complications. Cesarean section they have been doing, but what complications may happen? Is it possible for them to be dealt there? So the basic thing is the refusal is a right of the patient, but have they been told all the consequences in detail and in writing, documented or not? If they have been documented, they will go in favor of the doctor.
So very good, Kiran.
I would like to add one thing.
Yes, Pramila madam. Yes.
I'll say that in refusal, there has to be a proper rapport between the patient and the doctor. In case the patient has been a regular patient with a regular antenatal checkup, I think within 9 months, the patient develops a good rapport and confidence with the doctor that whatever doctor says is good for her. This generally happens when patient is coming just on the one-time visit and you straight away say that you are requiring the elective cesarean section. There the confidence between the patient and the doctor does not dwell.
Yes.
So
yes, Venus?
Sir, I want to add one thing here is that refusal for the elective, yes, very rightly said, is a choice of the patient. Refusal for life-threatening situation is not there. Suppose there is a placenta previa bleeding. Her refusal is not going to be of any importance. But a patient elective surgery counseling and the date finalizing, there can be surely a refusal from the side of the patient.
Yes. So, Vinit wanted to add something.
Sir, the documentation part for the negative consent of not doing of not taking up the cesarean section as advised by the doctor in full detail. So the negative consent has to be documented, sir.
Yes. So if a patient or relative asks, so if we do not go for cesarean section, so are we under obligation to explain about alternative modalities of treatment?
Yes. Yes, sir. Definitely.
Definitely yes. We have to. And if she refuses or relatives are not ready to give consent for cesarean section, naturally we have to document it. And we have to get a signature that in spite of all this explanation on part of doctor that cesarean section is very much needed, but we are not willing to give consent. So would you would like to document it? But say for
just
example,
one adding. I would like to add.
Kiran, 1 minute. Kiran. So in few of the cases, even if they are not ready to give signature of refusal of consent also, then what will you do? Yes, Kiran.
Yes, so for the first point I wanted to add, if better it would be that consent should be taken in front of some other health facility also, because patient might say that this consent was taken in a force or something. Considering these days the litigations, it is always better if some other health personnel or otherwise a non-concerned person is there. As for the second part, so you asked if they don't give the consent, refusal consent also. In that cases, this happens into the medical college many a times. We explain to the patient, they don't give consent and they don't also write the negative. In these cases, what we do is we try to talk and communicate in front of the other patient's relations, or we call somebody who is little understanding and cooperative, and then we make a 2-3 doctors, one sister along with, and if possible 1 or 2 relatives who are close by. So like many, if the other persons are also giving this, we write it down, take the signature of all the many persons like doctors, sisters, other staff, or if possible other relatives. Then it becomes easier to.
Yes, Kiran, would you like to sign as
I think along with it, we should write on that very consent and in the
So
presence of other
on case
people,
paper,
that
everything
the
should be
relative
well written, that it was explained to the patient, but patient
it
is
should
not
be well
willing.
documented.
And any co-patient or any other visitor to the hospital should sign as a witness that in our presence it was explained to the patient and relative, but they were not ready to give consent. So I think enough discussion we have done. Let us move to one more thing. So proper counseling and negative consent, it is very much needed. So what is proper counseling, what is importance of consent and negative consent, we have discussed well. And in prior also, Dr. Narendra Malhotra has delivered very good lecture on consent. So let us move to another. One more thing, this type of case, RH negative or so, should manage in small nursing home, or can one refuse to treat if in emergency patient is brought? Patient is RH negative. You are unable to manage for blood or to manage this type of patient. So can one refuse to treat, or can one select the patient?
I think in these type of cases, the operating surgeon should properly assess the patient before taking her up on the OT table. If she feels like in this very case, in case she would have, I don't know what was the real condition, if she is anemic and she is RH negative and the surgeon feels that yes, she might need a blood, then she should not take up this case. Or if she takes it up, then she should have the arrangement or tie up with some blood bank so that in emergency she can get the blood. If she does not have that tie up, then in my opinion, she should not take up these type of cases, high risk cases.
In many
she should assess herself, her clinical infrastructure.
Yes. So in so many situations it happens at night hours. Patient is brought by old mother-in-law and no responsible person is with patient. Many times it happens with smaller nursing home. And in this type of situations, you have to take decision. So whether one can select patient to treat or not to treat. Yes, Kiran?
Yes, sir. Sir, officially we can have the right to select our patient except as per MCI rule, but except in the emergency cases. If the patient has come collapsed or bleeding something, then as per rules, she should be managed. That emergency part should be managed, and they should be that the rest of the thing, the facilities are not here, and you have to go to a tertiary center. If you agree to this, then we will be able to give you the emergency service.
So it is very clear that if it is cold case, then you have option whether to treat, whether not to treat. But if it is an emergency, you have no option and you have to treat. So let us have this reference. On 12th of August 2014, in Parliament, question was asked and Honorable Health Minister Dr. Harshvardhan had replied this: no physician shall arbitrarily refuse a treatment to a patient except where the patient is suffering from an ailment that is not within the range of experience of treating physician. But in the later cases, the physician may refuse treatment and refer the patient to another physician. But in this type of situation, required to stabilize the emergency medical condition of any individual who comes or is brought to such clinical establishment. So here, one more thing, to stabilize. So you are under obligation to stabilize emergency patient, and then only you can refer patient to another center. But here the word stabilize is also not defined. So whom you will say that patient is stabilized, again it is a gray area. So in this particular question, it was very clarified, and we are under obligation to give golden hour treatments if we are suffering, facing a emergency patient, and then only reference. But many a times it happens when we are giving this type of golden hour treatment and patient may expire during this treatment part only, because when patient is brought in serious condition. So many a times there would be allegation, if you are not competent enough to deal with the patient, why you wasted time in treating the patient, why you didn't refer patient in time. So whenever you are dealing with this situation, always proper counseling, very quick counseling. You manage patient, call one relative inside, and you explain everything during giving treatment, that this is the condition, I am giving only primary treatment. If she is stabilized, then we will have to shift this patient to higher center for further care. So if you have counsel like this, there won't be any consequences as far as medical legal part is concerned, if at all you are facing. So refer to in time to higher center is one of the answer in this type of situation. Any special precautions at the time of transferring the patient? Anybody can take.
Yes, sir, there are very good golden rules for transferring a patient, whether it is intra-hospital or it is inter-hospital. Even if we are shifting a ICU patient for a CT scan in the hospital itself, there are very clear-cut guidelines that these particular things need to be checked before sending the patient, and the communication has to be there between the two departments. Now, if we talk in this case, there is a shifting of the patient from one hospital to another. So communication, and there should not be a breach of continuity of care at any time. The person who is shifting the patient from one area is giving the primary management and the initial management, and the next team should be ready with whatever possible. Like in this case, if there was a uterine artery tear, she was needing a blood bank alert, she was needing a massive transfusion protocol activation in the next hospital. She might be needing a urologist or a neurosurgeon for that matter, that there might be an injury to the ureter itself. So there, the surgeon, the OT, the anesthesia person, and the ambulance should have at least one responsible person.
Yes,
from
Venus, that we will come again. Who will decide where patient is to be referred? Either in government hospital or in any nearby corporate hospital in the same town nearby. Who will decide?
Sir, I think this is the doctor at that time who decide first, and then the choices are given to the patient. Like suppose we are tried with 2 to 3 hospitals, and or we have a continuity of care with those 2-3 hospitals, one some medical college, one civil hospital, one corporate hospital. All the possible option is given to the patient telling.
All the options should be given to the patient and relatives. Yes. They should take decision. It is very much escort of patient. Is doctor is under obligation to escort patient during the transport? With all emergency drugs, IV line, oxygen, to manage the situation on the way?
Yes.
Right. Yes. And transfer document. When you transfer any patient, you will have to submit all the necessary documents to the relative, whichever treatment you have given, in which condition patient was brought to you, and what was the condition at the time of admission to your hospital and at the time of referring the patient. So there are very good document as far as transfer document is concerned. Name of patient, date and time of referral, reason for referral, details of condition of patient, vitals when first seen, vitals when referred, history of comorbidity, operation details. If you have operated patient and patient is deteriorated, then you have to mention that. Copies of indoor papers and investigations done, antenatal record and partograph in obstetric patient, and all the records of investigation. Transferred in ambulance, yes or no? Arranged by who has arranged the ambulance? Accompanying by who is accompanying the patient? Doctor himself, herself, or any other doctors or your qualified staff, with all the equipment, oxygen cylinder, monitor, pulse oximeter, syringe pump, bag mask, portable ventilator, etc., and contents of emergency drugs in the emergency tray, and monitor details during the transit also, pulse, blood pressure, saturation, respiration, details of any event during transit, and name and contact number of doctor, staff of tertiary care. So where you are referring the patient, you have to inquire about, say, for example, ventilator, for OT, or any other you are requiring, because when patient reaches there and facility is not available and patient has to go to another hospital, then it will be very difficult situation. So before taking decision or before shifting patient to particular place, you have to inquire about the required things and date and time of handing over the in charge doctor to the tertiary care center when you have referred the patient. So this is the checklist or all the documents you have to give to the patient and relative. Patient's relative informed consent, transfer documents, all case papers and reports, date and time of decision to transfer, date and time of ambulance arrival, date and time of exit from your setup, name and qualification of person accompanying the patient, date and time of handing over to the tertiary care center. So this should be ready in your hospital. One copy should be ready and you have to just fill in the blanks because you have no time many times in this type of situation. So, and preserve all the documents. Whenever you transfer patient, you have to preserve all the documents. One more thing, in this particular case which we are discussing, there was comment in PM note, abdominal hemorrhage following negligent surgical procedure. Can person doing post-mortem examination comment like this? Negligent surgical procedure? Because in this case, there was bilateral uterine artery tear. She sutured both the artery very well. And in PM finding, there was internal hemorrhage. But can it be attributed to negligent surgical procedure? Comment from panelists. And
no, not at all. Not at all. On doing the post-mortem, you cannot comment on the surgical procedure. And there is no way. We have done the post-mortem so many times. But you cannot judge the surgical procedure. And you should not and not comment at all on the surgical. You can only comment on that there was an internal hemorrhage. Not on the technical procedure because that is not post-mortem person's domain.
Yes, I agree. I mean, it's not in the domain of the person to give the reasoning. The finding should be given exactly. If there is a hemorrhage, they should be mentioned.
Cause of death and
at the maximum, he can say that uterine arteries, both the uterine artery was torn and they were sutured. That's all. This much they can give it.
Common consensus, we can challenge this type of post-mortem examination report. So it is very obvious. No blood kept ready. So naturally, when we are dealing with this type of situation, RH negative or so, at least we should send blood for cross-matching. And if
sir, can I make a comment here, sir?
Yes, madam. Yes.
Sir, what could have been done in our case when the cesarean section was advised 4 days back? I think the blood should have been arranged then and there only.
Yes.
The blood for cross-match.
So,
sir, she came in emergency to us after 4 days.
So at that time, if she would have advised to the relative, you please go to nearby blood bank and get cross-match.
Yes, the grouping and cross-matching should have been done.
Donor should have been ready. Donor should have been ready.
Donor?
Good defense. Yes.
Good defense.
Very good point, Vinay. So reason for not cross-matching blood during high-risk delivery, and 80% of medico-legal cases against gynecologists are obstetric related. 80% of these cases are related to lower segment cesarean section complications, and 80% of complications are related to hemorrhage. So if one wants to be 80% free of litigation, take care of bleeding and cross-matching blood in given situation. So carry on message, cross-matching, especially in case of RH negative, and consent.
I think here I want to, can I add?
Yes.
I think every obstetrician practicing, taking the deliveries in a private should always have a contact with the blood bank.
Yes. So in my hospital, it is routine. I always inquire with the blood. I am taking this patient, she O negative, positive. If at all required, it will be available from your blood bank, and I send sample of patient, and I keep blood ready there in blood bank. If at all it is required, then only I demand. So this is my practice. So it can be if it is visible to everybody.
Sir,
But
can
one
I
more
add
thing.
one thing? Sir, can I add one thing?
Yes, yes.
That initially all obstetricians come with a lot of self-confidence कि हम अच्छा करते हैं, हमारी कोई bleeding नहीं होती. That mindset has to change to careful practice.
Exactly.
What you are saying is exactly what I do. We are in private setup. हम कब बोलने से नहीं चलेगा. On our document we should write.
We have to
Arrange one
document
unit
it.
and cross match and keep.
Yes, yes.
And even write that in case it is not needed, it will not be transfused. ताकि दोनों तरफ से आपको पिटे ना.
Sir, I am in government setup.
Yes.
I am in a government setup, you know.
Yes, yes, Vinny.
Yeah. RH negative, I start speaking at the start of the 9th month that you have to keep your blood ready. You have to keep your donors ready. So at 34, 35 weeks, I start writing on my prescription. Arrange 1 unit blood, RH negative, high risk pregnancy. We start writing so that we are safe. That timely, at least 4 or 5 weeks were given to her to arrange a donor because she's an RH negative.
So
She just cannot just land up in emergency and.
So one more question: does consent require for blood transfusion?
Yes. Yes, sir.
Always yes, because in this
separate consent, sir.
Yes, in this particular case, inference held by court, doctor is required to get 2 separate consent from the patient, one for surgery, if at all you are going for surgery or procedure, and another for blood transfusion if anticipated. Surgery involves risk and blood transfusion involves additional risk. So these were the inference held by court. So separate consent for blood transfusion is required. Medical record not to be believed was one more inference in that particular case. So we should be very careful as far as record is concerned. Whichever efforts we put to save life of patient, we have to mention everything in our record. And we have involved more than one person in the treatment. Then we have to see that a note of all the doctors or all the attendants should not be contradictory, which happened in this particular case. So in this particular case, this was happened. So we see the increasing litigations, increasing mob violence, increasing assault on doctor and hospital staff. Because previously, this is the picture of Lord Dhanvantri and considered to be first physician on earth. And we were considered next to God as far as our noble profession was concerned. But now scenario is changed. In a lighter way, now it is told that Vaidya Raja Namostubhyam, Yam Raja Sahodara, Yam Harati Pranani, Tom Pranani Cha Dhanani Cha. So attitude of society is changing towards our medical fraternity. And now scenario is like this. Operation Safal Raha, ab doctor ko koi khatra. Previously we were telling patient ko koi khatra nahi. And this is real reality. So no kickbacks, no commission, no illegal way of earning was practiced for 22 years. Now hospital business has become totally commercial. Dr. M. Santakumar has practiced medical ethics for 22 years and now he is closing hospital. And heartfelt thanks for cooperation extended by all doctors, staff, publics and patients. So this has become reality in our practice. So why this is why society is becoming intolerance? Just see, previously it was like this. A doctor was telling patient, don't worry, nothing will happen to you when patient was admitted for any surgery or so. Now scenario is changed. Now patient is telling to doctor, don't worry, nothing will happen to you. So this is changing scenario. So changing social attitude towards our medical fraternity. And this is attitude of society nowadays. All are immortal until doctor kills them. So this is the attitude. और सबसे अचरज की बात यही है कि जब दारू पीकर लीवर सड़कर आदमी मर जाता है तो उसके रिश्तेदार दारू की दुकान तोड़ने के बजाय अस्पताल तोड़ते हैं. This is reality in our practice.
Yes, sir.
High expectation on part of patient, relative and society from medical fraternity. Once we have bring patient to the hospital, each and every responsibility on the shoulder of a doctor and he has to give best available result. And expectation is like this also. एक अच्छा डॉक्टर केवल वह है जो परिवार त्याग कर कंदमूल फल पर जीवन व्यापन करे, मुफ्त इलाज करे और भिक्षाटन करके दवाइयां एकत्रित करे, बाकी सब डकैत माने जाएंगे. So changing attitude of society, and why this is happening, who is responsible for that? So let us discuss changing attitude of society towards medical fraternity, intolerance of society. But why this has happened? Who is responsible for that? Any panelist can take, including Mitra.
I think, sir, basically
medical fraternity, patient, society, government. Who is responsible?
Sir, it is the system.
Everyone has some role.
We are all the part of the system.
Can I say something?
Yes.
In my opinion, it is only because there is break of trust.
Yes.
मरीज अब डॉक्टर को ट्रस्ट नहीं करता, अब उसके पीछे चाहे जो भी रीजन हो, that is the reason why the relationship has totally gone haywire. In one word,
they are the most. For the mistrust, there is a reason for the mistrust, and for mistrust, everybody is contributing to it, right from the government to the layman and the media and everybody.
Yes,
I will say that.
Kiran wanted to something.
Sir, that's what my opinion is. I think everyone, every factor which you have written, everyone has some concern. Even we doctors also have some role into it. Abhi aapne kaha tha, no, what was that? No cutback or something like that. Even sometimes young doctors or otherwise also in the race of reaching high very quickly are taking up, sorry to say at this platform, but it is our platform and we have to judge ourselves also, only then we can correct it. So that also plays some role.
So I think this is joint responsibility of everyone.
Joint responsibility.
Doctor, medical fraternity, patient, society, government, and judiciary.
Yes.
Yes. Because just say for example, Consumer Protection Act in 1986,
that is the biggest factor
under this, and after this CPA, doctor has become much conscious. So many a times we go as far as safe practice is concerned. So we subject patient for certain investigation, and ultimately treatment becomes expensive, costly one. And many a times there is exorbitant expense and against unexpected result. So it becomes a reason for litigation. So this is also one of the
media is also responsible. Sir, media is also has some role.
We are coming to that.
Okay.
So, with this,
Sir, I want to. Can I make a comment?
VP Santa, this judgment brought doctors who charge fees for their services under purview of Consumer Protection Act 1986. And with this particular judgment widely perceived as favoring the patient. So after this CPA, the whole scenario is changed. Yes. Anybody wanted to add something? Yes, Kiran or
someone else.
Yes,
Sir, I wanted to add two things. That most of the litigations against the obstetrician and gynecologist in today's era is because of the cesarean. The most important thing is that what is the indication of the cesarean. So if we are very clear about the indication of cesarean, many things are going to be quite in control. And the second most important thing that I feel is that your colleague fellows lose comments. This is, and the postgraduates not trained for how to receive a patient referred from a primary or a secondary center to a tertiary center. That is the most important. That loose comment is the most important thing that damages everything between the trust of that patient on the primary center and then the tertiary center or whatever, and the whole system of ours.
So again, a proper communication with patient is very much important. So now coming to the point which was taken by Dr. Kiran, how much media responsible for deteriorating doctor-patient relationship?
Quite a lot. But I feel it, they always, yellow journalism they practice. They don't, I mean, like if we do something very good, some rare cases and save the patient, they will just write a small note of it, even if you are telling them. Never, highlighted the right way.
So in any hospital, when something goes wrong, it becomes a headline in newspaper.
Headline.
They never try to contact doctor other part of the story, and straight away they will go with this, because role of media is like this. ये दिखता है, ये बंदा झूले पर अच्छी तरह से he enjoying, but how this is represented by media, the same picture but represented by media, as such he has hanged on the rope.
Very true picture.
So this is the reality.
Oh,
what a many times this also happens. पैसों के लालच में सिजेरियन कर रहे निजी अस्पताल
जी,
कि कोई एक वर्ग ऐसा हो सकता है, few percentage, but it doesn't mean the whole fraternity, because with this type of comments, usual attitude of the society towards medical fraternity becomes very difficult one. Yes, Venus?
Sir, with due permission of yours and Dr. Alpesh sir and Mitra ma'am, I would like to appeal that throughout India, we should have higher charges of normal delivery as compared to cesarean.
So there was experiment done in one of the big city, that charge of cesarean section.
Chandigarh has same rates, sir. Same rates.
For vacuum or for
cesarean or normal delivery.
So nobody can put allegation that merely for charging cesarean section was done. One more thing.
Ma'am, sir, Patel sir, I'll just interrupt for 1 minute. And this is something, if you remember, past Vice President of FOGSI and past President of POGS, Dr. Shirish Patwardhan had started this small movement in Pune, where what they used to do was they used to take the full bill, total bill of delivery at the time of ANC registration. And it was same for cesarean and vaginal delivery. Then the bias of getting more money was removed, because at the time of registration, you pay the entire amount.
Can I interrupt, Manish? Can I interrupt a minute?
Yes, sir, sure.
I will give a different dimension. MC, I will give a different dimension. Now, suppose you are, for an example, you are charging 50,000 per normal delivery as well as 50,000 per cesarean section, right? Now, if you have taken the advance and it's sort of contract labor, you are saying. Now, the society will talk in both ways. If you do a normal delivery and something goes wrong, they will say that you did attempt the normal delivery to save your money.
Okay.
And if you do cesarean section well, it's anyway you are going to do it.
I agree. So, the only information which I wanted to give was this was one of the things which was started here, not that it gained any popularity, but it was started here, and lot of practitioners. We were PG students at that time, so lot of
practitioners. But I told you the other edge, other side of the coin. I told you.
Yeah.
Yes.
Okay.
So, is there any role of politician?
Oh, full.
Full role of politicians.
So, Girish,
all the negative influences of
yes, I have a very straight opinion about
I think media and politicians go side by side.
Yeah,
correct.
Both of them. Yes.
And this poor image of medical profession now.
Yes.
Sir, आप सारे yes के question पूछ रहे हो.
Rising healthcare cost. Is it one of the causes for rising the litigation rate?
Yes, sir.
Yes.
We are living in a. So the point you said that we are living in a evidence-based medicine. So for that, if, the investigations have to be comprehensive, they have to be complete. So definitely that will increase the cost. Just like you said right now. Initially it was like उसने तो मेरी pulse देख के बता दिया कि ये हुआ है. It is not like this.
Yes,
Yes.
Sir, Indian families want.
I think in the rising healthcare cost, patient also is contributing a lot, because their expectations, they are too high. They want 5-star facility. Then they come to the hospital, and when they go to the government hospital, they want 5-star there with less of the money. There
no
they
money at all.
No money.
जब कॉर्पोरेट पे आती है, उनको सब फैसिलिटी मिलती है, तब यहाँ आके शोर मचाती है कि यहाँ पे पैसे बहुत ज्यादा लग रहे हैं. So they want both the
Indian people will be happy. Indian people will be happy to have normal vaginal delivery of male baby at no money.
Yes, you're very right, Dr. Mitra. 100% right.
Yes. And on their Mahurat. On their Mahurat.
On their Mahurat, correct.
So this is poor budgetary allocation to health on part
Yes,
of
that is the government contribution.
Sir, resources are very
because even in government hospital, because it is not like that. There are problems with private hospitals also. There are some problems with government hospital also. Litigations against government doctors. So poor budgetary allocation. So, and there are a lot of patients. So burden of work in government hospital and lack of staff, lack of doctors. So these could be the some of the reasons. Yes, Venus wants to tell something. She's working.
Sir, this COVID time has actually opened the eyes of many people that it is not the government medical system that is supporting people in the time of pandemic. If I talk about Punjab, whole of the Punjab in the COVID times is supported by 100-bedded, 50-bedded, 200-bedded hospital, private hospitals. There was almost, I will say, either there were no ventilators in the government setup, or if there were ventilators, no one was knowing how to operate them. They were shifted to the hospitals where the people were knowing how to operate them. So definitely poor health budget is a big question, and this COVID pandemic has made the thing so clear to everyone around.
Yes, Vinit.
Sir, I would like to make one comment here that in JSSK, we are not charging even a single penny. And Dr. Pramila Jindal, as she said, they want all the facilities in the government setup without paying a single penny. And the thing is, अगर किसी भी सर्विस को आप फ्री देते हो ना सर, उसकी वर्थ खत्म हो जाती है. तो so worth has gone. The worth that we are giving to the time, the resources, everything that we are giving to our patient just becomes worthless by giving it free. This is my viewpoint. At least something should be, some negligible amount, at least on third baby, fourth baby. किसी भी point पे आके सर कुछ तो charge करेंगे ना. He's delivering sixth baby and free of cost. And the litigations you are saying are on the rise on the government setup too. Too many departmental inquiries, too many audits.
In your hospital, if you are charging nothing to any patient,
nothing, and they want every facility,
then they are not your consumer, so they cannot sue against any of your service provider staff or doctors in Consumer Protection Act under Consumer Forum. Of course, they can go for criminal case. They can go for.
They go to the High Court, or departmental inquiries are there, or the state inquiries are there.
But they cannot go for sue for compensation in Consumer Forum.
That is very true, sir. Yes. That is very true.
So
but sir, charges hone chahiye. Please, it is a humble submission.
One more area for litigation: behavior of doctor and hospital staff to the patient and relative. This is common allegation in so many of the cases that it was very rough behavior on part of doctor and hospital staff. We were not taken utmost care, etc. So.
Respectful maternity care around.
This thing comes only as an allegation when the bill is produced to them.
Yes.
Then they find fault with everything.
Yes.
वहां पे सिस्टर ने मेरे को ये नहीं दिया, क्लास 4 ने मेरी पट्टी नहीं उठाई, डॉक्टर ने ऐसा बोल दिया, जूनियर ने ऐसा बोल दिया. In case, I mean, that is within their pocket, then these behaviors, they are all tolerable.
Dr. Girish?
Yes. I would like to interfere here. And actually, I was to comment at the end of the session when.
No, of course, there will be your expert comment, but in between you can.
yeah, in between, behavior of doctor and staff, of course, does matter. And one point I want to add, all panelists may think over it. Poor budgetary allocation to health. It's not only the government allocation that matters. If you go to an average family, their own allocation to the health is very poor. So it has to be balanced on both sides. You have to make provision for your own health. So you must concentrate on this aspect also, not only government, but every individual family's budgetary allocation for health is very poor.
Good. Very good.
Very valid point.
Sir, I want to make one comment. Sir,
In
one comment.
litigation, rough behavior on part of doctor and hospital staff is responsible. It is statistic given by one of our learned medical legal expert from Ahmedabad, Dr. Mahendra Joshi. He happened to be member of State Commission also. And this was the statistic from 1991 to 2003. He had studied 1,000 judgments, and he had a study in this judgment, and these were his inference. So situation is like this: patient, doctor, but patient never know that he is not at all safe when he is doing like this towards doctor. And one more important question: can doctor be prosecuted for negligence under section 304 or 304A? Manish also can join, huh? And Girish also. Yes, everybody.
No. So normally no, unless and until it is a gross.
I was booked under 304A.
So basically, criminal negligence should be.
And you are bailable.
You are the intention when they say that you are guilty of wrong intention.
Let me say something prior. So as far as this 304 or 304 is concerned, this is criminal liability in our practice. So all this story goes with three words: intention, knowledge, and care. Intention. When anybody inflicts any injury with intention to cause death, then it becomes a case of murder, that is 299, 302, etc. When anybody has knowledge, say for example, when anybody inflicts any injury to anybody with knowledge that it is sufficient to cause of death in ordinary course of nature, then